Dr. Ishaq is a renowned interventional cardiologist. The third of our panelists will be Professor Ishtiyaq Rasool. Now, the first session will be on the localization, risk stratification, and the management of pre-excited accessory pathway. And I'd request Dr. Fariha Sadiq Ali for her presentation. Dr. Fariha is the Director of Electrophysiology program in the Heart Institute. And I just request, Madam.
Okay, thank you very much, Taha. So audience, in next 30 minutes, it's gonna be intense. I'm gonna talk about accessory pathway under the headings, the types, pre-excitation syndrome, the properties of accessory pathway, localization, risk stratification of asymptomatic WPW, and case-based management of AVRT. So I'm gonna share a couple of cases with you before I start. So the first case is a 38-year-old gentleman, asymptomatic, and he had an abnormal ECG. So he was referred to the arrhythmia clinic. And this is his ECG. Don't worry, we're gonna come back to these cases a little later. So, and then the second case is of a 60-year-old lady who had recurrent palpitations and presyncope, and she would present to the ER with those symptoms. And she would have tachycardia on the ECG. And the third case that I have is a 42-year-old lady who had Epstein's anomaly. She had recurrent palpitations, documented heart rate of 200, but no ECG was available during the tachycardia. In clinic, her ECG was this. So so when we talk about accessory pathways, I'm going to mainly focus on the common AV accessory pathways that we see commonly. I'm not going to focus on other less common accessory pathways like atriovesicular, which is called as MOHIM, and nodoventricular, vesiculoventricular, and atriohis pathways. So we all know that AV pathways are the remnant of from the embryological development of the AV annulus. And these are actually muscle strands, and they connect atrium and the ventricle bypassing the His Purkinje system. So when do we call accessory pathways concealed? When the accessory pathway is not seen on the ECG, there's normal intervals and you don't see any ventricular pre-excitation. And it is called as manifest, as its name says, that it shows its on the ECG and you have a ventricular pre-excitation. We commonly call accessory pathways as WPW, and what is a pattern when we only see the ECG manifestations of accessory pathway. That is, there's short PR interval, there's delta wave, but patient is completely asymptomatic. And obviously, syndrome will be when all these ECG changes are present in a person who has symptoms and have documented arrhythmia. So just quick review of the electrophysiological properties of the AV pathway. So it manifests as short PR. Why? Because the conduction is super fast, even faster than the AV node. And that is why there is short PR. It also manifests itself as a delta wave. And what is a delta wave? It is the slow muscle-to-muscle conduction into the heart, and which causes a slowed upstroke of the QRS. The short PR, slowed upstroke of the QRS is the ECG manifestation of the accessory pathway. When we see a ECG, sometimes we say usko subtle pre-excitation thi. So what does subtle pre-excitation means? It's actually a fusion complex. So a small part of the QRS, the initial small part, is caused by the ventricular depolarization from the accessory pathway, and the rest of the depolarization happens through the AV nodes. So there is just a very subtle pre-excitation called as fusion complex. But when the Pre-excitation is manifest, it's a broad complex, and most of the ventricular depolarization happens from the accessory pathway. You call this as completely, fully pre-excited ECG. In addition to fusion and fully pre-excited, we also use words intermittent pre-excitation. And what does that mean? It means that we see pre-excitation in one QRS and we don't see in the other. In one ECG it is there and one is not. Previously, it was said if intermittent pre-excitation is a marker of low risk. Unfortunately, that concept is kind of challenged. And now with the recent studies, we know that even patients who had intermittent pre-excitation have shown to have high risk features of accessory pathway on EP study. So unfortunately, intermittent pre-excitation is not a reliable low risk feature of accessory pathway. So this is how you would see intermittent pre-excitation happening. Now, when we look at the ECG, the first thing that we want to know is where is this pathway located? And it's just not matter of looking good कि मुझे पता है कि pre-excitation कहाँ से आ रही है. It has its own reasons, right? We need to know where the pathways are, and when we know where they are, we in managing the patients or planning a procedure, the risk and the success is related to the location of the accessory pathway. So the commonly pathways are common on the left side, left lateral, then followed by the posterior aspect of the septum or the left side. And then even less common are the right-sided free wall pathways. Very uncommon are the septal pathways, which are mid-septal or interoseptal pathways. So this is the face of the two clocks in the LAO view, and you can see it's the same thing that has been marked. So mitral valve annulus, lateral, posterolateral, tricuspid valve annulus, anterior, anterolateral, posterior, and the septum. Now, when you look into the literature, you see a lot of algorithms out there, Aruda, St. George's, and many. And I get overwhelmed when I look at these algorithms, and I get confused, and I can never come to conclusion. So what I do is I actually have a practical approach to it, which I use. And so what I do is first of all, I look at the QRS morphology in lead V1, right? And we're not looking at the delta, we're just looking at the QRS. So if there is a R wave in V1, which is a right bundle morphology, it's a left-sided pathway, period. On the left side, we only have two types of pathways, left lateral and left posterior pathways. So for left lateral, the inferior leads QRS would be positive. And for the left posterior, the inferior leads would be negative, right? So left posterior and left lateral. Now, if in V1, again, if there is a Q wave in V1, which is kind of a left bundle type morphology, it's usually a right-sided pathway. And in right-sided, we can have a right free wall and right-sided or septal pathway. So we actually look at the transition of the QRS in the precordial leads in somebody who has a left bundle morphology. And if the transition is late in V4, it's actually a complete right-sided, and it can be anterior, anterolateral, or posterior based on the inferior leads positivity or negativity. So late transition, positive inferior leads, it's right anterior, anterolateral. If it's late transition, negative P waves, negative QRS and inferior leads, it's a right posterior. Then if somebody has an early transition, meaning the QRS in V2 is very tall, immediate transition, then it's the septal pathway. And again, the same leads, inferior leads, if it's positive, is enteroseptal or mid-septal, or if it's negative, it's posteroseptal. I'm going to show you some images to just confirm this. So the first thing, QRS morphology in V1. If you look at this patient has a right bundle morphology. It's a left-sided pathway. Lead 2-3 AVF is positive. It's a left lateral pathway. Again, right bundle morphology, left-sided pathway, 2-3 AVF negative. It's a left posterior pathway. And we don't have to minutely localize the pathways on the ECG. That's what we do when we are doing the mapping in during the ablation. So again, left bundle morphology, late transition means the R wave transition is in V4, and you have a positive 2-3 AVF, means this is a right-sided anterior anterolateral pathway. And if with late transition, so QRS is positive late in V4, and with negative inferior leads, it's a right posterior pathway. For septal, early transition means V1 is negative, but lead 2 is very positive. So this is a septal pathway. Lead 2-3 AVF negative is the posteroseptal pathway, and if lead 2-3 AVF is positive, it's more close to the enteroseptal or midseptal location. So this is important because the risk and success of the procedure is related to the site of the pathway. Now we all fear the sudden cardiac death in WPW, but fortunately it is not a very common presentation, and it is very rare to find somebody as first presentation of WPW with cardiac arrest. But we need to know what are the high-risk features that will cause sudden cardiac death. Older age actually falls into a high risk. And why? Because with age, AV node will get old, the conduction will slow, and the accessory pathway never gets old. The conduction stays fast. And also the other features are pre-excited AF with a very short RR interval, and the RR interval is less than 250 milliseconds or more than 240 beats per minute. Somebody is having symptomatic tachycardia, multiple accessory pathways. Epstein's anomaly is a feature of high-risk sudden cardiac death, and somebody has familial WPW syndrome. So these are the features of sudden cardiac death in WPW. Fortunately, we don't have to see them very often. Now, how do you risk stratify a patient in asymptomatic WPW? Well, we need to understand that no pathway is low risk. All pathways can have high risk features despite whatever we do to risk stratify them. So the recent guidelines suggest that high-risk occupation patients with asymptomatic WPW pattern on the ECG should be risk stratified using an electrophysiological study, which is a class 1 indication. And what we do is we try to risk stratify based on the induction of AF, shortest RR interval, accessory pathway, if we have multiple accessory pathways, or somebody get inducible tachycardia. So these are the high-risk features of accessory pathway. But if somebody doesn't have high-risk occupation, just a common man, then even then EP study is a class 2 indication, and we would be able to risk stratify them. Unfortunately, non-invasive study like exercise test does not give us those answers. We may not actually see sudden change in the QRS morphology from narrow to broad or broad to narrow to actually define the effective refractory period of the pathway. So how does WPW present? Obviously, it presents with tachycardia, which can be orthodromic AVRT. It's a narrow complex, regular tachycardia, can be broad complex with a bundle branch block. Pathognomic of AVRT is electrical alternance, and this is a short RP tachycardia. So this is how the narrow complex short RP tachycardia, it's the regular SVT. Then it may also present with antidromic AVRT, which is a very rare presentation of WPW. It's a wide complex regular tachycardia, negative inferior leads. It can be irregular if it is pre-excited. So this is how a wide complex regular AVRT will present antidromic. Unfortunately, there are no algorithms to clearly differentiate this type of tachycardia from VT, right? So no matter how experienced you are, you may not be 100% sure, but there are certain features. You can see a little pre-excitation in the leads that will suggest that this is a antidromic AVRT. So Now, moving on to our cases, and we're going to see the management and how should we go about it. So the first case is a 38-year-old gentleman with abnormal ECG. He had no symptoms, and this was his ECG. So the first question that I'm going to ask myself and to you all is, where is the pathway located, right? The easy thing that I follow, I have a left bundle morphology or Q wave in V1. There's an early transition in V2. So this is a septal pathway. My lead 3 AVF is negative. So it's going to be a posteroseptal pathway location, right? One point is that if somebody has a lead 2, which is isoelectric, you may find this pathway in the middle cardiac vein. So we'll be surprised. And this is how the posteroseptal pathway in the coronary sinus os are kind of into the coronary sinus body. So what is the next step in the management? Young guy, asymptomatic, no high risk occupation. Well, we can reasonably offer him an EP study to risk stratify based on the current guidelines. Now, this patient underwent EP study. We did some provocation, and we did EP study without a provocation as well. Fortunately, we were able to induce a narrow complex regular tachycardia, which was an orthodromic AVRT. In addition to that, this patient also had his catheter-induced atrial fibrillation, but you can see that atrial fibrillation has pre-excitation intermittently, and the shortest RR interval was 220 milliseconds. So another high-risk feature of accessory pathway in this gentleman. Now, what is the next step in the management? Obviously, this guy is asymptomatic, but he has high-risk features on EP study. So we're going to do ablation as a class 1 indication based on the high-risk features that he had during the EP study. So this patient underwent an EP study and ablation of a posteroseptal pathway located in the middle cardiac vein. This is an AP view. This is the coronary sinus catheter. This is the RV catheter atrial, and this is the ablation catheter kind of inside the coronary sinus middle cardiac vein. Sorry. And this, I'm not sure if you can see it clearly, but this is actually shows you the middle cardiac vein origin from the coronary sinus. So successful ablation and no pre-excitation on the ECG. Now, the second case is a 60-year-old lady, recurrent palpitations, and she had pre-syncope. And the ECG in the ER when she presented was this. So what is this? This is a narrow, complex, regular, short RP tachycardia. She's hemodynamically stable. How would we manage this patient? Like any other SVT that we see in the ER, we give, if they're stable hemodynamically, we would do vagal maneuvers, not responding, IV adenosine, and if not responding, verapamil, diltiazem, or beta blockers. And obviously, if they're unstable, we cardioverse them. So she received IV adenosine, carotid massage didn't work. And this was her ECG after converting to sinus rhythm. Now, the question that we ask, where is the pathway location, right? The same principle, right bundle morphology or R wave in V1. So this is a left-sided pathway. We have inferior leads negative. So this is a left posterior pathway. So what is the next step in the management? Somebody who has WPW, recurrent and symptomatic, we offer them catheter ablation. The catheter ablation was performed of the left posterior pathway, understanding that we knew beforehand that this is a left-sided pathway. We were prepared to go onto the left side using transeptal approach. Various centers use retrograde approach. Some centers use transeptal approach to get into the left atrium. So we use the transeptal approach. Why does it not want to start? Sorry. Why doesn't want to start? Okay. So we doing a transeptal in the LAO view. We bringing the lead, the sheath with the needle down, and we saw a drop. Okay, and at the site of the fossa vallis, we advanced our needle, which is inside the sheath, and pop, it goes, and we see contrast into the left atrium. Okay. So we then went into the left atrium with our catheter and a sheath, and you can see that we've been mapping the mitral valve annulus. I'm just going to show you this laser pointer. So this is the coronary sinus catheter. It's sitting on the mitral valve annulus, and we are mapping it. And this is somewhere at the 6 o'clock on the mitral valve annulus in an LAO view of the clock. So this was truly a left posterior pathway. And you can see some of my colleagues would say the catheter looks that it's under a lot of tension. It's not an easy location to stabilize the catheter and ablate. So fortunately, we got the pathway, we ablated, and post-ablation, there was no tachycardia, and the ECG shows sinus rhythm with no pre-excitation. The third case is a 42-year-old lady. She had Epstein's anomaly. She had recurrent palpitations and ER visits with documented heart rate of 200. She was from Southern Punjab. We didn't have any ECG to review during tachycardia, but she said she had a heart rate of 200 beats per minute. This was her ECG. So understanding this is Epstein anomaly, the ECG in her may actually not give a complete location of the accessory pathway. But what we can see is there is a Q wave in V1. So probably is gonna be a right side. I'm not too keen to see V2 positive, but I see 2,3 AVF negative. So somewhere on the posterior aspect on the right side, either septum or the tricuspid valve annulus. So with that thing in mind, understanding that she has Epstein's anomaly, huge distorted anatomy, we went in, so we offered her catheter ablation, understanding WPW and Epstein's anomaly are high-risk features. Most common pathway in WPW is a free wall pathway on the posterolateral side. So because it was a complex anatomy, we used our 3D mapping system to to make the anatomy and map the tachycardia on it. And this may seem really strange or unusual to you, but this is a anatomy of the right atrium in LAO and RA view. The green dots here are the annulus. The right ventricle has been cut off, chopped. And the red points here mark the catheter position is where we actually got the pathway and tachycardia terminated. And you can see it on the intracardiac. So yes, this tachycardia was found to be originating at the posterior path side, tricuspid valve annulus, close to the 6 o'clock position. So this is the intracardiacs for our electrophysiology colleagues. We ablated the pathway. This is a narrow complex tachycardia. So it's been SVT, was not an antidromic, it was an orthodromic AVRT. We ablated in the pathway limb. So this is the X-ray image showing a huge heart, how the catheters are placed are kind of under a lot of stress, difficult CS location. And this position here is on the clock. It's a tricuspid valve annulus 6 o'clock position where we got the catheter, the pathway. Post-ablation, she had a right bundle, which was previously masked by the accessory pathway. So finally, what are the principles of management? We've gone through the cases. Asymptomatic pre-excitation, we need to re-stratify them via EP study. No features, no pathway is low risk unless proven otherwise. Even if it is a low risk pathway on EP study, it is recommended to do ablation of low risk pathways if it is a experienced center, high volume center with experienced operator. We have to be very careful because the site of the accessory pathway will dictate the complication. So we don't want to have somebody asymptomatic with a mid-septal pathway getting AV block because we just were too anxious to do this ablation. Now, symptomatic patient, obviously somebody's having SVT, AVRT in the ER, adenosine, wiggle maneuvers, beta blockers, calcium channel blockers. For the pathway termination, the guidelines suggest use of class 1 antiarrhythmics, flecainide, and 3 drugs, ibutylite, propafenone. Unfortunately, none of these drugs are available in Pakistan. So what do we do? If somebody has pre-excited tachycardia, cardioversion is the only option that is available to us, unfortunately. No amiodarone is mentioned, so please do not give amiodarone. If somebody has a pre-excited tachycardia or pre-excited AF, please do cardioversion because unfortunately we don't have these drugs available. Obviously, when somebody has repeated symptoms of AVRT and they have a manifest pathway, these are the patients who would not tolerate any AV nodal blocking agents. So catheter ablation is considered to be the first therapy if they have a pre-excited ECG and repeated palpitations. Symptomatic patients who do not have WPW on the ECG and they have repeated AVRT, and they don't want to go for catheter ablation, which is still the first line therapy, pharmacological management with beta blockers, calcium channel blockers, class 1C antiarrhythmics can be used. So symptomatic recurrent catheter ablation is the treatment of choice, low risk, high success rates. Thank you. I'm happy to take questions, comments. I'm happy to take any questions or any comments from the audience. Mike. Reasonable low risk.
That conventional wisdom for over now 1970s and when these guys first came out, over now almost 50 years has been that intermittent pre-excitation does not sort of gives you a get out of jail free card.
Yeah.
So asymptomatic intermittent pre-excitation. Now, a lot of the data that would suggest that it is that patients can still present with pre-excited AFib even if they do not even if they do not have consistent AFib. So I'm sort of confusing the issue. Let me rephrase it. That most of the data that suggests that patients can present with intermittent pre-excitation and have fast AFib with WPW. One, it is mostly related to children. And secondly, it would be more, it's not sudden death so much that they present with as it is ventricular pre-excitation. And though ventricular AFib with ventricular pre-excitation may lead to sudden death, but the presentation is very rarely seen to be actual death.
Yes,
So,
thank you very much, Dr. Azam. Yes, you're right. But you just said we have a lot of data from the older studies, the recent single randomized control trial, and a lot of data recently have shown that in patients who had intermittent pre-excitation when they had EP study, some of them had high risk features. So it may not be just, take a step back and say, "Ye to bilkul theek rahega." Yes, we are fortunate that most of the patients will not present with sudden cardiac death. We need to understand that older people, more than 65, are at risk of fast pre-excited AF. Why? Because the AV node is getting weaker. And now the accessory pathway may take over because they are older generation people. They may actually take a lot of beta blockers and all of that. So the pre-excitation may become more evident in later ages. So everything has to be with caution, right? Because we're talking about invasive procedure and the risk versus benefit has to be taken into consideration. But most of the notion is experienced centers, experienced operator, you can consider that.
I think all those are valid points. I think what we should be very careful about, and not just in EP, but I think whichever aspect of cardiology we are looking at, is that we do not equate VT past AFib with WPW or high risk features with death. Those are two separate endpoints. I think most of the studies, it'll be very difficult to show an increased, or it'll be very difficult to show that these patients will benefit from an invasive study, that it will reduce their risk of sudden death.
Yeah, because there was a recent RCT that actually had done ablation on asymptomatic patients, a control group, medical treatment observation, and the rest were given ablation. And you would be surprised to see that the arrhythmia reduction was, so arrhythmia occurrence was 77% in control group and only 7% in the asymptomatic ablated group. So yes, everything has to be with caution, whether we are doing intervention cardiology or electrophysiology. Patient input and their decision has to be respected. So, you know, thank you, Dr. Azam.
Assalamu alaikum. Dr. Ria, very nice presentation. I know you've gone within the presentation, you have put the message across, but just something for everyone. How do you feel about patients being prescribed AV nodal blockers just on the basis that they have an ECG which shows pre-excitations and they claim they have palpitations? I mean, because I'm sure everyone sees this in their practice. So how do you feel about them as a
Well, I
general
think
message?
the guidelines are very clear on it. If somebody has pre-excited ECG and they have AVRT or palpitations, while in the emergency room, you can use AV nodal blocking agent because they presented with a narrow complex tachycardia. But if they are at baseline, they have a pre-excited ECG, giving them AV nodal blocking agents is not a good idea, right? So this is very clear. Somebody has pre-excited ECG, whether they have a documented tachycardia palpitations or not, please do not give them AV nodal blocking agents. Catheter ablation is probably the best option. Yes, somebody does not have pre-excitation and they have AVRT. Yes, consider beta blockers and calcium channel blockers. Okay.
Excellent presentation, very lovely. But just 2 points. One is that the surface localization of accessory pathway, true and good to the students and for the academics. But many times, you know, pathway ends up somewhere else sometime. The second question is regarding the Epstein patient. You did it very well, actually, with the help of a mapping system. My question is, was that the only pathway in there, or did you manage to find
yeah, I
something
didn't
else?
show you the post-adenosine picture. That was the only pathway. Yes, we need to be absolutely sure when we're dealing with Epstein's, there may be multiple accessory pathways, but that was the only pathway. The other thing, localization. Yeah, no matter what algorithm we follow, no matter how good we are on the ECG, we may not be able to localize the pathway potential or location on the ECG, and careful mapping during the procedure, atrial pacing, sinus rhythm, during tachycardia is very important. So it's not just go and burn, it has to be meticulously mapped before ablation.
I've got a very simple question, being a non-AP physician. First of all, thank you very much for an excellent account. In clinical practice, we see a lot of ECGs consistent with some variety of pre-excitation. They're very not uncommon, you see, every now and then. And it becomes very difficult to identify which person will be heading for arrhythmias and when we should refer them to EP studies. Not everybody is willing to go through this, and that everybody needs to be studied. But is there some basic criteria for an average cardiologist or general cardiologist which should make him suspicious that this patient needs something more to be done? Because this is very not uncommon to see these pre-excitation, short PR intervals and delta waves and so on. They're very commonly seen. And people are totally asymptomatic.
Thank you
So-
very much, Professor Salk. Yes, it's a very valid question. A lot of cardiologists see pre-excited ECG, and the guidelines are not so very pretty clear on it. So we cannot look at the ECG and say isko arrhythmia nahi hoega, ya isko kabhi bhi palpitations nahi hongi. Sudden cardiac death risk is very, very low in overall. So we're not talking about sudden cardiac death. Anybody ECG has a pre-excitation, please do refer to our electrophysiologist. The way to go about is to risk stratify them based on the EP study. May not need catheter ablation if it's a low risk pathway, but EP study is a very low risk procedure, and you can at least safely identify high risk candidates who would have. So yes, any patient who has pre-excited ECG, even if they are asymptomatic, please refer to electrophysiologist because the guidelines do recommend risk stratification for them based on the EP study. Unfortunately, a lot of people would do ETT, but we don't get the actual or the exact answer whether this pathway is a high risk or low risk.
Thank you very much. Once again, very good session, and here-wise, I see that the number of EP people is increasing. I remember the first meeting, which was in 2018, and the number of people sitting today. My question is that you said that every patient with a WPW should be referred for the risk stratification. Then the question which comes into mind that if you do the risk stratification, what is the number of the patient in statistics you find that they need ablation?
Well, we don't have local data, unfortunately. So I may not give you the local data, but about, I would say, so patients who have WPW, 80% will have AVRT as a manifestation, whether they are having manifestation of AVRT on a spontaneous arrhythmia, or they are provoked or induced on EP study. So at least 80%.
So actually we do an EP study on all of them. So because all of them sort of come under the requirement. So I agree with you actually. So all of them, as you said, just WPW and ECG would probably about 70–80% end up having an AVRT, and we induce them. So I think I agree with you. There's no local data. That's what our experience is for the last 20–21 years.
Thank you.
Manifest pre-excitation, and you think that they don't have any symptom, but they have some non-specific symptom. They will come to you with a chest pain. Doctor साहब मुझे कभी-कभी छाती में दर्द होती है. They come like मुझे घबराहट होती है. But you don't have any documentation. But these people must have been having something. So you must refer those guys to electrophysiology.
And my last question is that we are the intervention people. We always, when talk about the intervention, तो हम बात करते हैं कि what's the symptomatic, whether you do it for the symptomatic benefit or you do it for the hard endpoints like mortality reduction. So if you do the number of the procedures, what is the cost? What is the risk reduction in death in terms of mortality? And whether it's just a symptomatic relief?
Well, yes, it is symptomatic, right? Because most of them will not have sudden cardiac death. The percentage of sudden cardiac death in WPW is very low, but 80% will have symptoms affecting the quality of life. If somebody has to visit ER 200 times in a year, spending the money, leaving their work, what do you say? Spending few $100,000 on it as a one-time, and honestly, it's a curable procedure. So cure, done.
But yeah, if for some reason the patient declines ablation,
Yeah.
What's the medical option long term?
Well, if the patient doesn't want to have it, doesn't want to have it. till they are actually tired and exhausted of repeatedly going to the emergency room, and they finally decide, "Acha, ab kar dein."
Nahin, Makar, is there any medical follow-up that you would
Yeah, so,
recommend?
well, there's no medical
Any
follow-up.
antiarrhythmic?
No. से asymptomatic antiarrhythmics तो नहीं देने बिल्कुल भी. Symptomatic हो रहा है, pre-excited है तो कुछ भी नहीं देना है. No pre-excitation, you can give them beta blockers to reduce the symptom frequency. Unfortunately, this is how it is. Okay, ji. Thank you so very much.
Thank you, Dr. Faria. So the next talk is on the commonest arrhythmia that we see and manage as a cardiologist and also as electrophysiology. So the next talk is on management of atrial fibrillation in heart failure patients. I'd like to request Dr. Ghazala Irfan, who is assistant professor in cardiac electrophysiology in NICVD, for this talk.
Assalamu alaikum. So, very important topic, I would say, and also lot of controversy between the treatment management options, a lot of new data coming in, which we ultimately have to incorporate in our management. So, atrial fibrillation and heart failure. What is the epidemiology of heart failure and atrial fibrillation, despite recognition as being as the major cause of morbidity, mortality, and healthcare costs? It continues to rise in prevalence because of aging population, obesity rate, increased detection of AFib thanks to the new technologies, and improved survival rates in heart failure with optimal medical therapy. We don't have our data, so still we are looking at the data from the West, and the projected data by 2030 is 12 million people in US with AFib and 8 million with heart failure. And development of AFib in heart failure patient is a negative prognostic factor. Why? Because it worsens the quality of life, increase mortality, and even it is regardless of the ejection fraction. That means it proved to be equally high mortality and worse quality of life in heart failure with preserved ejection fraction and heart failure with reduced ejection fraction. So what is happening? Whether it's a cause or it's a consequence. So if we see heart failure and AFib, sometimes it's very difficult to decide which comes first, whether heart failure comes first or whether the AFib comes first. A lot of time patient came to us with the atrial fibrillation, and then when we do the echo, we find that is a heart failure with reduced ejection fraction. Or sometime patient who are coming recurrently with palpitation and shortness of breath, and then you do an echo and you find the ejection fraction is 60%, patient is, and then this patient goes into the heart failure into the preserved ejection fraction category. So what is happening? Heart failure with cause fibrosis and AFib with also cause fibrosis. Then what is happening here? Increased filling pressure, dysregulation of intracellular calcium, and neurohumoral activation. AFib with cause increased LA size, and then electrophysiological remodeling. All the things happening will decreasing the cardiac output because of rapid ventricular rate, irregular heart rate, loss of atrial systole, and increased MR and TR. Same time, AFib actually alone can cause heart failure because of tachycardia-induced cardiomyopathy. So atrial fibrosis, what is happening with the atrial fibrosis? You lose reservoir, conduit, and booster function, loss of atrial contraction, wall stress and increase, inflammatory cytokines, circulating neurohormonal factors, interleukin-6, TNF, all are increased. And what electrical abnormalities are happening? There is increased atrial refractory periods, especially in lateral right atrium and distal CS, slowing of impulse conduction in the area of fibrosis, resulting in membrane potential, more depolarized, and the plateau phase of the amplitude is smaller in the atrial cells in the atrial fibrillation. All these things what happening with the mechanics, hemodynamic, you lose the atrial kick, reduction of the cardiac output as much as 25% with diastolic dysfunction. And what is tachycardia is causing altered calcium handling, increased sympathetic drive, worsened ventricular function, which can also lead to tachycardia mediated cardiomyopathy. So realistically, if we see, the answer is both, because what's happening, it creates a positive feedback loop. Appearance of both causes the progression of the both. So that means you have to treat atrial fibrillation whenever it appears in patient with a heart failure. Because if you improve the outcome of AFib, you are ultimately improving the heart failure outcome. This is in circulation published. If you see here, the patients which they have no heart failure and mortality rate after the AFib is decreased. And once the patient is developing AFib, the mortality increases in both heart failure and reduced ejection fraction group and heart failure with preserved ejection fraction group. How can we see there are currently different monitors, gadgets are coming in with which we can screen the patient. When the patient is coming in the emergency room or in the hospital, we can do 12-lead ECG, palpatory method. Then you have watches which can give you a ECG. Other than that, there are handheld devices like Cardia, which can give you a 12-lead ECG. And that can also give you a rhythm analysis if the patient is having palpitations and we are not being able to monitor whether it's AFib or not. So how you're going to treat? So number one is heart failure, reduced ejection fraction. You started with guideline directed medical therapy, beta blockers, ACE inhibitors, ARBs, ERNI, aldosterone blockers, SGLT2 inhibitors. But there is no specific medical therapy that targets both conditions. That means the patient who's coming with heart failure and also at AFib. So what do you think that if we are treating heart failure, are we treating the atrial fibrillation? So what does the data saying? So if we see the beta blockers, yes, we have very good trials of the beta blockers in patients who have heart failure with reduced ejection fraction. But if we see the same patients who have heart failure and atrial fibrillation, so the heart failure collaborative group that showed it as a meta-analysis, and they showed there is no improvement in all-cause mortality in patients who have atrial fibrillation and heart failure. Same goes for ACF heart failure sub-study. It shows a little bit of mortality benefit, but not reduction in hospitalization. So other studies also suggest AFib reduces the efficacy of evidence-based beta blockers. Only the registry, which is from the Sweden, it showed a little bit of benefit in patients who have using beta blockers in the heart failure. ACE inhibitors and ARB, they affect the incidence of atrial fibrillation. How they're decreasing mechanically, it makes sense because less neurohormonal activation, less fibrosis, and definitely, ultimately, you will get overall effects of the atrial remodeling in terms of electrical and structural. Primarily, the older trials of the atrial of heart failure with the ACE inhibitors and ARBs, some post hoc analysis shows a little bit of benefit in patients with atrial fibrillations, but some did not show any benefits because these trials were not planned, or these are not designed with the mind with atrial fibrillation and heart failure. If you see previous ARB, if we see mechanistically, what is the possibility? ARB are decreasing inflammation, collagen synthesis, and diastolic left ventricular pressure, systemic blood pressure, and ultimately, definitely all these things decreasing the left atrial pressure, structural remodeling, and decreasing the atrial fibrillation chances. Aldosterone blockade may reduce the onset of atrial fibrillation, especially in emphasis heart failure. They show the reduction in new onset AFib with eplenon. But heart failure benefits was maintained regardless of the baseline atrial fibrillation. And if we see the preserved ejection fraction trial data, guideline medical therapy has not proven effective in the affecting outcomes. Treatment is geared most towards the volume and blood pressure control. TopCat trial, no reduction in composite cardiovascular death, cardiac arrest or heart failure hospitalization. Only recently, I think Emperor Preserve trial has shown some benefit in heart failure and preserve ejection fraction in terms of decreased mortality. And they have in their data patients who have atrial fibrillation at the baseline also. But we don't have still have any sub-analysis, so we cannot say anything clearly whether they are going to help in these patients or not. So if we see how we are treating patients with atrial fibrillation who have heart failures, what are the drivers and what are treatment we are offering them and how they are untreated. If there is no treatment, untreated patient have tachycardia, loss of atrial contraction and ventricular irregularity. So these are the three main drivers in heart failure in atrial fibrillation. If we are only controlling the rate, we are still left with loss of atrial contraction function and ventricular irregularity. If we are doing AV node ablation, yes, we are improving tachycardia, yes, we are improving ventricular irregularity, but still you don't have atrial contractile function. That means you are decreasing 25% of diastolic dysfunction function. But if you're getting these patients in sinus rhythm, you're improving the tachycardia, you are improving the loss of atrial function, and you are improving the ventricular irregularity. So ultimately, if we are bringing the patient into the sinus rhythm, then we are going to get the full benefit of the treatment of atrial fibrillation. So let's see, because this is something now we have new data coming in with new trials in which all the patients with heart failure also have the guideline directed medication previously, which was not available. So previously we were mainly concerned with controlling the rate. So if we see even with the rate control, diamond congestive heart failure trial in which they have used dofetilide versus placebo, there was no effect on mortality. So all the trials, if you see with the rate control versus the rhythm control, in which mostly they are using amiodarone, and for rate control, they are using beta blockers, there is no effect on mortality. Only the CAFE2 trial, rhythm, sinus rhythm may improve quality of life and LV function. So this was also rate versus rhythm control. Then comes, this is something which we are missing in our daily practice. Patients who came with heart failure, atrial fibrillation, we try to control the rate. And until now, if we see all the data, we are not helping these patients. So we first, most importantly, must try to bring these patients back to sinus rhythm. We should give them a trial to be in the sinus rhythm and see how their functions improve, because it restores 85% of time sinus rhythm, although 30 to 40% of patients remain in sinus rhythm at the end of the 1 year, and it can improve left ventricular ejection fraction, exercise capacity, and heart failure symptoms. This is one thing which we can do in persistent atrial fibrillation patients. Now, today is the era of atrial fibrillation ablation. Why? Because with the medication we have seen with the antiarrhythmic medications, they have a lot of side effects, and long-term patient compliance is poor with the antiarrhythmic medication. They stop the medication, then they ultimately come back to us with the atrial fibrillation. It's a little bit busy trial because I don't want to concentrate too much. But if you see the major trials which were done, and recently if we see the East AFNet trial, and in that this is a trial in which they have actually proved that the early rhythm control or usual care initial rate control in case of system mitigation to rate control, they are composite of that in cardiovascular causes, stroke, hospitalization, heart failure, acute coronary syndrome. It was early rhythm control was superior to antiarrhythmic medications. Even with the previous trials where there is a lot of, they were not really randomized trial, they are little, the number of the patients were less, but still if you see the rhythm control was with the ablation was always superior with the rhythm control or the rate with the medication, or rhythm versus PVI versus the rate control. This is the overview of some ablation studies, and the highest number with the Cabana heart failure. It was really controversial trial initially because the composite of death, composite of that point. Now, if they have they have the ablation study, they did the PVI, that is the pulmonary vein isolation with linear lines in Qrs both, and 22% of the ischemic heart failure patient. Ejection fraction is 60 to 61% here, and persistent AFib is 55%. And in that, if you see the percentage of success of ablation strategy, that is also almost 40%. What are the ongoing trials? They are contra heart failure, RAF, and these all trials are catheter ablation versus rate control. And they are mainly now concentrating on the quality of life and also composite endpoint of the cardiovascular death. Any procedure, if you're doing, definitely you are going to think of the complications. There is no procedure which I'm going to say is without complication, but the rate of complication, this is from an RCT of the multiple trials. And if you see pericardial effusion and tamponade is almost 3.9%, hematoma, groin bleeding, needing transfusion 1.96%, atrioesophageal fistula 1.5%, post-procedure pneumonia 3%, and others will be the cardiogenic shock, pleural effusion. Some patients who already have some ICD implanted, damage of the ICD, or suspected pericarditis. So how we are going to do the catheter ablation strategies? What are the two strategies which are commonly used? Is the cryoballoon ablation of pulmonary vein, and then is the RF, that is a radio frequency ablation, or point by point ablation, in which you ablate the pulmonary vein isolation. You do pulmonary vein isolation. You do the whole map of the left atrium. You draw different lines, mitral line, roof line, cafe ablation, and cryoablation is a single shot pulmonary vein isolation. So what is the overview of long-term rhythm control in patient with heart failure? Step 1 is assess and treat risk factor and comorbidities. Step 2, initiate medical treatment based on current guideline. Reduce ejection fraction, ARNI, beta blocker, MRA, SGL2, and lifestyle. Preserve ejection fraction, ACE, ARB, MRA, statin patient with risk factors, left ventricular hypertrophy, or left ventricular dysfunction. So what is the step 3? Discuss options, medical therapy or catheter ablation. In reduced ejection fraction, catheter ablation should be considered to improve survival and reduce heart failure hospitalization. This is a class 2 indication. And in the medication, you have imidrone, dronidone, and sotalol. Reduced ejection fraction, only imidrone can be given. In dronidone can be given in preserved ejection fraction, sotalol also in preserved ejection fraction. And reassess if the reoccurrence of AFib. Catheter ablation is the first line treatment in heart failure ejection fraction, class 2A indication, and tachycardia-induced cardiomyopathy, class 1A indication. After failure of drug therapy, class 1A indication, and even if the patient decides that the patient doesn't want to try medication, some patients don't want to take long-term medication, you can directly go for the catheter ablation of atrial fibrillation, usually with a single shot cryoballoon ablation, which have a much better results. So how the guideline directed, we have started the guideline directed therapy, lifestyle risk modification, oral anticoagulation dependent on the CHADVES, pharmacological rate control, and cardioversion if required. Evaluate for rhythm control for cardiac ablation. Who are the patients who are likely to benefit from a catheter ablation? You cannot offer it to everyone. You cannot expect good results from every patient. So likely benefit, AF-mediated cardiomyopathy suspected, NYHA class 1 and 2 patient, no significant ventricular scar on late gadolinium enhancement MRI, none or mild atrial fibrosis, paroxysmal or early persistent, and younger patients or no significant comorbidities. These are the patients who will benefit most from the catheter ablation of atrial fibrillation. And if the ablation is successful, you monitor for AF recurrence and burden. If it's a failed ablation, repeat ablation, multiple procedures, sometimes patient needs multiple procedures along with antiarrhythmic medication. Less likely the patients who will not benefit that much, NYHA class 3 or 4 heart failure, significant ventricular scar on MRI, advanced heart failure, severe LV dysfunction, severe atrial myopathy, that means atrial dilatation and fibrosis, long-standing persistent AFib, poor prior failed ablation, or advanced age or significant comorbidities. These patients, usually you go for the rhythm pharmacological control, antiarrhythmic therapy, imidrone or dofetilide plus minus cardioversion, or AV node ablation with CRT for the patient in which you think that they will not going to end up with multiple attempts. They are not going to go back into the sinus rhythm. This is one of my patient which has a CRTP for heart failure. She's a 60-year-old female, diabetic, hypertensive, non-ischemic cardiomyopathy, and she was doing very good with heart failure treatment within CRTP. Then she, after 1 year, she came back again that she was having acute shortness of breath. And when we monitored, when we do the interrogation of the device, we found she was having runs of paroxysmal atrial fibrillation lasting for 4-5 hours. And that was causing her symptoms. Whenever she was having atrial fibrillation, she was short of breath. She couldn't do anything. Her function class gradually started dropping as much as her atrial fibrillation duration was increasing. Although she, I started her first, she was already on beta blocker. I started her on quadrone, but with quadrone, she developed gastritis kind of symptoms, and she was not tolerating quadrone at all. So then we offered her AF ablation. This is done with cryo balloon. And after transeptal, you isolate all 4 of the pulmonary veins. This is the left superior pulmonary vein. It's running. So you take your balloon to the left pulmonary vein, you inflate it, and then you give the dye and check whether there is a leak over there. If there is no leak, then you start with the cryo ablation. One by one, you isolate all the veins. This is the left inferior pulmonary vein. This is the right inferior pulmonary vein.
Excuse me, please switch up your mics.
Out of portion. One month
follow-up. She is asymptomatic. There are no atrial fibrillation episodes. She's still continuing with the heart failure treatment. And in fact, her ejection fraction, which was at the start was 35%, was later improved to 45%.
This is a conference.
So in conclusion, heart failure and AFib are closely tied and either can be the source or result of the other. Heart failure therapy mainly consists of GDMT supplemented by device, CRT when indicated. Medications for AFib are limited as a wide adverse effect profile leading to non-compliance. Now there is sufficient data available suggesting catheter ablation of AFib as a treatment option resulting in improved quality of life and decreased hospitalization. Still, I will not comment with the mortality benefit because data still is lacking with the mortality benefit. Although I think the newer trials which they're doing, maybe we will have the mortality benefit from that. But with the heart failure patient, even if you are improving the quality of life and decreasing the heart failure hospitalization, that will ultimately result in the mortality benefit, because the patient who's coming again and again to the hospital, that means the heart failure is not controlled. And ultimately, if heart failure is not controlled, triggers are not controlled, you are increasing the mortality. Thank you. We can have the questions, if any. Yes.
The trial data which you showed didn't show much benefit with beta blockers, ACE inhibitors, or even for that rhythm control versus rate control. So it's kind of surprising because again, from clinical experience,
Yes.
if patient is in AFib with a rapid ventricular rate, you control the rate or try to cardiovert them. And once they are in normal rhythm, they feel remarkably better as compared to before, because in patients who have low EF, and there's almost 25% contribution of the ejection fraction from the atrial cake. So once you restore the atrial cake, the ejection fraction improves and they feel symptomatically better significantly. But surprisingly, most of the data which you showed doesn't give any benefit, either symptomatic or mortality. Isn't that kind of?
It's not on mortality, but most of the trials, even catheter ablation and drugs, they give with the quality of life improvement and recurrence of atrial fibrillation. So most of the studies which are done, even if you see,
you should be grateful to your mom, otherwise, you know.
There was only one trial which showed there was some symptomatic benefit. But
No,
rest of the
all of the trials, they have shown symptomatic benefit. That's what I'm saying. Still, even with the randomized trial, they are not able to show the endpoint of mortality. There is no mortality benefit even with the Cabana heart failure. That was the reason it was not published, and it was again, the data was revised, everything, and with subgroup analysis, they were managed to show that the composite endpoint is not that much different, and the composite endpoint with the mortality. But if you take out the mortality, and if you're taking only quality of life, and if you are taking quality of life improvement and not a recurrence of the atrial fibrillation, that is improved in all the trials. Let me show you here.
So can I add something?
Sure.
If you don't mind. So that's obviously always the question that's been asked of us, that AF ablation does not improve mortality. So I think first of all, we have to realize that a lot of procedures in electrophysiology, that we are being bitten by our own success. So for AV and RT, we ablate, and 95% of the patient did not have recurrence of AV and RT. Same goes with the pathway. So that same success was being accepted of atrial fibrillation, which obviously atrial fibrillation is not a simple arrhythmia, it's a complex arrhythmia. It's not something that will results in 90 or 95% success rate. And most of the, if you look at, let's say, the mortality benefit of PCI in patients with stable angina. So if you see, I think the trial data for mortality benefit in angina patients is also not there. But I think we don't really question doing PCI in symptomatic patients with angina. So I think with the same analogy, we have to think of atrial fibrillation as well. So atrial fibrillation provides symptomatic benefit, and the trial data which is most robust for that is the Cabana AF, which comes out obviously last year. So we looked at the quality of life, symptomatic benefit, and it's definitely shown that definitely AF ablation proves that there is definite symptomatic benefit. Early rhythm control trial, which obviously I think Ghazala has shown, ECFNet, yes, have also shown that not just symptomatic benefit, it's also benefit mortality to some extent, early rhythm control. So I think the key is in atrial fibrillation is early rhythm control management. If you wait 10 years or 5 years down the line, by the time atrial fibrillation becomes persistent, I think that's when the data is not there. I think in persistent AF patients or chronic persistent AF patients, once the AF sets in, the AF begets AF. So then it becomes very difficult. But I think the message which I want to give here is early rhythm control in atrial fibrillation, whether, and especially in patients who have tachycardia-induced cardiomyopathies. I think the data is very clear that ablation in these patients are first-line indication. In those who have tachycardia-induced cardiomyopathy, fast atrial fibrillation resulting in low EF. So I think in that group of patient, AF ablations should be first line.
And if we see that we are doing it. I think in last, until now, we have done 30 procedures in an ICVD, PVI procedures. Other than that, Dr. Talha in RIC is doing, in Punjab, PIC is doing, AQ started doing.
So the
Tabba
question
Farja
is
doing.
that, so in anyone with recent AF, especially with a reduced rejection fraction, do you now propose that we are doing enough to send? Because my impression was that this is a complicated procedure and that we are not doing it that frequently here. But if now that is the case and the complication rates and everything else is low, then why not send
Because
everyone
with the
for?
PVI, if you're doing with cryo balloon is a single shot. That's the easiest procedure for AFib ablation, I would say. Because you are just isolating the pulmonary veins. And even if you see the data with all these trials, they're not doing complex ablations. They are just doing pulmonary vein isolation. And the recent data which is coming in, they're just saying, isolate the pulmonary veins first because they are the major triggers. And once you have isolated them and then you follow the patient, and if there is a recurrence, then these are the patients which are going for the redo procedures. And if you see, there are patients which you are not going to offer the catheter ablation. If a patient's LA size is really huge, if the volume is 55, these are the patients, whatever you do, they are going to come back, because what happened with them, the fibrosis, atrial fibrosis is already set in. And even if you do complex procedure, like you do pulmonary vein isolation, and then you do all the lines in the left atrium, like you do the mitral line, you do roof lines, then you do the fractionated EGMs, you ablate everything. Still, these are the patients who are come back because the fibrosis is got set in there, and you are going to have new triggers. So those are the patients which are not going to benefit from ablation. Patients who are coming early, who have early AFib, they are going to benefit in the long run, because you are stopping the fibrosis at the start. Yes, Talha, please.
Generally, Sir Nadeem Rizvina baat puchiye. So generally the procedure itself is not very difficult. Obviously a procedure is a procedure. The complications that probably, if we can say, that potentially can arise are mainly due to the transeptal puncture, or with potentially reversible complications of phrenic nerve palsy. I think there are operators in Pakistan who are now trained quite well in the particular procedure. Dusri baat, it's actually doing the most important thing is selecting the right patients, because atrial fibrillation, it's a complex arrhythmia, as said, because not all of atrial fibrillation is actually atrial fibrillation. These are micro reentrant tachycardias, because we have a lot of rheumatic valvular heart disease in its initial stages, rheumatic heart disease. So it means if we select the appropriate patients, earlier the better. We can potentially, I won't say absolutely cure right now, but I would say in inverted commas, we can cure their relative symptoms. And initially, yes, when we look at the upfront costs in the private sectors, they are there. But when we maybe translate it and extrapolate it over a period of years and look at the health economics, I'm sure the more these procedures come in play, with properly done procedures, I think the eventual healthcare costs would actually decline, because obviously the equipment would get cheaper, the burden on the hospital emergencies, lost time of work, on the medications. And if with a little bit of investment, we can give the patient a peace of mind that, look, now you're healthy and he feels healthy, especially in terms of symptoms. And hopefully, as Dr. Yawar said, maybe in a couple of years or maybe 5-10 years, we get further robust data to suggest mortality benefit. I think it's quite a nice procedure. And yes, I would request that majority of all of us colleagues, we should have a consultation done from the people who are doing the procedures, simply just to filter out who would really benefit and who would not, because it's very difficult to give a blanket statement at this stage with who's going to benefit it from most. But in general, the earlier the better. Unfortunately, sometimes what happens is that patients naturally, I mean, they are dragged on medicines by the time they're paroxysmal, because there's no absolute demarcation between paroxysmal and persistent. So what happens is that they achieve the late paroxysmal stage where they're translating into the persistent. And then if we start ablating, well, there are probably histological changes that have occurred beyond the pulmonary veins. And these patients would be the ones who would be having recurrences as compared. So earlier the procedure, the better. In appropriately selected individuals who have true paroxysmal atrial fibrillation, probably it would give quite a reasonable outcome. And every major city more or less is doing this procedure now. So it's not something that the patients we travel can. Like, I'm sure there are a lot of procedures. I mean, myself, I decline. I simply just don't go
Yes.
for their procedure. Dr. Ghazala.
Yeah, a lot of patients we decline actually. You will not benefit because single procedure is not possible. Sometimes patient come and then I tell them no.
So
I think single procedure is not possible. Maybe you are going to need another one and another one.
Sure.
And I cannot guarantee you that even after 2-3 procedure, you will be in AFib. So you have to think of, this is not an option. We have to think of the other options. Like as I already, then these patients will go for the CRT with AV node ablation.
So sure.
Same question. Has there been a trial comparing like DC cardioversion and maintaining them in normal sinus rhythm with amiodarone versus doing DC ablation? Because you see the anticoagulation, you still have to give them, and the likelihood of recurrence is also still there after ablation. So what's the difference, or is there any trial which has shown any benefit of two?
No, I think there is only trial with catheter ablation and amiodarone.
Sorry, मैं actually mentioned in the start. ये जो डीसी कार्डियोवर्जन वाली बात आपने शुरू में की थी, प्रोफेसर साहब यही बात पूछ रहे थे. इसके बेनिफिट्स हैं डीसी कार्डियोवर्जन के, विद amiodarone बेनिफिट्स ज़्यादा हैं. There were studies and studies earlier. आप BMJs पढ़े ना, उसमें many studies. शुरू में बड़ी प्रैक्टिस होती थी, अभी भी करनी चाहिए. In fact, we are at AFIC hold a registry, probably over 10,000 patients now. Lately, DC cardioversion के मुकाबले में जब से ये AF ablation आई है, and remember जो डॉक्टर साहब अब बात कर रही हैं, these are high risk patients. They're not simple, straightforward. तो जो high risk patients में AF की ablation की वो बात कर रही हैं, उसका benefit जैसे कबाना यावर ने quote किया, कबाना despite all its limitation, remember big number 778, big follow up 48 months, age wise 68 years इनकी age थी, तो उसमें rhythm की benefit show हुई है. चाहे आप DC कार्डियोवर्जन करें वो भी rhythm control है, चाहे AF ablation करें ये भी rhythm control है. तो head to head trials initially हुए होंगे, later on अभी recently as such कोई head to head trial नहीं, क्योंकि अभी AF ablation की superiority तो establish हो गई है. So it's obviously something which is being done nowadays and established.
In the same context, Ghazala, very simple. Bashir has raised this point. Atrial fibrillation is a very common condition, especially in the elderly. People above 60, I think maybe 50% people will have atrial fibrillation. And in the absence of structural heart disease, DC cardioversion has been a known modality for treatment. But what I see in Pakistan, DC cardioversion is very nominally or maybe not used at all.
That's why I put it here specifically for the same reason, because this is something.
And this culture has not evolved at all. People stay on medications, but they don't opt for DC cardioversion, whether it's our apathy or lack of, you see, knowledge by the patients, whatever, apprehension or whatever. So I think DC cardioversion is very much underutilized.
Yes.
And this needs to be emphasized to our fellows and young doctors that this is a known modality. And in the absence of structural heart disease, you may revert and you may stay in sinus for a long period of time.
And especially for the patient who come with heart failure with reduced ejection fraction in atrial fibrillation, if you give them trial for DC cardioversion and they remain in a sinus rhythm for 1 year, you will notice that they have, I have so many patients who have improved dramatically with the quality of life.
Yeah.
Walking distance, day-to-day activity. Some of them have improved ejection fraction, some of them may not have improved ejection fraction, but with the same medication on sinus rhythm, their quality of life has dramatically improved.
Yes, absolutely. And they can come off anticoagulants, you
Yes.
see. That's
No,
another
they
thing.
cannot come off anticoagulants.
No, after,
No, if the chat test is high, they will be on anticoagulant for lifelong.
yeah.
Yes.
But just one point I wanted to raise. Paroxysmal atrial fibrillation is a real challenge for the clinicians,
Yes.
you see. And when we didn't have Holter monitor, we couldn't even diagnose these. But now with the Holter, we can diagnose at least.
Older handheld devices, you have watches, all these things are so common nowadays.
What's the best approach for paroxysmal atrial fibrillation?
Best approach
for the benefit of our young
atrial
doctors.
fibrillation. I would say best approach for proximal atrial fibrillation ablation. I am ablationist, so I would say ablation. Because it improves quality of life. And you know, these are the patients who benefit most because the LA size is normal. They are young patients. And if you offer them treatment right now, they are not going to change from paroxysmal to persistent. And if you just rate control them and give them Codron on and off, or Sotalol or Dofetilide or Flecainide, and then they come and goes in atrial fibrillation. So what is happening? You are creating the substrate for atrial fibrosis, and ultimately atrial fibrosis will set in and LA size will increase. And at that time, this patient will not benefit from the ablation, because once the LA size increases, it's very difficult for these patients to be remain in sinus rhythm even after ablation. And these are the patients who have, if you see the data, these are the patients who have recurrences mostly, who have high LA volumes at the baseline.
I just want to add one thing that I had the opportunity to work during my training, during my RMO-ship in an ICVD, and I used to work with Dr. Samad, Professor Faruqi, Professor Aslam, and that was a period of pure clinical cardiology. And I remember that we used to do more cardioversions in AF patients, but I don't know how it occurred during the last 10 years or so that we are doing it less and less. And I, being practicing in an ICVD, really I was saying less cardioversion. Yeah, I think that I am trying to say that was not the ablation area. That's why we were doing it more and more. And since the ablation came, however, we are doing ablation not in that much quantity, in that volume. So we must have continued that practice also simultaneously, but that has gone down very much, and the ablation hasn't come up to that much, to that level to replace it. I'm talking about Pakistan. That I understand. Therefore, I'm talking about NICVD and the old clinical practice which we were doing here. I'm hopeful, really. Hello. I pray for that. My best wishes and my prayers are with you, of course.
Yes, Dr. Sala. Yeah.
जब स्पेशलिटी आती है तो डिजीज बढ़ जाती है. When there was no AP personnel, we used to treat these patients ourselves in our own way, you see, and not everybody died. I mean, people used to survive, but yes, with the addition of EP personnel and especially these young ladies, dynamic ladies, EP is becoming very popular and getting a lot of footing in Pakistan.
Okay, Dr. Ghazala, I mean, thank you, everybody. It is very interesting, hot topic. So you can understand it. Atrial fibrillation, I mean, is interest to everybody because the most commonest arrhythmia, and even for medical personnel. My issue is what we are learning, and we have gone through a lot. There are two issues, of course. They changed the definition of atrial fibrillation. And even the guideline, why? Because it was acute and chronic, that concept has changed. as Dr. Talla very correctly said, we have to pick these patients and refer these patients very early. If we lose that time, then all the modalities doesn't work in long term. The two questions still unanswered. One is symptomatic relief and the other one is mortality. We know from the Cabana trial itself has limitation. That was a very disappointing trial for electrophysiologists, but it had limitation. The only trial so far is a Castle heart failure trial, which has already only about 100 or 150 patients. That's the only trial which has shown if you do catheter ablation in a patient with EF less than 30%, their mortality goes down. So it's a very clear indication that patients who have recurrent heart failure and their AFib, they should be referred for. The other group, as you said, the early patient and paroxysmal. And answering to Bashir and Eve's question, that's a very interesting question actually. For general physician, if somebody comes with AFib, whether you do cardio work and antiarrhythmic or refer for ablation, there's small study done and only one limited study which I know that shown actually cardioversion is safe and more not effective, but is safe. The problem is when they compared this, found that was the early trial, more complication in the ablation group. Although the recurrence was less than 70%, but with cardioversion, the recurrence was 60%. On amiodarone, the best data we have is on amiodarone was 65%. So what it tells us, if you do electric cardioversion, it is safe, but patient is going to come back. I do repeat every patient who refused for ablation every year, cardioversion on these patients, which is very safe and effective. But you send the patient for ablation, you have to be sure to understand the risk of complications. The only complication, which was the big thing, is about esophageal thermal injury. So the problem, what we do ablation here, if we don't do a thermal probe in the esophagus. So that is my concern, that we do it, but we can control the temperature. And Ghazala, can you answer that? Because the only my concern is about the esophageal injury, which can be damaging to the patient.
Yes, but it usually occurs with RF ablation. And now you have esophageal probes, you can put that, and with that also. And even if you're not putting with the newer technologies, you are watching the impedance and temperature, you have limitations. People are doing high power short durations. High power means they are going up to 95 watts with 2 seconds and 3 seconds duration ablation with no complications. So it's like with the advancement of the technology, the complication rate is decreasing day by day. And the most commonly, I would say, the single shot PVI is something which is not getting that much complication. The most important complication is the phrenic nerve palsy. So if the operator knows how to monitor for the phrenic nerve palsy, you can avoid it. So that's the most important complication. I think this is the last comment, then we'll break for the tea break.
Just one comment. Remember, atrial fibrillation is a complex arrhythmia. So we are talking about ablation here, but as with all cardiovascular disease, this also needs lifestyle modification.
Absolutely.
So if the patient is obese, with the BMI of more than 25, has obstructive sleep apnea, so I think these are the risk factors that has to be controlled as well. I think yes, we are talking about ablation, but I think this should be kept in mind.
So these are the patients who are not going to benefit ultimately with any treatment because they're not going to do lifestyle modification. So we'll finish with this and we'll break for the tea break, and then we'll reconvene in 15 minutes. Thank you.
First, the first panelist will be Professor Dr. Zahid Jamal. Dr. Zahid Jamal has been the person who has established the electrophysiology program at NICVD, and he was the first implanter of ICD in Pakistan. The second of the panelists is one of my first teachers in cardiology, and I had the privilege to train in my first year under him. He is the executive director and the medical director of the Heart Institute, Professor Dr. Bashir Hanif. Our third panelist for these two talks will be Professor Nadeem Hassan Rizvi. He is a renowned interventional cardiologist. Now, the talk that we have next is a very important talk, both from the perspective of the cardiology trainees and for the EP trainees as well. It's for the indications for the device implants, pacemakers, ICDs, and CRTs, and it's going to be a case-based talk. So I'd invite one of my first teachers in electrophysiology, and I'd say a very dynamic electrophysiologist, Dr. Faisal Qadir.
Bismillahirrahmanirrahim. Assalamu alaikum, everybody. First of all, I'd like to thank the organizers for the invitation. It's a pleasure to be here. So my task will be to discuss the indications of devices, pacemakers, ICDs, and CRTs. This would be case-based, but I'll mainly focus on guidelines. So I'll refer you to these guidelines, which are mainly the American Society of Cardiology, 2012 guidelines for device-based therapy. Then 2017 guidelines, there was guidance for the implantation of ICDs. Then 2018 guidelines that I will focus more for bradycardia and conduction system delay. And of late, very fresh is 2021 ESC guidelines for cardiac pacing and CRT. So I'll start with this case, and it's a simple observation that a patient has a 4.2 second asymptomatic pause. So is a pacemaker indicated? That's a question. I know that the 3 second pause has lived in the cardiology community, and the initial guidelines in the early 2000s did recommend a pause of more than 3 seconds to be an indication for pacing. But as we notice here, this is a patient who has a termination of atrial fibrillation. So the atrial fibrillation is going on and it terminates with a pause. And then there's a return of sinus beat, that's a junctional beat, and then the patient came back into sinus rhythm. He's asymptomatic with a 4.2 second pause. So what the guidelines say is, they do mention a 3 second pause, but that is in the context of an AV node or AV block. So if you look at this 2012 guidelines, it is mentioned in an acquired AV block. So if a patient has sinus rhythm with documented periods of asystole greater than or equal to 3 seconds. So what it means is that if a patient has a complete heart block with a very slow escape rate of more than 3 seconds, or an intermittent high-grade AV block with a pause of more than 3 seconds, then that is an indication for pacing. So it is in the context of an AV block. And for an atrial fibrillation, it is more than 5 seconds, even if it is asymptomatic, seen on an Holter, that would suggest it's a significant AV nodal delay and the patient needs a pacemaker. This is a chart borrowed from the 2018 guidelines, eliciting the approach to sinus node dysfunction. What it just comes down to is the presence of symptoms. So if a patient has symptomatic bradycardia, and you can correlate the symptoms with the bradycardia, even if it is a pause of 2.8 seconds, it is symptomatic, or a bradycardia which is symptomatic, it is an indication for pacing. Or if a patient is on a guideline-directed medical treatment, which requires a beta blocker, and the patient does develop significant bradycardia and is symptomatic, then you ought to put a pacemaker. That would be a class 1 indication. Then later down, lower down would be a more focus on if a patient has pure sinus node dysfunction, to put an atrial-based pacemaker, implant an atrial lead or an AI pacemaker. That would be class 1 indication. And if you put a dual chamber pacemaker, try and minimize with some algorithms to minimize right ventricular pacing with the dual chamber pacing. So it's mainly symptoms. It is not a rate cutoff. It is not a pause level cutoff to recommend therapy. It's mainly the presence of symptoms. Now, moving on to AV blocks. This is a 60-year-old lady who has episodes of lightheadedness. If you see this ECG, she has sinus rhythm with first-degree AV block, a prolonged PR interval, and also a right bundle and an axis. So she's got a bifascicular block. Intermittently, she was noted to also have complete heart block. So is a pacemaker indicated in this case? Yes. If you look at the guidelines, and there's been some subtle change between the 2012 and 2018 guidelines. So what the guidelines now say is any AV block which is high grade, advanced AV block, high grade would mean more than 2 consecutive P waves which are non-conducted, or Mobitz type 2, or a complete heart block, irrespective of symptoms, put a pacemaker. So that's the new indications. If a patient has asymptomatic and significant AV nodal delay, also a class 1 indication. And interestingly, if a patient has a marked first degree AV block or a second degree Mobitz type 2 AV block with symptoms which are clearly attributable to the AV block, it's a class 2 indication to put pacemaker. And we see this complex chart. I'll break it down into 3 parts. The first part is that again, walking from the right to the left. That sleep has on these patients. So this is how a nocturnal bradycardia would look like, that you can see on the left side of the trace. The sinus rate is gradually slowing. We see a progressive PR interval prolongation, and then there is a 2-to-1 block. So it is in the context of heightened parasympathetic or vagal stimulation during sleep that the patient develops sinus bradycardia and also sometimes AV blocks. And not uncommon to see that in athletic patients who have heightened vagal tone at night. Now, this is from the 2021 ESC guidelines. So pretty much similar indications for sinus node dysfunction and AV blocks. So there's congruence between the ACC-HA and as well as the ESC guidelines. And the bottom is the sometimes patients who have unexplained syncope and have a bifascicular block. And the symptoms are suggestive of a bradyrhythmic syncope, what to do about these patients. So the guidelines would say that do an EP study, and if you find significant HV interval prolongation, HV interval would mean that infrahisian there is significant delay. So if you have significant HV interval prolongation more than 70 milliseconds, then it will be an indication for pacing, or you do an incremental atrial pacing and find intra or infrahisian delay or block, then that would be an indication for pacing. So that can be considered. Or if a patient has alternating bundle branch block, so one ECG has right bundle, another time he has a left bundle branch block, asymptomatic, but alternating bundle would be a class 1 indication for pacing. One more thing in the ESC guidelines is congenital AV blocks. Sometimes we tend to see these patients. They are asymptomatic. What to do about them? Middle-aged, or they present to you. So the guidelines recommend that if they have congenital complete or high degree AV block and have one of these following features, then it's a class 1 indication to put a pacemaker. Number 1 is the presence of symptoms. So if they are symptomatic, you go ahead. If the pauses are more than 3 times their baseline escape rhythm. So whatever escape they are at, like 50 or 60, and you multiply it by 3 times and you document an RR interval more than that, so that will again be an indication. Or if they have a broad QRS escape, you can consider a pacemaker. And or during Holter testing, you find QT prolongation because of bradycardia, complex ventricular ectopy, or mean daytime heart rate is less than 50 beats per minute, then pacing becomes a class 1 indication in these patients. Pacing in acute myocardial infarction, almost the same recommendation, but here they kind of have given a number of waiting time. So if the bradycardia is persistent, heart block, or otherwise, and if it's more than 5 days of MI, after 5 days of MI, you put a pacemaker. Almost similar recommendations for patients who have post-operative heart block, like aortic valve surgery or other surgeries, which have high risk of AV blocks. What about his bundle pacing? So a lot of hype about this new modality of pacing. This is conduction system pacing. So there are no class 1 recommendations. I showed you the class 2B recommendations there. However, in patients who have CRT, you're attempting a CRT and are not able to place the LV lead, you may consider his bundle as a class 2A option to pace the conduction system directly. And what about leadless pacemakers? So this is a pacemaker without a lead, and it's a small capsule sort of size device, which is implanted directly into the right ventricle without a lead. So it's a device and an electrode built in. So that's called a leadless pacemaker. So it's a class 2 indication, especially in patients who do not have accessibility from the upper extremities. They have blocked veins, or they have high risk of infection or had prior infection, or patients who are on hemodialysis. You can consider leadless pacemakers in these patients. Pacing for reflex syncope again was a debatable thing. When to put pacemakers in reflex syncope. So now with good randomized data like the issue 3 trial and the VASIS and the Spain, and now the BioSync CLS trials, we have good randomized data to have a class 1 indication recommendation for patients who are more than 40 years. So it's not for young patients, it's more than 40 years and have unpredictable severe syncope, who have either asystolic pause, asymptomatic pauses more than 3, or asymptomatic pauses more than 6, or they have cardioinhibitory symptoms, syncope, or asystolic pause documented during tilt testing. So in these sort of patients, class 1 indication for pacing. Then coming on to case 3 for an ICD. So this is a patient who presents to you. It's not projecting on the main screen. So this is a patient who has who's come to you for an opinion for an ICD. He's asymptomatic. He's 20 years old. His brother died suddenly because of sudden cardiac death at the age of 20 years. On an echo, his EF is normal and he's got marked septal hypertrophy with a thickening of more than 35 millimeters. He's got SAM and a resting gradient of 10 millimeters. So he's got hypertrophic cardiomyopathy. An MRI showed thickened septum, but there's minimal scarring on the MRI. So what to do about this patient? So for Icd secondary prevention, we know patients who have the guidelines are pretty clear, and the patients who have sustained VTs, who have survived a cardiac arrest or sustained stable VT, it's a class 1 indication to put pacemakers in either ischemic cardiomyopathy or non-ischemic cardiomyopathy. So secondary prevention data is same and similar. For primary prevention, it comes down to is the etiology ischemic or non-ischemic? No, I'm fine. I'm safe because we are discussing ICD, so no issues. तो छोटा नहीं इसका साइज तो बड़ा स्लाइड शो पे
In the interest of time, for the completion of this presentation, we'll curtail the questions at the end of this presentation.
Okay, so if that's visible. So I was discussing this ECG. This patient has marked hypertrophy of the septum. You can see the prominent R wave in V1, V2, and you also see a septal Q wave in these inferior leads, 2, 3 waves. So it's suggestive of marked septal hypertrophy. So we'll come to this case, but as far as the guideline indications for ICDs are concerned, secondary prevention is clear, as I mentioned, class 1 indications. For primary prevention, we have the data coming from the multiple landmark trials. Present. Okay, so that's better. So this is divided into ischemic and non-ischemic. So if EF is less, these are heart failure patients who have EF less than 40%. If they have non-sustained VT and they have positive VT induction on EP study, it's a class 1 indication to put pacemakers. That's coming from the MUST data. Then EF less than 35% NYHA 2 to 3 heart failure coming from SCUD-HEFT, class 1 indication, and ischemic heart disease, EF less than 30%, class 1 heart failure is coming from MADIT 2. For non-ischemics, it's mainly SCUD-HEFT with NYHA 2 to 3 and EF less than 35 is a class 1 indication for a permanent pacemaker. For channelopathies and cardiomyopathy like the Brugada, long QT, or hypertrophic cardiomyopathy, if it's a class 1 indication if they have survived cardiac arrest or they have symptomatic sustained VT. And if they have high risk features, then it's a class 2 indication to consider them for ICD as primary prevention. Now it's a busy slide, but generally for patients who have ischemic heart disease, this is all what we've discussed, class 1 indication and class 2. I would just focus here that patients who are less than 40 days post-MI or 90 days, less than 90 days post-revascularization, it's not a pacemaker ICD as a primary prevention. You have to wait for that time and then reassess their echo for EF assessment and then implant an ICD. For patients with non-ischemic cardiomyopathy, I'll just focus on patients who have syncope and it is sounding like an arrhythmic syncope, class 2 indication to put an ICD, and otherwise this part of the slide where a patient who has incidental finding of a cardiomyopathy and he has heart failure symptoms, it is not an indication for a primary prevention ICD. So you treat them with good guideline directed medical therapy. Some patients may have improved EF and then reconsider based on an echo to put an ICD. Now coming to a case for hypertrophic cardiomyopathy, we have guidance from the European Society as well as the ACC. On the left is the ACC flowchart for recommendation of ICD in these patients, and on the right is the hypertrophic cardiomyopathy for ESC guidelines. They look at some risk factors like family history, syncope, massive LVH, and then they recommend guidelines, ICD implantation as a class 2A. As far as the European Society is concerned, they look at a HCM risk sudden cardiac death score, and they classify into low risk, intermediate, and high risk. If the risk is more than 6%, then it's an indication for primary prevention ICD. Now let's calculate what happens to our patient. This is the app. You can download it as an app and feed in plugging the details. But I just want to show you just some fallacy in this application, which may not give you the correct result. So in our patient who's 20 years old, whose wall thickness is 35 millimeters and has got a gradient of 10 millimeters mercury, you plug in all the details, but just for a while, rather than 35 millimeters, you write in 29 millimeters, which is still significant, and see the indications. So the risk that calculates comes out to be 6.15. So it's high risk and an ICD should be recommended. Okay. Now conversely, if we put the correct value in our case is 35 millimeters, and now the same value turns out to be intermediate risk. And now this is we know time and again that more than 35, the higher the septal hypertrophy, the higher risk of arrhythmias and the worse the prognosis. But this is an issue with this application because applications at the end of the day use data coming from registries. And in this sort of hypertrophic cardiomyopathy registry, the number of patients who had really thick septum was less, and hence the data was queued up, and this is a result of this. So we just have to be a bit cautious with this application. Otherwise, I think I use the application pretty frequently, and it is a good application. Now, what about subcutaneous ICDs? So this is an ICD which does not have a lead, and it's a device which we put in the axilla. So the guideline recommendation would be for patients who have vascular issues and you can't put an ICD, or patients who do not require pacing, because sometimes some patients with ICD also require pacing. So if there's not a need for a pacing, you can consider a subcutaneous ICD as an option. Coming to our last segment of CRTs, this is a 58 years old male who presents with fatigue on exertion. His prior MI, status post PCI, doesn't have any active heart failure symptoms, and is on very good guideline directed medical therapy. I'll show you the ECG in a while. He's got sinus rhythm with PR interval prolongation and Mobitz type 1 AV block, and he has a left bundle branch block with a white QRS. His echo shows an EF of 45%, and it doesn't have any significant valvular abnormality. So this is the ECG showing a left bundle, significant PR interval prolongation of like 260 milliseconds, and there's a Vancouver pattern, so it's a type 1 AV block. His EF is 45%, got left bundle, white QRS. Should we put a CRT, consider him for a CRT? So just a brief slide about CRT and the benefits of CRT. The two trials on the left are older trials. They enrolled patients who had significant NYHA symptoms, NYHA 2 and 3 symptoms mainly. You can see the benefit between CRT and medical treatment on the left. The middle two trials, the MAD CRT and the RAFT trials, are more recent trials. They enrolled patients who are mainly NYHA 2, so less sicker patients with heart failure. And you can see the benefit. You can see the benefit as opposed to an ICD, but generally the numbers of sudden death and mortality has reduced, and this is probably because of good medical therapy that was being implied on these sort of patients also. But certainly CRT is beneficial to ICD in these sort of patients also. And you have the data, the old US carvedilol study, just comparing medical controls with medical treatment with beta blocker, showed a significant reduction in certain cardiac death also. So what are the guideline recommendations for CRT? A class 1 recommendation would be patients who have less than 35% EF, NYHA 2, 3, or ambulatory 4, left bundle branch block, and a very wide QRS more than 150 millisecond. That's a class 1 indication. If the QRS is not that wide, it's between 130, 150, it's a class 2 indication. Or if the patient has a non-left bundle pattern, either be it an intraventricular conduction delay or right bundle branch block, but a very significant QRS widening, it's again a class 2 indication to consider CRT in these sort of patients. What about patients who have more than 35% EF? So the region between 36 to 49% or 50% EF, what to do with these patients? So class 2 indication would be what I discussed, patient who has a requirement for ventricular pacing, and you think that he will require the ventricle needs to be paced significantly more than 40%. A class 2A recommendation would be for these patients to put a CRT, consider CRT. So this is what we have discussed. I like this chart from the ESC guidelines because sometimes we are in that position to decide, should we go ahead with a CRT pacemaker? Should we prefer a CRT with a defibrillator? We understand the cost implications. So the guidelines use this word of shared decision making, which means that the physician and the patient get into a good discussion, discuss their pros and cons, and it's considering the patient's values, preferences, and goals, and then come up to a consensus. So if a higher age, we know these patients usually die of pump failure rather than arrhythmic deaths. You may probably consider CRT-P in these sort of patients. And a younger patient, you will probably err more towards selecting a CRT defibrillator. If we do an MRI and find significant fibrosis, maybe a CRT-D would be a better option. And then these are a few variables like non-ischemic cardiomyopathy fare better with CRT. So you can consider CRT pacemaker, a patient who has short life expectancy, major comorbidities, poor renal functions, you will probably consider CRT-P more than CRT-D in these sort of patients. And coming to our case, who has got an EF of 45%, AV block, left bundle branch block, what should be the way forward? Stop his beta blockers, he's already on beta blockers, stop his beta blockers, maybe his AV block is going to get better. Don't give him beta blockers in future. That is one thing. You may do a treadmill stress testing, see how his AV block worsens, do an EP study, do a Holter. How do you pace the ventricle? Do you put a dual chamber in him, do a CRT or his bundle? So these are all valid questions. So what we did was a CRT in this case, and we see this very nice CRT ECG with a shrinking of the QRS complex, and this patient responded very well. I'll just skip off this slide. That's it. So in conclusion, I will say that patients for guidelines for permanent pacing or indications for devices, there is no rate cutoffs There are no pause cutoffs to recommend. It's mainly symptoms that you decide for pacing. There are new technologies around like his bundle and leadless pacemaker. So we have more options, but it also means that we have more decisions to make and more shared decision making with patients. For defibrillators, it's mainly focusing on heart failure and calculating the risk of sudden death to decide for implantation of defibrillators. And for CRT, we know a survival benefit of CRT also. We certainly are aware of the improvement in heart failure class, as well as reduction in hospitalization with CRT. The best patients will be non-ischemic cardiomyopathy, LBV, more than 150 millisecond QRS duration would be very good candidates, and a shared decision making when choosing between a CRTP versus a CRT defibrillator. And we have these new technologies. Did not touch on these, but these are also other options in patients with low EF but narrow QRS. We can consider cardiac contractility modulation and baroreceptor stimulation. Okay, thank you very much for your attention.
Thank you, Dr. Faisal, for that excellent talk. I think we are already short of time, so we can entertain only 2 to 3 questions. And in the meanwhile, I will request the IT people so they can play with the projector setting. So only 2 to 3 questions.
Was that people with the post-MI after a month or so. This has been a debate which has been going on, like what is the numbers needed to treat to get the benefit? For example, in patients who've got ischemic heart disease and low EF, how many lives are saved? Because, as interventionalists, we just want simple guidelines that, yes, this patient would really benefit and this would not. I mean, we've got years of experience with not putting in AICDs because of expense and whatever. But now that the guidelines seem to be changing, the impression that I got was there were some complications with these AICDs. So the overall benefit was not that much. So there were certain people who did have arrhythmias or with very poor EF with cardiac arrest. Those are the ones that there was definite indication. Now, just very clearly, what would you recommend for us as interventionalists that this is the patient and how many lives are saved for every 1,000 patients that are treated with AICDs with EF of less than 40% post MI?
So if I get your question correctly, the first thing I think you asked about the patient who has had an MI and has got an EF of 25 to 30% and should
less than 40% is what you showed on.
So should we put an ICD upfront? Because certainly this patient is high risk for sudden death. So the guidelines would keep a class 1, these patients are at high risk. The guidelines would recommend that you give them guideline directed medical therapy and reassess their EF in 40 days after MI, or if they have revascularization, 90 days post revascularization. And if their EF improves, then they don't need an ICD. If their EF is still low, then it's a class 1 indication to put an ICD. In the meantime, they would recommend, because these patients would be at risk for developing sudden sustained arrhythmias. So a class 2B indication is recommended for a wearable cardioverter defibrillator. So it's a vest that the patient wears. It's not a device, it's a vest. And if the patient has an arrhythmia, the device.
But then you're talking about millions and millions of patients who've got in our country who's got EF of less than 40%, post revascularization, post CAPH, post PCI, who've not had it, and they're just, you've seen hundreds of them.
Yes.
So from what you say is that there's a class 1, they should all have AICDs.
No,
because their EF after 90 days is still less than 40%.
Yeah, so
they've got scarred areas. They have not had cardiac arrest, but according to your slide, they should have AICDs.
Yeah, so the must data would be for between patients between EF 35 to 40%. So you will do an EP study and look for an inducible VT. And if that is the case, then you will put an ICD. So less than 30% in coronary artery disease, even if the patient does not have any symptoms of heart failure, it's a class 1 indication to consider for primary prevention ICD. That's coming from the MADE-2 trial. So, and we know MADE-2 was like 23% reduction with ICD, sudden cardiac death as compared to medical treatment.
Only problem is that with this, when it comes to 30, 25, 35% range, I think if I give the echo to 3 cardiologists, all 3 maybe, one may be saying 25, other may be saying
Agreed.
35 or 40. So that really becomes kind of sometimes very difficult to what to do in such cases.
Yeah, that is an issue that has been looked into, but unfortunately, what the data that is coming from the guidelines is based on a visual assessment from echo. So the gold standard probably would be an MRI, but at those times, the large scale trials that was done was based on echocardiographic assessment.
So just a little comment on who should we offer an ICD, and we have data from MADIT2, but we have 8-year follow-up from MADIT2, and we have a MADIT2 scoring that will based on clinical features, ECG, and some lab workup that will classify patient into low risk MADIT2 score, who will definitely benefit from prevention of arrhythmic deaths. Older people, advanced heart failure, broader QRS, renal failure, atrial fibrillation, the more you keep adding these to your primary prevention ICD, the risk of sudden cardiac death prevention becomes less and less, and implanting ICDs have less favorable impact. So, you know, the sub-study of MADIT2 and 8-year follow-up do help us in selecting that population. So 40-year-old, no heart failure, normal QRS, no renal failure, no AF, MADIT2 score is 0. But if somebody is 65, heart failure, renal failure, QRS is broad atrial fibrillation, MADIT2 score is 5, they will not benefit. So you can actually risk stratify them even based on the clinical predictors as well.
One more thing, sometimes what happens is in what Dr. Nadeem says is that we should be a bit judicious about using of ICDs in our population. Obviously, they come at a very formidable cost. So a patient who's got coronary artery disease and has got very low EF and is a younger patient, probably our focus would be that you should at least try and put an ICD. Patients who present with advanced heart failure symptoms, they probably may not, they would probably die more of a progressive heart failure rather than dying of an arrhythmic death. So consider younger patients, coronary artery disease, low EF for primary prevention. That is probably give you the best.
Hello.
Yeah. Yeah, so that has been looked into this Danish study, which has come up with patients predominantly who had non-ischemic cardiomyopathy. And what it showed that the ICD did not have a benefit as compared to other patients who had good guideline-directed medical treatment. So certainly guideline-directed medical treatment does have a dent on it. I showed you the slide between just plain old beta blockers and placebo. Certainly beta blockers work. Now with ARNIs and the SGLT2 inhibitors that we have now, with very good medical treatment, add to that CRT, you're talking about great survival benefits. So, so good medical treatment again has a definite role, and you can see the recent CRT trials showed less mortality because they also had good medical treatment along with CRT. So the benefits certainly are there with good medical treatments.
Okay, Dr. Harun, you have a question? Yes.
ACE inhibitors.
Yes.
Yeah, so,
yes,
so
John answer.
So yes. Two things. One would be that you strive for symptomatic improvement. So that is one thing. If a patient is a CRT candidate, the EF is not improving, he's not doing well on maximally tolerated medical treatment, you'll go for a device. On the other hand, if for an ICD, if the EF improves and is out of that range, and we've seen patients who do have improvement, especially the non-ischemics, they improve with good guideline directed medical treatment, so they don't need a device. And if the persistent EF is low, so maybe for primary prevention, you can consider an ICD.
Yes, what I meant to say was that, like you were earlier telling, like 30 days or 90 days, you wait and then you implant the ICD or CRT if the patient doesn't improve. But with the coming of this new armamentarium of the drugs, maybe they need a slightly longer time and they may benefit. And if you wait, they may never need it.
Sure. I mean, those only small follow-up on patients after ARNI, those patients were on the transplant list, they were taken off that list. Okay, so we know, I mean, symptomatically they improve. The challenge is most of the people who die, they're in function class 2. So sudden death has nothing to do with the symptoms. You have to remember, okay? The symptoms may improve, but the patient still, unless their EF improves, the risk of sudden death will be there. So ARNI may decrease sudden death or not, indirectly it may, but it definitely improves symptoms. The question of ICD, unless the EF is low, they will be at high risk. So it doesn't go with the symptoms. Majority of the people who die suddenly are active people who are not in the hospital. They are healthy people. So they are the one who are at risk. The patient who are symptomatic, what you see in the hospital, they will die from pump failure. They will not die from arrhythmia. So in the CARE heart failure trial and companion trial, they did not put a defibrillator. And what did it show? That symptoms improved, the mortality went down. When they added companion defibrillator trial, they changed the whole game. They said, no, you have to have a defibrillator because majority of people who you thought they improved, they died suddenly. So the ICD risk, the only data which is negative for ICD is in the definite trial of dilated cardiomyopathy. That is also controversial because ischemic cardiomyopathy is different than non-ischemic. The people who are at non-ischemic cardiomyopathy, if you put the defibrillator, they followed up. The patient who had ischemic heart disease, they got their first shock within first year. The patient who got non-ischemic cardiomyopathy, they did not get the shock till 4 or 5 years. It doesn't mean they are low risk where the event goes later on. So therefore, in non-ischemic cardiomyopathy, indefinite diabetes, the trial was negative because it did not show earlier mortality benefit. So you have to be selective in dilated cardiomyopathy and risk stratify. That's the only question. But ischemic cardiomyopathy, you can't take that risk.
Indication is 35 and 40. And it increases more than 40 with the ARNIs and these things. Then what? Then there is no indication for the ICD.
Indication for a device?
This is a device.
No, I mean, you know, it has to be less than 35% with function class 2 or less than 30% with function class 1. So if it's 40%, that patient doesn't belong. Unless, as just mentioned about if the patient has non-sustained VT, then P study, if the EF is above 35%, to risk stratify, that was must trial.
A patient is on 35 or 30 injection fraction. Okay, then we are giving the ARNI on these SGLT2. And if ejection fraction rising to 40%.
Then he's already doesn't go into high risk.
Okay, thank you, Dr. Faisal, for this nice elaborative talk. And it is an excellent talk. So for the next talk, I'll invite Dr. Talha bin Nazir from Rawalpindi Institute of Cardiology. The next talk is a very important talk because it's a common thing that we see in our clinic being electrophysiologists. So Dr. Talha will be speaking on pacemaker malfunction and the ECGs which will be presented in the clinics. Dr. Talha bin Nazir.
Assalamu alaikum, everyone. Firstly, thank you very much for everyone actually to invite me to this occasion. It's always good to be here in Karachi, and it's always good to meet colleagues, senior peers, and junior colleagues as well. My talk is really not more of a talk, it's more of an interactive session. I believe that what I'm going to be trying to do is perform some sort of brainstorming from especially the cardiology fellows, which I can see a few of. Now it might be your day. I personally think the best way to go around studying ECG is to be interactive about it. I'm not going to be overwhelming you with a lot of new knowledge. The only purpose is to rehearse probably what we know and try to apply it to some of the scenarios. So it's more of a diagnostic process where it will sensitize and even refresh my own memories. So to begin with, I'll be, right. So we know that implanting a pacemaker is perhaps not probably the most difficult thing, but managing a pacemaker is actually what is required, and a basic understanding is required from all of us who are in clinical practice. So generally, what is a pacemaker? A pacemaker, just to keep it in way, it's a little generator. It has a wire, a couple of wires, or 3 wires, which are going through the venous system, and they're either implanted into the right ventricle, right atria, even at the junction of the AV nodes nowadays, just infraradian, and also some wires are passed into the coronary sinus and to the LV free wall. This is just the same picture with the same principles, because when we talk about pacemaker malfunctions, we could be having problems within the generator. We could be having problems within the leads. We could be having a combined problem. We could be having a problem at the interface where the lead meets the myocardium, local myocardium, or the local tissue. In addition, we can have problems within this canister, which houses not only the battery, the circuitry, the computerized algorithms of the device. So I'm just going to move on, and as I said, it's more of an interactive session. I would request that as many of you, they might seem straightforward, but as many could contribute to this, I think that's what would make this more interesting rather than me just actually giving my narrative on this. So very quickly, we have a 37-year-old gentleman. He presented with dizziness and pre-syncope. He was implanted a pacemaker, and that pacemaker was passed, the lead was passed into the RV. This is the rhythm strip. Intentionally, I've not given the options just yet, but would anyone want to just comment what they see on this rhythm strip? Can I have a raise of actually the cardiology fellows and team? Please don't be frightened. I'm a very nice and friendly person. I won't intimidate you guys. Do we have guys over here? We have. Can you pick one? Which area are they sitting in? This area? This area? Absolutely. So can we have one of our EP fellows actually just giving us a comment, and so that they can add and they can maybe break the ice? Okay. Okay. Would it help if I put the options down? Would this be a bit more helpful? I hope it is visible to the people sitting at the ends as well. Can everyone see the slide? I know it's a bit small in size, but please, I've tried my best to make them very simple and to the point. So if I can just help you in this way. So this is a rhythm strip. Do you think this is a normal rhythm strip?
There is loss of capture in this strip.
Sorry, wait. So can we have the mic basic thing?
There is loss of capture in this strip.
Oh, so okay, so Zara, aap bata sakte hain ki why do you say this? So why are the 3 other options not the correct ones? Mike, please de dijiyega.
So basically what we see is the pacing rhythm strip, and the pacing is actually happening on the regular intervals. And we can't see any capture. When we see a pacing spike, we can't see a capture next to it.
first of all. And the pacing spike is coming on the R wave QRS complex. So that means it's not able to see the QRS and not inhibiting itself. So I think failure of capture and sensing is the.
Okay, so if I can just ask you, since you've been kind enough to volunteer, please feel free to talk. Okay. So why do you think option one, A, failure to output?
If
how can you say you can rule that out just for the benefit of everyone?
Okay. If it was failure to output, then what I think it's we can't able to see the pacing spikes.
Very good. Okay. So does everybody follow that? It's quite basic, but it's important. Failure to output, that there is a generator, it's not able to communicate to the myocardium any output. So it's not able to output what it knows. Failure to capture and oversense. What is oversensing? If we can just, sorry, I'm just put you in the limelight.
Yes, so,
you're, I'm sure, a wonderful doctor, and you have the courage to actually stand up and say.
Okay. Sir, oversensing is when obviously again the QRS is basically small, and we haven't what we can say is tune the device to see the QRS, to see the small QRS, basically.
Okay. Okay, so I think I'll just, because we do have a few cases, but I'm going to just say to you that oversense, you're sensing, the device is sensing something which is actually not there. It's sensing something else. Zara zyada hi over ho gayi hai device, zyada hi smart ban rahi hai. ठीक है? Does that make sense? And in that case, usually whenever the device thinks there is a native signal, it will never give an output itself. So therefore, you should not be seeing a pacing spike, technically. Okay, you if it's a bigger ECG, especially, you should not be seeing a pacing spike when you should be seeing it, right? So failure to capture. Well, failure to capture, आपने कहा था, या इसके जो निचले वाला option आपने दिया था?
Failure to capture and the sensing.
Yeah, I think that's more of a complete answer. It's not sensing it.
Yes.
It's not sensing the QRS that you can see on the ECG strip. And it's just literally the pacemaker is giving the signals, it's marching through it. Here it senses, because possibly maybe the patient's precision has changed, maybe the vector has changed. So maybe just subtly in some of the leads, it could have actually detected this. Whereas in the rest of it, it just completely ignores it. Okay, so yes, the correct answer would be failure to capture and undersense in this situation. What do you think could be the cause? Anyone, any ideas? So unfortunately, the pacemaker was implanted. So it was a single chamber pacemaker, and the lead was placed originally at the right ventricular apex. As you can see, the lead has actually migrated or transisted actually back towards the base of the right ventricle. So this can happen, and this can lead to such a phenomenon. There are various, you could say, causes which would cause loss of capture. Could be threshold rise. It could be due to the infarctions, drugs such as flecainide, which are class 1 antiarrhythmics. Could be lead problems, such as the insulation defects, fractures, displacements, perforations. Similarly, the battery might be end of life. It's not able to generate enough voltage. The programming errors could be there. It could be functional or output levels. I will go through these as the presentation progresses. The undersensing, basically, that's when the spike occurs earlier than expected. You're not expecting it to be there, but it just suddenly occurs. And that could be also due to lead displacement, new bundle branch blocks, infarctions in the localized myocardium, premature beats with perpendicular electrograms. So I'm just trying that this purpose of this slide is, it's not always very, very easy to understand the cause behind it. Sometimes you might end up with a lead, oh, the lead is in position, but there could be several other causes that could be there. So therefore, this requires obviously a little bit of thought and further input and maybe device interrogation. So case number 2. It's a 67-year-old gentleman. He was having dizziness. He had a dual chamber pacemaker implanted. Again, a rhythm strip is shown. So Who would like to go for all of this? Is there a normal strip? Yes? No? No? Okay. So failure to capture. Okay. Please aap bataiye, why do you think it's failure to capture?
Sir, in lead number and third QRS, there's no QRS. And there's no passing spike is there.
Okay. So sorry, मैं आपको यहीं interrupt करूँगा. Failure to capture?
And also it is like a failure to output. Means के आपने उसको बंद किया, जैसे आप बता रहे थे 3 to 4 times उसका ऊपर रखना होता है, तो ये भी हो सकता है failure to output.
ठीक. So pacing spike यहाँ पर आ रही है जहाँ पर आनी चाहिए थी?
नहीं आई है सर.
So इसका मतलब है हमने पेसमेकर की बोलती बंद कर दी किसी भी वजह से. अब या तो उसने कुछ सेंस ऐसे किया है कि जो उसको लगा कि ओ भाई मुझे तो आउटपुट नहीं देनी चाहिए, या कोई सर्किटरी के अंदर कोई प्रॉब्लम आई हुई है, ऐसा ही है. So probably the right answer in this situation, Dr. Saab, I would suggest would be probably failure to output. क्योंकि आपके पास pacing spike नहीं. यहाँ पर follow कर रहे हैं ये सारी चीजें. It's very important that you guys follow it. मैंने बहुत ज़्यादा details इस presentation के अंदर नहीं की है, but whatever I communicate, I would like you to take it away in a nice fashion and memorize this. So I hope ये चीज follow कर रहे हैं सारे. Failure to output है, it's not failure to capture. Okay, right. Under sense क्यों नहीं है वैसे? पहली स्लाइड में बता चुका हूं. So under sense का मतलब कि अगर वो सेंस नहीं कर रहा कि कोई नेटिव चीज आ रही है और वो कहता है मुझे तो बातें करनी चाहिए, मुझे तो I have to give a pacing spike at every step. So hence it's not under sense, right? Normal phenomenon already हम लोग कह चुके हैं, failure to capture बात हो चुकी हुई है. So sorry, it's just waiting for the transitions. As you can see, the pacing spikes आनी चाहिए थी, वहाँ पर एक arrow के ऊपर एक pacing spike आई थी. We've discussed this. इसकी जब interrogation वगैरह की है, तो what it was doing was it was oversensing some sort of artifacts and signals. So device interrogation बड़ी important हो जाती है. Whenever there is a malfunction, it's not only for the purpose of सिर्फ बैटरी कितनी है, उसके बहुत सी चेक्स हम लोग कर रहे हैं, जिसमें डिवाइस की परफॉर्मेंस चेक हो रही है, वो सी क्या कर रही है, वो रिकॉर्डिंग्स, क्योंकि it's a inbuilt halter in a way. It's giving you a lot of arrhythmia detections. So this patient had actually myoinhibition. इसके अंदर oversensing हो रही थी myoinhibitions की. Okay, I've been okay. मैं अब जरा कोशिश करता हूँ यहाँ पर मैं स्पीड करूँ, but very importantly again non-pacing spike, lack of spike आ जाए तो यानी कि failure of output हो जाए. It could be a pseudo malfunction. It could be one of the device's algorithms. It could be a oversensing issue, which could be, for example, crosstalks in dual chamber pacemakers. It could be due to the myopotentials वगैरह अगर आपकी जो oversense हो रही है उसकी वजह से. So oversensing, as you can see, is here. Then there are causes for oversensing: cardiac activities and then non-cardiac activities. Issues that can cause it. Lead problems themselves can actually lead to all of this. What about this next one? So it's a 56-year-old gentleman with dyspnea, pacemaker implanted. Interrogation showed a battery longevity at 7 years. Chest X-ray was normal. Rhythm strip was shown. मैंने इसमें जानबूझ के एक दो informations आपको नहीं दिए, लेकिन I would just want that these are the options. What do you think is happening over here? And precisely, we are just looking at this area. कि यहाँ पर मैं थोड़ी pattern break हो गया ना. So what do you think could be happening? Is there some sort of so यहाँ पर pacing spike आना चाहिए था और नहीं आया, ऐसा ही है? ऐसा नहीं है या पता नहीं? So how many would say कि जी यहाँ पर pacing spike आना चाहिए था? एक good. So अगर नहीं आ रहा, मैं क्योंकि ये फैसला हम लोग पहले कर लें कि ये अंडर सेंस करे या ओवर सेंस करे, क्या ख्याल? Please.
The pacemaker is working perfectly normal.
It's working perfectly normal. अच्छा, वजह?
So because we might have the hysteresis function in this pacemaker.
Sorry?
Hysteresis function in this pacemaker probably.
ठीक है, आप इसके अंदर समझती हैं कि हम लोगों को इसको कोई थोड़ी ऑप्टिमाइजेशन वगैरह की करने की ज़रूरत है? आई मीन अगर मैं ये कहूँ कि ये नॉर्मल काम कर रहा है तो यहाँ पर इसकी सेंसिंग, इसकी थ्रेशोल्ड्स, इसकी कैप्चर सारा कुछ ठीक ठाक है या आप कुछ थोड़ा सा ऑल्टर करना चाहेंगे यहाँ पर?
I don't think so.
Okay, everyone agrees? Okay, we have मेरे ख्याल में इधर आज इनको भी डॉक्टर साहब आप बताइए प्लीज।
I think it's working perfectly fine. If we see the shape of T wave before the missing spike, it's little different. Maybe there was some atrial activation which was sensed by the pacemaker.
आपके ख्याल में the pacemaker is seeing something extra जिसकी वजह से वो थोड़ा सा pause ले जाता है?
Yes.
Okay. And do you think should it normally be seeing this if this is a patient या उसको कोई हो सकता है कि थोड़े से कोई symptoms इसकी वजह से आना शुरू हो जाए? So I understand कि perfectly normal भी I've just realized it कि अगर मैंने आपसे सुना है तो I can consider it's a normal pacemaker function but it's not optimized in terms of its settings. Yeah, so it's something where it's oversensing.
Oversensing the T wave.
T wave, exactly. अगर आप ये देखें कि you strip it off, there is basically जहाँ पर T waves थी पिछली स्लाइड के ऊपर वो उसने oversense एक दो की और pause किया। आगे obviously एक QRS आया तो उसने उसको देख लिया। So obviously what would you want to do? Raise the bar for the sensitivity ताकि इन T waves को भी जो कोई premature अगर आ जाती हैं या कोई vector वगैरह change होता है because of body positioning या lead positioning, so इसको भी वो थोड़ी देर के लिए ignore कर दे। ठीक है जी, वरना otherwise T wave oversensing वगैरह होती जाएगी। Okay, I'm just going to go to, let me just check out a case. Just 5 minutes, okay. So, right, so 56-year-old dyspnea, dual chamber pacemaker. This is the rhythm strip. And what do you think of it?
First two QRSs, they are the dual chamber pacemaker, atrial pacing and sensing. And second, again, pacing and sensing, atrial ventricle. And the third, there is a atrial sensing, ventricular pacing and sensing. Again, and fourth, there are atrial and ventricular board sensing and pacing. So this is a pattern.
Okay, and so what do you think then? The options are there for you. So do you think there is the atrial lead is under sensing, do you think? So इसने atrial beat एक native आई है, इसने तो sense कर लिया है, इसने फिर pace तो नहीं किया उसको atria को, उसने ventricle को तो pace कर दिया। Okay, atrial lead loss of capture in normal sense. Does everyone agree? Yes,
Yes.
बहुत like हैं आप मेरे ख्याल में। Everyone agrees. That's good. नहीं. So Mashallah, I think you've chosen the right thing. So इसकी लेकिन important चीज़ ये है कि बाकी चीज़ें समझ में आ रही हैं कि atrial lead under sensing नहीं है, क्योंकि देखिए यहाँ पर इसने P wave को और अगली P wave को इसने correctly sense किया और sense करके इसने pacing spike नहीं दी है। ठीक है जी। दूसरी बात है कि atrial lead का loss of capture कहीं पर नजर आ रहा है, ये भी अगर मैं आपको कह दूं and take my word for it, I know it's a rhythm strip, लेकिन यहाँ पर आपके पास एक basically अगर एक pacing spike आई है तो इसके बाद एक atrial depolarization भी आई है, P wave आई है आपके पास, और ये सारों पे इसी तरह से जा रही है, तो loss of capture तो फिर ना हुआ। ठीक है जी। अगर under sensing का कोई, so anyway option B एक साइड पे एकदम आउट हो जाती है। आपके पास जब option C है, so atrial lead का loss of capture There is a subtle difference over here. यहाँ पर एक loss of capture आ जाता है, और otherwise sensing is otherwise normal. क्योंकि उस वक्त वो जब sense करता है तो वो देखता है कि हाँ भाई मुझे चुप हो जाना चाहिए। ठीक है जी। So this is something that you need to understand. Again, it's just the same thing. I'll just quickly go through the next one. इसमें मैं एक स्लाइड पे स्किप करना चाहता हूँ, सॉरी इसको स्किप कैसे करते हैं, sorry, just going to very quickly go to one slide क्योंकि I just wanted to show you, this is very important actually. Sorry, Ji. So 82-year-old, unattended, brought in with pre-syncope. Sorry about the size of the ECG strip. I'm just going to give you the options. Undersensing, oversensing, more information required, failure to output. मैं कुछ नहीं और बोलूँगा. So 82-year-old male, unattended है, कभी बार आ जाते हैं with pre-syncope. ECG strip छोटी है, तो इसमें क्या कोई अंडरसेंसिंग हो रही है, ओवरसेंसिंग हो रही है, फेलियर टू आउटपुट हो रही है, या सर हमें थोड़ी सी इंफॉर्मेशन और दे दें. इसमें पेसमेकर कौन सा डला हुआ है? डला हुआ भी है कि नहीं? ठीक है, क्यों? मैं ऐसे फ्री में नहीं देता इंफॉर्मेशन. व्हाट्स द रीजन एंड लॉजिक बिहाइंड इट?
More information.
ओके, चलो मैं थोड़ी सी दे देता हूँ इंफॉर्मेशन, ले लो. These are the limb leads. So my question, the patient has a pacemaker or not? वो वैसे ही बाबा जी थे, वो गिर गए थे, उनको तो कोई मसला नहीं हुआ था, ऐसे ही गिरे. इनको अब बल्कि अब पेसमेकर डालना है हम लोगों ने. बाज़ बात क्या होता है, आपके फिजिकली पेशेंट के पास नहीं होता है, आपका कॉलीग आता है, कहता है यार ये एक पेशेंट की ECG आई हुई है, तो यार ये रिदम स्ट्रिप है, ये पकड़ लो इस चीज को. More information required. This is important now. जब भी ECG आप इंटरप्रेट करो, always ask for a 12 lead ECG. बहुत दफा वरना पता ही नहीं चलता कि पेसमेकर क्या. और I know we are all pushed for work and time. The message I'm wanting to put across is always read a 12 lead ECG, not on its own, but with a history as well. ठीक है, ये हिस्ट्री और क्लिनिकल सिनेरियो बहुत जरूरी होता है. एंड ऑब्वियसली जितनी इंफॉर्मेशन आप एक्सट्रैक्ट कर सकते हो, इसकी आदत में आओ आप लोग. सो बेस्ड अपॉन व्हाट यू हैव नाउ, व्हाट डू यू थिंक इज द प्रॉब्लम? इन चार के अलावा भी बता सकते हो मुझे. डू यू थिंक देयर इज कैप्चर? फेलियर टू कैप्चर हो रहा है. ठीक है, फेलियर टू कैप्चर हो रहा है, फेलियर टू सेंस भी हो रहा है यहाँ पर. या हम बोल नहीं सकते वो वाली चीज, क्योंकि आपकी जो सबसे इंपॉर्टेंट चीज है यहाँ पर देखें, इसमें आपको पेसिंग स्पाइक्स नहीं एक्चुअली नजर आ रहे. ये होती कंटिग्यूअसली ECGs हैं, एट द सेम टाइम ये सारी ECGs हो रही होती हैं. सो यहाँ पर बंदा कहता है ओ सर यहाँ पर तो बेसिकली यहाँ पर तो सेंसिंग ही नहीं हो रही, यहाँ पर इसको फायर करना चाहिए था. तो लेकिन एक्चुअली प्रॉब्लम क्या है, यहाँ पर तो हमें कहीं पर भी नहीं, इवन हद तक यहाँ पर भी नहीं नजर आ रहा. So basically there is failure to capture. So essentially the message over here was failure to capture. And see a 12 lead ECG. Important चीज क्या है, तीन चार चीजें ही होती हैं. So one, there is undersensing. Basically you're seeing the device is not seeing something and it's firing. You see extra spikes when you should not be seeing it. If there is oversense, you should be seeing a spike, but you don't actually see it because the device is actually sensing something else. Failure to output, you basically don't get a pacing spike at all, and you obviously have the appropriate information available कि एक device डली हुई है और उसको करना चाहिए. इसका मतलब है कि उसमें कोई problem आ रही है. If there is failure to capture, there is a spike, but there is no local depolarization, whether it's of the atria or whether it's of the ventricle. So with this, I would just like to conclude my presentation. The whole purpose was just to sensitize, and I hope अब थोड़ा सा आसानी होगी. Thank you.
Thank you, Dr. Talha, for this excellent talk. And thank you, Dr. Zahid Jamal, as well. Thanks a lot, sir. So for the next talk, the three panelists will be Professor Dr. Harun Aziz Baba from National Medical University, Dr. Abdul Ghaffar Maiman from LUMS, and Dr. Sayyida Saira Bukhari, Assistant Professor Cardiology, Khan University. The next talk is on the management of syncope, and for the talk I'd like to invite Dr. Amir Hamid Khan. He is the professor of medicine in the section of cardiology at Khan University and service line chief.
नहीं उसने ये वाला देना था मुझे। Okay, thank you. Sorry for this. I'm going to talk about the evaluation of syncope as per the guidelines that were issued in 2018. It's a very vast subject. There are varied guidelines, multiple views. So I'm going to give you the kind of spin that I think is needed in this subject. One of my mentors used to say, if you know syncope, then you know quite a lot of medicine. So it's a tough subject. So I have nothing to disclose. And so syncope is a sudden, brief, and transient loss of consciousness caused by cerebral hypoperfusion. So it is important that you lose blood flow to the brain, and that is the cause for you to faint. Now, this is my most famous quote that I often use. The difference between syncope and sudden death is that in one, you wake up. So it's an ominous condition. So I'll start with a case. This is a real case of that I recently dealt with. He's a 55, but I've been following him for about 3 years. It's a 54-year-old man, seizure witnessed and taped, recurrent syncope unheralded with no prodrome, once following an anger episode, and it had a short recovery time, would recover within a few minutes. And he experienced jerking of the body, and this was noted on video, which was taken by his daughter, who was very vigilant. He is a diabetic and hypertensive. His ECG shows a left bundle branch, uncomplicated left bundle branch block, which means there's no left axis deviation. And the coronary artery disease, for the coronary artery disease, he had an angiogram done for these problems and had non-obstructive lesion in the OM1, and subsequently had a myocardial perfusion scan to assess that, and did not show any ischemia. Outside our facility, he had 2 serial echoes done over a period of time, and it states that the ejection fraction was 35%, but he had about 3 echoes at our center, and each one was showing 55% ejection fraction. He only had atypical septal motion because of the left bundle branch block. So when he came to me, he was a difficult diagnosis, and I was kind of looking at whether he had neurocardiogenic syncope. So I got a head-up tilt test done. And I'm looking at a group of people who have negative head-up tilt tests, but still tend to have vagal syncopes. 3, and out of which 1 was a double provoked. So we gave double the nitrate dose that is recommended, but nothing happened. So as I said, his MPS was normal, his EF, gated EMF was also normal. So we got 2 ways of assessing his LV function. His Holter was done repeatedly, and we could not pick up anything about 3 Holters were also done. And he continued to have transient loss of consciousness. So we got this newer Holter. We don't still have it, but on a trial basis, and they were very kind enough to lend it to me, and I applied it. So the first time we went for 17 days and we did not pick up anything. But he had pre-syncopal symptoms, but there was the noise in the device and we could not pick up. And then the second time we went for about 6 days and we picked something up. Now, this is with permission of the patient. So the device should be the other way around. So we were kind of putting it wrong. So this is the Holter device, which will give you ECG. You can keep it for 4 weeks. You can charge it like the mobile phone. On one stretch, I think it goes 7 days. And then you can take a bath with it as well. So it's a good thing to have. And this is the event on the 4th of September at 6 o'clock. 10 minutes past 6, this was his rhythm. And then he complained of symptoms, and then he went into this rhythm. So you can clearly see that there is no sinus slowing, there's no RR variation, and suddenly there is an AV block. And if you can appreciate the lower part, the AV block goes on and on. So over here you see PP intervals, and in the second strip you see that the PPs pick up. That means the patient is not liking it, has become hypotensive. And you're seeing myoclonic jerks over here, which are coming through as an artifact. And this is a bigger myoclonic jerk. So I have a video of him as well, but I did not have permission for that, so I cannot display it over here. It was very classic. And these are the people we tend to put on anti-epileptic drugs. So blood pressure and loss of consciousness. So even if we cut down the blood supply to the brain for about 6 to 8 seconds, you tend to experience loss of consciousness. And this is whenever the blood pressure at the heart level goes to 50-60 systolic, it supplies about 30 to 45 millimeters of mercury to the brain. Humans are the only animals who tend to have syncope. Animals have cardiogenic syncope. Neurocardiogenic syncope only humans do. Animals tend to freeze, and that's Stotzel's reflex. They freeze because they want to show the enemy that they're dead or they're not there. So that kind of syncope, there are sheep that have been noted to have this, but humans tend to fall. And the reason, if you can look over here, is that we have a lot of difference between the heart level and the brain. So we have to use a lot of anti-gravity maneuvers. So what is syncope is a clinical syndrome in which transient loss of consciousness is caused by a period of inadequate cerebral nutrient flow, most often the result of an abrupt drop of systemic blood pressure. And typically this is short, 8 to 10 seconds, and recovers spontaneously. So if this was so simple, why are we talking about it? We are talking about it because syncope has, again, it's a hybrid animal. 45% are neurocardiogenic syncopes, and they have the lowest or practically no mortality associated with them. Then you have cardiogenic syncope and orthostasis and neurogenic syncope. Cardiogenic syncope and neurogenic syncope have significant mortality, so cardiogenic having the most. And orthostasis you see at a young age with POTS, and in the older age when you're on polypharmacy and you have other issues going along on as well. 15 to 20% still remain undiagnosed. That is why it is very important that we follow guidelines. And this is David Bendit and John Ewan, their paper stating that if we follow algorithms, we can be cost effective and we can have more diagnostic yield. So the 2018 guidelines have looked at this, and they have said that you should do prolonged monitoring, as we did in our patient, and that will have a higher yield. You use more sleep studies, video assisted sleep studies. And then for syncope management, you should have an area which should have people experienced enough. The same principle that you have used for CCUs. CCU gives you a mortality benefit because you have trained staff who can pick up ST elevation MI, lethal arrhythmias, and have a shock box to give therapy. Likewise, syncope units should be there with experienced personnel so that they can help. So this is the evaluation part of the guidelines, which I'm talking about today. So transient loss of consciousness can be non-traumatic, or it can be due to trauma. And the non-traumatic is what we are talking about, and they're divided into syncope, epileptic seizures, psychogenic, and then there are rare causes like subarachnoid hemorrhage or vertebrobasilar transient ischemic attack. I will borrow this slide from David Bendit's 2020 presentation, and he has divided it into more simply into transient loss of consciousness related to trauma, that is concussion, and not true loss of consciousness like psychogenic syncope, drop attacks or cataplexy. I'll explain what all that is. And the rest is all in the midline, syncope, seizure, and our quest is to differentiate between neurocardiogenic syncope and epileptic seizures or seizure disorders. This is what happens in pseudosyncope. Pseudosyncope, nothing happens to the hemodynamics. The patient will faint, but on a head-up tilt test, your heart rate, your blood pressure will remain the same, whereas in syncope or neurocardiogenic syncope, you'll have paradoxical bradycardia. The heart rate will go down and the blood pressure will go down. And that's classic because you don't get this kind of situation anywhere else. Secondly, so what is drop attacks? These are sudden spontaneous falls while standing or walking with complete recovery in seconds and minutes. There is usually no recognized loss of consciousness and the event is remembered. So that is a major difference. It's a symptom, not a diagnosis, and it can have diverse causes. And Sheldon was the first to describe this in his series. Cataplexy, again, is a sudden loss of voluntary muscle tone triggered by a strong emotion such as laughter. Cataplexy occurs during waking hours. During a mild attack, there may be a barely visible weakness in a muscle like a eye twitching or something. So this is loss of muscle, not loss of consciousness. So but this will fall in the differential when the patient is presented to you with history of fall. Now, if we look at the loss of, so you take a history and then you divide them into the categories that we've talked about. So if this is transient loss of consciousness is non-syncopal, that is, you've not lost consciousness, as in neurocardiogenic syncope, it could be epileptic seizure, psychogenic, you give them specific treatments. But if the syncope is neurocardiogenic, your initial evaluation depends on history, physical examination, ECG, and a postural blood pressure. These are 4 vital things that should never be missed. The highest yield in the emergency department is that of postural drop check, which is about 66%. So then risk stratify, and I'll talk about risk stratification through history, physical exam, past history. And the message is we have to differentiate between, once we have taken out the neurogenic syncope, we have to differentiate between syncope, that is neurocardiogenic, and seizure activity, and rule out cardiac. So if there are high risk features, early evaluation and treatment is required. So you admit the patient. If they are low risk and the episode is single or rare occurrence, then you can explain and no further follow-up is required. In between, if it's low risk but recurrent, then we can do tests outside as an outpatient and then follow. And what are the tests to do? As I've said, ECG part is forms part of the physical examination. So it is not a test, it is part of the examination. Echocardiogram is the most vital test because if your LV function is down versus normal LV function, there is significant mortality associated with that. You can do a carotid sinus massage in patients who are more than 40 years of age, and you do a head-up tilt test to rule out neurocardiogenic syncope and to study orthostasis. Because once you tilt the patient, if they are orthostatic, they will show early orthostasis versus late. In old age, if you keep making the person stand, then they keep dropping blood pressure till they become symptomatic, and the heart rate will go up, but will stop compensating at some point in time. And then you have the routine blood tests in which hemoglobin is very important. They should not be anemic. They should not be losing volume. So of all the tests that we do specifically for in electrophysiology, the yields are given on the right side. And if you see, the maximum yield is of implantable or implantable cardiac monitors. And I have shown you the example of Reveal. This is very small and you don't need an electrophysiologist to implant it. It is on a syringe. You can actually inject it under the skin. Just a generation before we were implanting these. And so you can do that. It can stay in for 3 years and it can pick up quite a lot. But rest of the tests, Holter monitor is 24 or 48 hours or 72 hours max. These are the conventional Holters that we're talking about. But the one that I've shown you will probably change the outcomes for Holter also. Our own yield at the Aga Khan University is about 4.1% for Holter monitoring. So for diagnostic evaluation, there is good evidence. This is guideline chart. I don't want you to be overwhelmed. And I was sitting at the end of the hall and I could not read. So I will not, so I'll show you a better slide. So reflex syncope, long history of recurrent syncope, especially particularly before the age of 40. That would favor neurocardiogenic syncope. After unpleasant sight, sound, smell, or pain, prolonged standing, during meals, And these are classic features. Being in crowded or hot places, autonomic activation, so they become pale. They will give you the feeling, the sweating, nausea, vomiting. You can vomit before you go down, and you can also vomit after you get up. So the history should be very, very clear about this. And with head rotation, like I am feeling tight over here, if I rotate my head, carotid sinus stimulation, I can go down. And absence of heart disease, that's very, very important. This will favor reflex mediated syncope. Now, we were taught as students that you cannot have vagal syncope while you're lying down, but most of the interventionalists sitting over here know that when we play with the groin, you can actually make a patient syncopal while they're even lying flat. So there's an entity called supine syncope, and we have a paper in Qrs written a few years back, in 2018 actually, where we have published a data of 6 or 7 patients who had supine syncope. So if someone says that, you know, they have bad nightmares, and the partner says that their breathing becomes difficult and, you know, labored, and they feel that if something is happening or they're fitting, this is something to be picked up. If you go on the net, you will find out that there are people, groups of people who are talking about this supine syncope. So it's not an uncommon thing. So we need to change our thought process that supine syncope can also rarely happen. In our group, all these people had positive head up tilt tests. So, but only few had upright syncope. Similarly, orthostatic hypertension, it's while standing, it's prolonged standing can cause that, standing after an exertion, postprandial hypotension, and there is a temporal relationship with the start or change of dosage of drugs that they take, and especially in the elderly, and a presence of autonomic neuropathy. Someone who's Parkinsonian comes in, orthostasis is something that you should be thinking. These are clear issues over here. Now, remember that once we exercise, we pool blood, and orthostasis or neurocardiogenic syncope can trigger in once you stop abruptly. But if you faint while you are exerting, then it is ominous. But once you stop and not cool down, so we always say warm up and cool down. It is to make sure that this does not happen. It's more common than we think. Similarly, cardiac syncope during exertion or when supine, sudden onset palpitation, immediately followed by syncope, family history of unexplained sudden death, and presence of structural heart disease. So that's why echo is very, very important. And rest ECG findings, I will not go into the details, and you can't read it over here, but a good thing has been, a lot of things have been said about the ECGs, the high risk features, so I won't repeat them. So mostly cardiac syncope is arrhythmic. It can be structural also, but you will see rarely aortic stenosis going down without announcing itself. But arrhythmic, you can go down without announcing, just like the person I showed you, he's only 54 years old, and he's got a bad AV block, which is symptomatic. Similarly, there are high risk and low risk features, and you can look at the guidelines, they're very, very clear about it. I am just asking you to pay attention to the high risk features, and the major high risk feature would be new onset of chest discomfort, syncope during exertion, sudden onset palpitation, immediately followed by syncope. Everything that is pointing towards cardiogenic syncope. Neurocardiogenic syncope does not have mortality associated. Morbidity, yes. So similarly, minor conditions can be no morning symptoms or short duration, family history of sudden cardiac death at young age, and syncope in a sitting position. However, neurocardiogenic syncope can also happen in a sitting position, but then they give telltale signs. These come in groups. So someone sitting starts sweating, feels that something is going to happen, ghabrat, a little epigastric pain, and then they, usually while eating, their face will go into the plate. And for neurocardiogenic syncope, so you have to be Sherlock Holmes. Ask them, how do you fall? Or witnessed account. And they'll tell you when they go down, they cannot brace themselves. So their hands will be back, they will hit their foreheads, they will have raccoon eyes, head injuries. Generally, if a conscious person falls, he or she will brace and will get fractures of the forearms. So see where the injury has happened. So this is very, very important. So naturally it takes time. That is why it is not easy. Similarly, past medical history, if you have any history past of coronary stenting, surgery, structural heart disease, that's very, very important. And similarly for physical examination, if you have unexplained systolic blood pressure of less than 90, or it can suggest, or any suggestion that you're volume losing. So postural drop again tells you, that's why it has a high yield. That if in the ER you come and you have resting tachycardia, slight sweat, normalish low BPs, and then you make them sit up and they drop 30, 40, do a rectal examination. They may be losing blood in the gut. It's very common. Half of the world is on aspirin. And what we don't realize is aspirin makes us bleed as well. So for ECGs, again, if you have left bundle branch block, high degree AV blocks, all the things that we've talked about for the pacing indications, if you see with a history of syncope, it's important. Okay, so if you have syncope, you've evaluated it's low risk, you can discharge. If it's high risk, you need to send them to a specialized unit or area or a consultant who deals with it. It can be a cardiologist or an electrophysiologist. Generally, these people end up with neurologists, and neurologists get to get a lot of tests done with very low yield. So 5% of these patients, out of 105 patients should be going to the neurologist. Rest should be going to a cardiologist, but that doesn't happen because when you faint, people think it's mirgi ka daura hai. And for the rest, if you are neither high or low risk, should not be discharged from the ER. You should be investigated in a specific unit and followed up. So if you're experienced or you send someone to an experienced person, there's a 50% chance that with a good history and one additional test, they will be able to pick up the diagnosis. So history is very important. And sometimes suspected approximately 30% of the time, the initial evaluation may help clinicians and you may need to do additional tests. But what is more concerning is that 20% of the times you will not be able to pick up. And if you take 100 and out of 100, you are losing 20 patients without a diagnosis, that's dangerous. So the presence of heart disease is an independent predictor of cardiac cause of syncope with a high sensitivity and a moderate specificity. So the absence of heart disease excludes a cardiac cause. Now, as I said, the question is between syncope and neurocardiogenic syncope. Seizure and neurocardiogenic syncope. And so there are multiple features. I'm going to show you a graph over here. This is someone who had a neurocardiogenic syncope. So if you see the ECG over here, and if you can follow my cursor, there is asystole. And if you see there is progressive slowing and increased amplitude, this is the EEG up top. So it's not that they're not getting, so they're getting abnormal waves. And then there's a tachycardia comes back, but blood pressure remains low because they work in tandem. And then you get significant changes in the EEG. Now, if someone is doing an EEG on these patients, they can be labeled as epileptic and can be treated for at least 2 years. And I've noticed that if you take all the people on anti-epileptics, about 8 to 9% people will have neurocardiogenic syncope and would be wrongly treated. So asystole of 3 to 6 seconds doesn't do much, despite the fact that we are putting in pacemakers. It doesn't do much. It phases you out. You know, thoda sa shayad unclear thinking ho jaye. You may not be able to answer a Viva question, but it doesn't. So 7 to 13 asystole will bring these theta and delta waves. So there has to be a neurologist over here to comment on that. But when the asystole is longer, 10 to 14 minutes, then the myoclonic jerks come in, and that's where the problem is. That's where we lose our patients to the neurologist. So we have to be very, very clear. History will tell you whether the seizure is tonic, clonic. You should know how they fall. When the neurocardiogenic syncope patient falls, he falls like this, slowly. A seizure patient will be forced down because of the muscular spasm. So witness account is very important, and you have to be Sherlock Holmes actually. These are the features given over here. And what they state here is very correct. Seizure is nearly as common as or half as common as neurocardiogenic syncope. So they will come together. This is the difficulty that we have. This was a patient, despite having a right bundle left axis, we could not symptom correlate her. And she was having pre-syncopal symptoms, and this is while she was admitted to the CCU, and we missed it even when she was admitted to the CCU bed. This is, हम बाद में खोल के देख रहे थे तो ये निकली उसमें, and मैंने अपने fellow से कहा, and you can see him in this reflection also, to take a picture of this. So it's difficult. So going back, and I'm now closing my talk, history is vital. Physical exam and postural drop is part. If you don't do a physical drop, it's a major omission. You may be face litigation in the US or in the Western countries. ECG is part of the examination. And I always say, when you're reading an ECG, look at the QT interval. It should be the first thing to read when you are seeing an ECG of a syncopal patient. And of course, the investigations, you have to follow an algorithm. Otherwise, you'll be all over the place, spending millions of rupees and still not reaching a diagnosis. So initial evaluation, as I said, could give you a yield of 50%. But neuroimaging has a low yield. So please, before you call in the neurologist, you must get your act together. This is from the 2017 family physician guidelines. And family physicians, I feel, operationally, they're very sound. So it states that so pre-syncope should be evaluated similarly to those who are having syncope. So it is just the extreme nature of syncope versus the initial milder form of pre-syncope. They can be the same. So please evaluate them correctly. And if they have high risk features, they should be admitted to the hospital, and patients presenting with syncope should have orthostatic blood pressure. It's a must. I'm ending. 10 minutes left. So abhi to bahut time hai. So patients with syncope who are at low risk of adverse outcomes may be safely followed up. So do not clutter the ER, do not hold them on the beds. They can, those who are low risk can go. Those who are high risk need to be admitted. Those who are intermediate risk can be assessed in a specialized clinic or by a person who can then give you a forward algorithmic approach. So risk reminder, remember that syncope has is associated with serious risk. Short-term mortality is low. It is 0.7% at 10 days and about 1.6 at 30 days. So you have time. But as the year goes, it goes up to 8.49%. And of these, 1/3 are cardiovascular. And these are not those cardiovascular जो आपको सामने नजर आ जाते हैं. These are the ones you're going to pick up through tests and through history. And 25% will recur in 2 years. So this is a significant recurrence rate. And so you make sure that you don't miss the serious ones. So this is Muhammad ibn Musa al-Khwarizmi, and I always put this whenever I'm using an algorithm, because it is his work that has given us an algorithmic approach. And across the world, algorithmic approaches, be it a hypertension guideline or STEMI guideline, have shown that they're cost effective, they're evidence-based, and they are clear. So my summary slide is the syncope is still the most challenging of most clinical diagnoses in cardiology or even in medicine. And history, no matter who says what, and when I say no matter who says what, I can be someone who has experience and I say, don't do this, don't listen to me, look at the data. And the data are suggestive that history is the most important. It picks up about 60% of patients for you, which is as good a yield as implantable devices. First account are the best. मैं हमेशा अपने students को कहता हूँ कि रेत में से जो पहली दफा चल के चला गया उसके निशान रह जाएंगे, बाकी सब उसके निशान पर चल के जाएंगे. So the first account is very, very vital. Do not destroy that. Sit and take a history. If I come into a unit and I ask कि आपने history ली थी खड़े होके बैठ के, और कोई कहता है खड़े होके history ली थी, I don't take them seriously, because you have to sit on a chair and take the history because it takes time. And your first account is going to be an account on which everyone else is going to depend. And you may have the right diagnosis for the patient. Neurocardiogenic is the most commonest. a form of syncope, but cardiogenic is the most serious. And the difference between the two is cardiogenic में unheralded होता है, जैसे हमारे उसको होता था, उसको पता नहीं चलता था. लेकिन sometimes neurocardiogenic भी अगर vasodepressor हो, it can be unheralded. वो एकदम उसका the vessels just give in and they plummet. And they don't realize. But बाद में जब head up tilt पे आप उन्हें डालते हैं तो they say नहीं थोड़ा थोड़ा मुझे पता चलता था लेकिन I was disregarding these symptoms. Cardiogenic में नहीं पता चलता, but both are short-lived. The difference between neurocardiogenic and neurogenic syncope is the post-ictal state. Neurogenic में अगर आपको grand mal seizure हो गया हुआ है तो defibrillate हो जाता है brain. By the time it recovers, it takes 20 minutes. But neurocardiogenic may be myoclonic jerks आएंगे, but they will recover in about 3 minutes or less. Follow an algorithmic approach. It has a higher yield and is cost effective. And I will leave you with a famous quote from my most famous personality, and that's Sherlock Holmes is, well, actually Sir Arthur Conan Doyle is, when you have eliminated the impossible, whatever remains, however improbable, must be the truth. And this is how we should be dealing with syncope. With this, I thank you if you have any questions. Brigadier Azmat.
तो आमिर आपको पता है हमारा और आपका हेड अप टिल्ट का ताल्लुक शायद 20 साल पुराना है, जब आप 20 साल तकरीबन मेरा ख्याल है, और उसके बाद से आप भी और हम भी को बहुत ही लंबी उम्र तक अभी भी प्रैक्टिस हो रही है. और प्रॉब्ली मैं हमारे मिलिट्री में जितने टिल्ट टेस्ट होते हैं मजबूरन मैंडेटरी, वो शायद बहुत कम जगहों पे होते हैं. Basically, a very good presentation. I'm always fascinated by this talk of syncope because there are still so many things जो कि हमें भी समझ नहीं है जिसकी. Number one, इस केस में आपने 3 दफा head up tilt test repeat किया. Did you change the protocol or why did you? So that's question 1 actually.
So yeah, a very good, excellent question actually. मुझसे मेरे residents, they have full permission to ask me this. पहली दफा किया, I was convinced at that time कि इसको neurocardiogenic हो रही है, we are missing something because nothing else was, इसका LV function was normal, point blank normal, and he did not have coronary artery disease. Well, had blocking but nothing. So दूसरे वाला जो किया था उसमें तो कुछ नहीं किया, and I was relying on the statistics कि इसकी specificity जो है 2 टेस्ट कराएंगे तो he may fall in the positive range, may be able to pick up the specificity. Sorry. जो तीसरा किया था उसको double provoke किया था. That was my own protocol which I could never write down, but we did a lot of tests on these patients. So you give double the dose and but tilt for another 20 minutes. पी गया, कुछ नहीं हुआ उसको. Then I was convinced that we are not up the right tree.
Okay. The reason I said this कि हमने सन 16-17 में ये tilt के दोनों प्रोटोकॉल ट्राई किए थे, uploaded front भी, Italian प्रोटोकॉल भी. तो anyway results खैर mixed ही थे. जो क्वेश्चन नंबर 2 है सर आपकी इजाजत से, वो ये है कि ये जो ऑर्थोस्टैटिक इसमें एंगल है वर्सेस द क्लासिक वेसोवेगल न्यूरो, इसकी मैनेजमेंट में आप क्या फर्क डालते हैं? और नंबर 3 अगर मौका मिले तो जो स्ट्रक्चरल हार्ट डिजीजेस हैं उसमें जब टिल्ट पॉजिटिव आ जाए तो आप किस तरफ जोर डालते हैं?
So पहला आसान सवाल है, जब अगर सिग्निफिकेंट स्ट्रक्चरल हो, बिकॉज सबसे बड़ा क्वेश्चन मेरा ये आज फ्लेकेनाइड पे भी बात हो रही थी सुबह, मैं थोड़ा सा डाइग्रेस कर रहा हूँ बिकॉज आई वाज इन द बैक एंड आई वाज सो फर्स्ट ऑफ ऑल वी हैव टू डिफाइन व्हाट स्ट्रक्चर. जैसे अब एमिएट केमिएट ट्रायल के बीच में स्कीमिया था, उन्होंने स्ट्रक्चरल कर दिया, स्ट्रक्चरल सारी दुनिया में चला दिया उन्होंने, एंड फ्लेकेनाइड वाज काइंड ऑफ नेवर स्टडीड एंड डिनाइड टू अ लॉट ऑफ पीपल. इट्स अ गुड ड्रग and we don't know how to use it because we've never practiced. So structural, let's say someone has severe aortic stenosis, first of all तो गलती से हो जाए head up tilt तो हो जाए, कराएंगे नहीं. So वहाँ neurocardiogenic syncope being neurocardiogenic response being very common in the population. A lot of times long QT वाले आ जाते हैं जिनकी typical neurocardiogenic history होती है. So I tilt them and I follow the long QT as per protocol, beta blockers और सारी चीजें, and ठीक हो जाता है. दूसरी चीज है जो वेजोडाइलेटर है वो हमें पिक करने में मुश्किल होता है, उसको खुद पिक करने में मुश्किल होता है बिकॉज वो प्रीमॉनिटरी सिम्टम्स उसको उतने अच्छे नहीं आते. लेकिन हेड अप टिल्ट टेस्ट हेल्प्स ओवर देयर बिकॉज देन दैट पर्सन फॉर द फर्स्ट टाइम रियलाइजेस कि उसके प्रीमॉनिटरी सिम्टम्स हैं क्या, एंड वो फिर जल्दी पिक कर लेता है. दूसरी चीज ये है कि जो counter maneuvers हैं, leg cross, muscle tense and hand grip का जो है, I have noticed and उन्होंने differentiate नहीं किया था. It works for both. So it has, I have never felt disadvantaged in treating someone who has a vasodepressive. Maybe others have different experience, but in my case, these maneuvers work at least for about 80% of people very well.
Not a question, Amir. Excellent and very comprehensive presentation. It's a difficult subject because this is one of the subjects which creates syncope to the physician also, you see. At times we are difficult to. Now, I think I just want to make a comment to share with you that what you said was very relevant. People switch from cardiologist to neurologist, sometime on their own, and sometimes because of our own fault that we have not gone through the battery of investigations. It reminds me of a patient which I saw in 1987 at Khan Hospital. This was a young gentleman brought from Hyderabad, labeled as epilepsy on anti-epileptic medications. And then we found that he was suffering from intermittent complete heart block. And he was given a pacemaker. So I think the point is very, very valid that we must exhaust our battery of investigations, go through the whole protocol before we hand over the patient to the neurologist or labeled as epilepsy. Because many people, many times, this is a confusion. And people just go to the neurologist, and once the patient goes to the neurologist, never comes back to us, unfortunately. So that's a problem. So I think we need to follow a protocol because syncope is a very common problem. It's not, I mean, and especially in the women folk, it's very common. So I think the need for a proper guideline or protocol to follow so that these patients are not missed, you see, because they keep on suffering from these symptoms for years and years. And the quality of life is very much interfered.
Few neurologists are now sending us patients because वो उन anti-epileptic दवाओं के ऊपर भी frequency जब change नहीं होती है, तो then they kind of start worrying. सर वो मैं वैसे ही शेयर कर लूं आपके साथ, FCPS में बड़े धक्के खा के पास हुआ था मैं कार्डियोलॉजी में, जो लास्ट वाला था आप लॉन्ग केस पे थे और syncope का पेशेंट था and he had a stent put in. So everyone was trying to push me towards the stenting and somehow because his syncope had always been my research interest, तो मैं उस पे जुड़ा रहा, तो that was इज्जत बच गई.
Dr. Amir, it was a excellent,
thank you, sir,
comprehensive, very elaborative talk on syncope, and especially as Professor Ishaq Khan and our friend Professor Hayat has mentioned, that it's a difficult topic. And still the cardiologists, I think, are not well in the grasp of this topic. So we need more information, more awareness, especially in cardiology community. I'm not talking about other doctors, especially in cardiology community, they are not much aware of the tests and the medications and all that. One thing I would like to ask you humbly, that you mentioned that HUT for the cardiogenic syncope is one of the tests of the choice. Like we have seen that it was one of the gold standards. But still it doesn't catch up the 100% people. It was, you mentioned some percentage.
67, 70, 80.
What is the reason? Is it due to some, the way you are doing it, or the drugs you are using it, or is there any other reason for it? Number two, I would just like to ask that what medications you use, especially in patients who are proved to have and this cardiogenic syncope, and what is the role of beta blockers in that?
Great. Excellent. So first, syncope should be a subject not for the electrophysiologist, but for the cardiologist, I think. We should have a clear guidelines and we should disseminate it through workshops. I believe that neurocardiogenic response is a normal body response. People have researched on this as well. There is no clear-cut randomized data to suggest that, but I feel अगर आपको syncope नहीं होती है, मैं आपको enough drugs according to an undiagnosed protocol पे दूं, तो मैं आपको भी बेहोश कर सकता हूँ ना head-up tilt test. जितना आप स्टीप करते जाते हैं टिल्ट को, उतना ज्यादा वो सेंसिटिव होता है, स्पेसिफिसिटी लूज करता है. इट्स अ काइंड ऑफ अ नॉर्मल रिस्पॉन्स ऑफ द बॉडी. हेड अप टिल्ट इसलिए नहीं होता क्योंकि people can compensate. A lot of times आप अगर हेड अप टिल्ट करा रहे हैं, नोट करें, लोग अपने पाँव मूव करते हैं, जैसे they move their feet like this even while they are standing on. So body में a lot of splanchnic circulation is there. वो अपनी abdomen को मसाज करते रहते हैं, सांस लंबा छोटा करके, तो उससे नहीं आप कर सकते. लेकिन पुराने जो प्रोटोकॉल्स होते थे उनके बीच में वो लिटा के रखते थे, फिर खड़ा करते थे, फिर आइसोप्रोटेरेनॉल से उनको करते थे. तो आई थिंक कि वी वर नेवर एबल टू आइडेंटिफाई द राइट काइंड ऑफ, हम उसको टाइम छोटा करते गए. अब हम 2020 पे 20 प्लेन टिल्ट करते हैं अकॉर्डिंग टू द इटालियन ब्रुगाडा प्रोटोकॉल, एंड उसके बाद 20 हम नाइट्रेट्स देते हैं. इससे पहले घंटा, ये जब की बात ये कर रहे हैं, वो घंटा लिटा के रखते थे, फिर घंटा वो करते थे. तो आई फील कि इसको ज्यादा स्टडी होना चाहिए, एंड it bails you out. It not only gives you a diagnosis, it gives you the response of the patient. जब आप उसको tilt करते हैं, lot of times आपको POTS नजर आ जाता है, बहुत सी दफा आपको orthostasis आ जाती है, delayed orthostasis आती है, and patient कहता है मेरे तो वही symptoms हैं. So it is not just limited for neurocardiogenic syncope. बहुत से और टेस्ट भी हैं जो हमने शायद सही तरीके से नहीं प्लान किए हुए, इसलिए उनकी सेंसिटिविटी स्पेसिफिसिटीज उतनी नहीं है अच्छी. और द लास्ट क्वेश्चन वाज अबाउट ड्रग्स. सो क्लियरली SSRIs हैव, अगर सबसे मुझे गिला सिंकोपी की स्टडीज में ये कि चूंकि पैसे उसमें ज्यादा नहीं होते, तो लार्ज रैंडमाइज्ड कंट्रोल ट्रायल्स नहीं है. ऑब्जर्वेशनल स्टडीज में छोटी रैंडमाइज्ड कंट्रोल ट्रायल्स हैं. तो उसके बीच में जो SSRIs का सबसे अच्छा डेटा है, बीटा ब्लॉकर इज अ न्यूट्रल थिंग, उसका कोई पॉजिटिव नहीं है. मीडोड्रीन जो है अल्फा एगनिस्ट वगैरह वो दिए गए हैं, उसका भी डेटा बहुत स्ट्रांग नहीं है, बिकॉज अ नॉर्मल बॉडी टेंड्स टू कॉम्पनसेट. हाँ, उनमें जिनमें ऑर्थोस्टेसिस हो रही है, देयर इज गुड डेटा ऑफ ड्रॉक्सीडोपा, उसका डेटा है, बट देन अगेन वो न्यूरोकार्डियोजेनिक में नहीं, ऑर्थोस्टेसिस में. But they sometimes overlap. तो जो overlapping symptoms vasodilatory होते हैं, maybe intuitively उस पे help हो मिल जाए, लेकिन I don't have evidence of that. तो drug therapy नहीं, जो ये leg cross muscle tense and जो hand grip maneuvers हैं, जो पेपर है, बड़ा फेमस पेपर है मिशेल ब्रेनोला वगैरह के ग्रुप से, उसका भी मैं बता दूं आपको. अभी मैं गाइडलाइंस देख रहा था. When I was a fellow in 2000, I had to make a presentation in cardiology update. तो मिशेल ब्रेनोला का मुझसे नाम प्रोनाउंस नहीं हो रहा था, तो मैंने उसको ईमेल कर दिया. मैंने कहा हाउ डू यू प्रोनाउंस योर नेम? कहता डोंट वरी, प्रोनाउंस इट एनी वे यू लाइक. और उसने मुझे 26 पेपर भेज दिए उसके ऊपर. उस जमाने में ही वाज चेयरमैन ऑफ द यूरोपियन सोसाइटी ऑफ कार्डियोलॉजी के ग्रुप का. वो आज भी चेयरमैन है सोसाइटी के ग्रुप पर. 20 साल तो उसको 20-21 साल हो गए. So they have still stood the test of time, and they're still leading. So European guidelines, I would suggest, are much better than the American guidelines. American guidelines में बहुत ज़्यादा caveats हैं. तो drug therapy नहीं है. These maneuvers work really well. अच्छा, दूसरी चीज ये है, there are papers that have shown कि अगर आप repeated tilts करें, तो आपकी न्यूरोकार्डियोजेनिक सिंकोपल एपिसोड्स की फ्रीक्वेंसी गिर जाती है, गायब भी हो जाते हैं. And sometimes इनके बायमोडल वेरिएशंस हैं. इट्स अ थेरेप्यूटिक, उसको साइंटिफिकली प्रूव नहीं कर सके. उन्होंने टिल्ट करके मनूवर्स कराए हैं, लेकिन कुछ भी आप नहीं करें, अगर एक पेशेंट को सिंकोपी हो रही है, उसको 4-5 दफा टिल्ट कराएं, तो उसकी टिल्ट वो गायब हो जाएगी. दिस पीपल हैव नोटिस्ड, एंड दिस हैज काइंड ऑफ कंफ्यूज्ड अस कि ये इसका मैकेनिज्म क्या है. नहीं, मैं वही तो कह रहा हूं. Medicine is driven by money. Money comes through certain organizations, and that is channeled into procedures. This is pure clinical medicine.
चूंकि इसमें बड़ा वास्ट एक्सपीरियंस है, तो आमिर की शायद नॉलेज में है. हम लोग अगेन मिलिट्री की तरफ रेफर करूंगा, क्योंकि उसको फिर फिट भी करना होता है, फिट फॉर द सर्विस. तो वैसे तो इसकी एक ऑर्थोस्टैटिक ट्रेनिंग है, जो कि क्लास 2A बेसिकली है, लेकिन मैं पिछले 20-21 साल से ना इसको क्लास 1 के तौर पे ले रहा हूँ. और इनको जबरदस्ती, या जैसे आप कह सकते हैं कि ऑर्डर देके 3 महीने के लिए ऑर्थोस्टैटिक ट्रेनिंग कराता हूँ with plenty of fluids. जी सर, local experience है, but as I said, Amir will bear me out that this is actually class 2A. But what I have seen is in local circumstances में over the last 20-21 years, 99% ये लोग fit हो जाते हैं. Their tilt comes negative क्योंकि हम उनको repeat भी करते हैं.
हाँ, उसमें थोड़ा सा एक पॉइंट ये कि आपका बहुत ही इनके जो टिल्स, इनकी बहुत सिनकपी होती है फौजियों में. मैंने जो मेरी पहली तस्वीर है वो देखें, उसमें भी फौजी लेटा हुआ है. सो बिकॉज दे आर सो फिजिकली फिट, तो उनका थोड़ा सा रिस्पॉन्स वर्सेस द मिडिल एज जो बाय मॉडल 50 इयर्स की एज में खातून बेहोश हो रही है, उससे थोड़ा सा फर्क है. लेकिन ही इज गॉट अ पॉइंट. टिल्ट ट्रेनिंग एंड हाइड्रेशन, आई थिंक हाइड्रेशन इज वेरी वेरी इंपॉर्टेंट. हम 1 कप चाय का पीते हैं तो हमें 4 कप पानी के पीने चाहिए जो हम नहीं पीते. सो बाय एंड लार्ज एज अ नेशन वी आर डिहाइड्रेटेड.
मुझे आपकी बात से एक याद आई कि इसका शायद कोई प्लेसिबो इफेक्ट भी होता होगा. या ऐसे ही है, जैसे पेशेंट दे डू कम आफ्टर कोरोनरी एंजियोग्राम हैविंग अ 3 वेसल डिजीज और कहते हैं एंजियोग्राफी का मैं तो ठीक हो गया हूँ, आई एम डूइंग वेल, मुझे तो कुछ मसला ही नहीं.
ये बहुत आपने अच्छी बात की. देयर इज अ वेरी वेल एस्टैब्लिश्ड प्लेसिबो इफेक्ट ऑफ दिस. जी
नहीं, वो ब्रिगेडियर साहब ने जो कहा वो तो प्लेसिबो नहीं है.
हाँ, नहीं
वो जनरली वो अजमत से फायदा उठाते हुए कोई एलिवेशन का भी इफेक्ट होता है. मतलब पीपल
इसका
posted as सियाचिन and other.
अजमत सियाचिन का तो जवाब देंगे. इसका सीजनल वेरिएशन है एक्चुअली. यहाँ डॉक्टर बजिया बैठी हुई है. डॉक्टर बजिया बैठी हुई है. शी यूज्ड टू बी अ स्टूडेंट एट AKU at that time and she collected data with me and वो कल ही में मुझे देखने को मिला. उसमें सीजनल वेरिएशन है और वो होता है.
ये सॉरी, मैं अगर आपकी इजाजत हो, असल में आमिर की बात से ये सच कह रहे हैं. ये जो यंगर एज ग्रुप है ना सर, इनको तो वो खड़े होने वाली एक्सरसाइज कराता हूँ मैं, और उसका सबूत ये कि द सेम प्रोटोकॉल, द सेम स्टैंडर्ड, द टेस्ट कम्स नेगेटिव, इंक्लूडिंग कि मुझे फ्लायर्स को भी फिट करना पड़ता है आपके इल्म में. तो ये आमिर का पॉइंट वैलिड है कि ये जो एडवांस एज के लोग होते हैं उनके लिए थोड़ा सी मुश्किलात होती हैं. तो आमिर से मेरा क्वेश्चन एक्चुअली यही था. मेरे ख्याल में जो एडवांस एज के हैं उनमें ऑर्थोस्टैटिक एंगल ज्यादा होता है बनिस्बत ये क्लासिक हमारे इसके. वो ऑर्थोस्टैटिक वाले को ट्रीट करना थोड़ा सा मुश्किल होता है. बट आई डोंट नो आमिर का क्या तजुर्बा है, लेकिन अगर आपको यंग मिले बंदा, यंगर बंदा बंदी जो भी उसको आप ग्रुप दे, उसको ये खड़े होने वाली एक्सरसाइज की प्रैक्टिस करवाएं. एक तो उनको एहसास हो जाएगा इस बात का कि अच्छा ये प्रॉब्लम एक्चुअली है, रादर देन टेलिंग देम. एक्चुअली जन सुहेल सर बड़े शौक से बात करते थे. वो ये मेरे साथ डिबेट होती थी, तो वो कहते थे नहीं, जब आप गिरने की पोजीशन आने लगे तो आप ये कर लें, हाथ ऐसे क्लिंच कर लें, टांगे ऐसे कर लें और ये बचत हो जाएगी. तो आई वुड से कि नहीं सर, उस वक्त तक पता नहीं बंदे को मौका मिलता भी है कि नहीं, तो आप प्रिवेंटिव के तौर पे ये
वो मैं आपको बताऊं, ये इसका बड़ा. So I was presenting this data of supine syncope लाहौर में, PIC डार साहब की कॉन्फ्रेंस थी. वहां प्रोफेसर मसूद अख्तर आए हुए थे. तो उन्होंने ये सवाल पूछा कि भाई इसका क्या करोगे, ये तो इसको तो तुम लिटा भी नहीं सकते, टांगे भी ऊपर नहीं कर सकते. सो अ पेशेंट ऑफ माइन जिसके मियाँ को सुपाइन सिनकोपी होती थी लेटे हुए, वो क्या करती थी, उसकी टांगे पकड़ के फोल्ड कर देती थी ऑन हिज चेस्ट एंड ही यूज्ड टू कम आउट. तो मैंने उन्हें कहा जी मुझे ये नहीं पता, कोई स्टडी नहीं है, लेकिन मेरी मरीज की बीवी जो है वो ये करती है, उससे होता है. प्रॉब्ली स्प्लैंक्लिंग सर्कुलेशन जो है उसको हम अंडर रेट करते हैं, हम पेरिफेरल सर्कुलेशन को वो करते हैं. अच्छा, दूसरी बात ये ड्राइविंग के दौरान भी हो सकता है. अभी मेरे पास एक लड़का आया, उसको ये न्यूरोकार्डियोजेनिक ड्राइविंग के दौरान ही कार इज टोटल, पता काट के निकाला उसको कार में से, होते हुए हो सकता है. एक्सरसाइज के दौरान नहीं हो सकता, रुकने पर होगा. Yes.
Once you hear about automatic working, you should not assume that you are talking about seizure now. So that's, I think, thank you for relaying that message. My question to you, and I feel that during practice and during taking a history, we realized that syncope is actually multifactorial. And I'd like you to comment on that because it's a milieu and an environment which provokes a known mechanism.
Yes, 100%. It's excellent question. So a lot of neurocardiogenic syncopes can be triggered by your antihypertensive therapy. अगर आप अपने ब्लड प्रेशर को गिराते जाएंगे, और if you are taking drugs which are causing tachycardia, पंप्स इनहेलर्स, तो वो भी ट्रिगर कर देते हैं। तो ये अगेन एज आई सेड बैट की हिस्ट्री लेना जरूरी है और टाइम लगता है इसके ऊपर। एंड हाँ, दूसरी चीज ये है कि मैं अक्सर ये सवाल करता हूँ कि हाउ वुड यू डिफरेंशिएट ऑन हिस्ट्री बिटवीन सीजर एंड न्यूरोकार्डियोजेनिक सिंकपी। तो लोग कहते हैं टंग बाइट हो जाती है, यूरिन निकल जाता है, यूरिन सब में निकलता है। द ओनली डिफरेंस दैट हैज क्लिनिकली बीन स्टडीड इज पोस्ट इक्टल स्टेट, कि आप ग्रामाल सीजर के बाद फेज आउट हो जाते हैं और आपको 20 मिनट बाद उठते हैं और आपको कुछ पता नहीं होता। न्यूरोकार्डियोजेनिक सिंकपी में जब इवन बिफोर योर आईज ओपन you start hearing noise sounds and when you wake up you have a tunnel vision, आहिस्ता आहिस्ता आपकी अपर्चर खुलता है और लाइट आती है। मन मैं तो मनूवर लगा के कर रहा हूँ। चलें, थैंक यू सर। हाँ, थैंक यू।
So we The third of the panelists will be Professor Dr. Azam Shafkat. He is the head of department, cardiac electrophysiology in NICVD Karachi. So the next talk is on inherited arrhythmias, diagnosis, management, and referrals for genetics. It will be presented by Dr. Mawson, who has recently joined the NICVD as a pediatric cardiologist. I just had a humble request to all the participants that from now on we'll be strictly following the rule of only 2 questions per presentation. And if you have further questions, you can talk to the presenters in the tea time.
So, Assalamu alaikum and good afternoon, everyone. Thank you for giving me this opportunity to present on this forum and conference. So today I'm going to talk about inherited arrhythmias, diagnosis and management. I'm Mohsen, as Dr. Taha mentioned. I'm currently joined NICVD as a pediatric electrophysiologist. Before starting is a huge topic. I will try to cover some of the important aspects and try to emphasize what practical points are important when we are evaluating patients with the inherited arrhythmias. So starting from the background, why it's important to talk about this inherited arrhythmia syndromes or sudden cardiac death. In the pediatric populations, as well as in adolescents and young adults, it is a very devastating event. You hear a lot that younger patients died suddenly without having any comos or previous illness. There are few very known personnels who expired suddenly. As I remember, Arfa Karim, Microsoft certified young girl, died suddenly with a seizure. I don't know whether her family ever screened for those inherited arrhythmia. If any of you was following the Euro Cup 2 months back, there was a very well-known footballer, Danish player, Christian Eriksen, fall suddenly on the field while playing, and he has a sudden cardiac arrest. Luckily, he was saved by the bystander there, his teammates, and saved his life. So when we compare to the adult population, sudden cardiac death in younger population is most often caused by the structural heart disease or some primary rhythmogenic disorders. In adult population, there is a bit high burden of coronary artery disease and ischemic heart disease. But in younger population and pediatric patients, the burden of ischemic heart disease is not that much. And most of the time, when we deal with the sudden cardiac death or any symptoms that are suggestive of inherited arrhythmias, it's mostly because of the structural heart diseases or any inherited arrhythmia syndromes. So most of those syndromes, when we talk about, and most of us know a lot of a lot of things about those syndromes are basically the channelopathies, ion channel dysfunctions, which is usually not detected when we do a conventional autopsy after having someone evaluated for sudden cardiac death. So there are a lot of syndromes. I will talk about the most common ones, including long QT, CPVT, and Brugada syndrome. The other ones are rare, like short QT and early repolarization syndrome, but the most burden we see, or at least I see in pediatric populations, are long QT, CPVT, and Brugadas. So why it's important to diagnose those patients? It's not only the index patient for whom we are talking about or for whom we are trying to make the diagnosis. It's all about the whole family, and especially the consanguinity in our scenario. It's very high in our culture, and these diseases go generations over generations. And whenever we found an index patient, it's an opportunity to identify those pathogenic mutation in the family. And because many of those who have the pathogenic mutation does not have any phenotype or does not have any sudden cardiac event or any syncope or seizure all of their life. But if we found someone in the family, because most of those disorders are inherited by autosomal dominant, and there is a 50% chance that they can transmit to their next generations. So it's very important to properly identify them, screen them, and then make the diagnosis. What's the difficulty in diagnosis? The most difficult thing is most of these changes which we try to see in the ECG is dynamic changes. Like at times you do the ECG and you found the QT interval of 480 or 490 millisecond. And at other time when you check the ECG or do a ECG, it was completely normal, 440 millisecond. So these changes are dynamic when someone sent for the evaluation. And if you say, oh, ECG is normal or the QTC is normal, it does not mean he does not have a risk of inherited arrhythmia or long QT syndrome specifically. The other problem is there is not much of data available when we try to see some index patient, especially when we try to see some patient who has a sudden cardiac arrest or sudden cardiac death. Most of the time there is no ECG available, or if the ECG was done ever, it was not with the family because there is no medical record system in our society. So so when we start the evaluation, as Dr. Amir Hamid very nicely present the syncope presentation. So for whom we start the evaluation, it is very important because when we say the syncope is a sign of inherited arrhythmia syndrome, many of our colleague electrophysiologists got a lot of consultations for benign syncope or vasovagal syncope. So whenever you do any test, even a complete blood count, the pretest probability is very important, that that make you realize that it's some dangerous thing that you are dealing with. So before doing a comprehensive testing, there should be a very high pretest probability for diagnosis of those arrhythmias. So what are the symptoms that make you realize that this patient or any specific patient can have some inherited arrhythmia? Is number one is the syncope, and I will not go into details of the type of syncope, as Dr. Amir Hamid nicely present that what kind of syncope should make you realize that it could be cardiogenic. And then there are seizures which are unexplainable. One point, as I am also getting the consultation from the neurologist, most of the time by the reason they started the anti-epileptics and the seizures are not responding. So then they think that they should be evaluated by some cardiologist. The other signs are sustained and non-sustained, VT or VFib, and then the family history of sudden cardiac death. So this part is very important for our society, that family history of sudden cardiac death, especially younger patients less than 30 years of age. If they have any comorbs, then they should be evaluated for those inherited arrhythmias. So what are the tools from which we start usually is a baseline ECG. We start with that. And if you look at this ECG, it's look like life is very easy. You clearly see a very long, prolonged QT interval in this ECG and some T-wave alternates. So if you found this ECG, you are a very lucky person, and it's easy to diagnose those congenital arrhythmias or inherited arrhythmias. But most of the times we are not that lucky, and we got a different kind of ECGs. So in this ECG, I think most of participants here are from the cardiology, and then they realize that the QT interval is very prolonged, and there are some T-wave changes that you can appreciate. It's changing its shape. So it's T-wave alternates, and it's a high-risk feature. So that's easy. And when we look at the long QT guidelines diagnosis, so if QTC interval is more than 500 in 2 different occasions, and there is no other risk factor for acquired long QT syndrome, then it's diagnostic. The reason I'm showing this is most of the times we get confused what the exact or what the ideal number at which we should call the long QT syndrome, either it's 460, 470, or 480. So I think the right number on which you can diagnose is the 500 on 2 different ECGs. Below that, anything is the pretest, is the other symptoms that make you help in diagnosis. So this is the difficult ECG. Now, if you look at this, most of the people, most of the cardiologists, our colleagues, see it very casually and say, oh, the QT interval is less than half of our 2-hour interval, and it's not prolonged. So it's a very crude method, and we should not, even at least as a cardiologist, we should not do that. The other problem with this kind of ECG is if I give it to the participants here, everyone will measure it differently. So someone say it's 440 milliseconds, someone will say 460, someone will say 480. So the other important thing is to measure it correctly. So I measured it 468, might be some other people measure it differently. So the important thing that is a practical aspect is where is the end of the T waves. And there's one study I found. They try to see how accurately the physicians, the emerged physicians and the cardiologists measure the QT interval. And the observation was that the majority of physicians cannot recognize a long QT when they see one because they are either take it very casually or not measuring it properly. So the first step is to measure the QT interval properly before commenting on that. So what is the best way of measuring it? It's the tangent method. Ideally, you should look at the lead 2 or V5 and measure it there. If the T waves are not ideal in V2 and V5, you can measure in other leads, but ideal are lead 2 and V5. And then you have to draw isoelectric line from PR or TP segment from one to other, and then make a tangent from the downslope of the T wave. And the point where it's intersect, you measure the Q to T interval and then calculate it. So this is the ideal way. It should not be eyeballing. It should not be just marking the end of the T wave and comment on that, because it has very serious implications. If you say someone that he has long QT interval, you are telling them they have risk of sudden cardiac death. So it should not be a very casual method of measuring that. So then for the definition, the other diagnostic criteria for diagnosing long QT syndrome is this Short's criteria. And I want to spend some time on this. So if you look at the number one thing is giving the scores for the QT intervals. It says if it's more than 480 milliseconds, it's score 3, and 460 to 480 is score 2, and 450 onward is score 1. So what does that mean? So it's again the other symptoms you have to plug in the equation. So if the score is more than 3.5, it's a high probability of diagnosing long QT syndrome. So what I tell my juniors is think it like that. You got a ECG, you got the QT interval of 460 milliseconds, and he has no other symptoms. He has no T-wave alternates. He has no syncope, either stress or without stress, and no family history. completely asymptomatic patient. So he got the score of 2 and he fall into the borderline criteria. But if you see a patient of same QTC interval of 465 millisecond, and he has a syncope with the stress, then score goes to 4.5. So then he's a diagnostic score for the long QT syndrome. So keeping in everything in equation is very important. It's not just a QTC interval on which you rely. You have to keep in everything along with it. So that's a very well and renowned statement from Peter Schartz, who says, I don't measure the QT interval, I look at it. And most of the electrophysiologists like that statement a lot. So what does that mean? So whenever you look at the QT interval, you are talking about the repolarization, and the repolarization is abnormal in those patients, and as well as the T-wave morphology is different. So the most 3 types of long QT syndrome, long QT 1, 2, and 3 have certain types of T-wave morphology that is being defined in those syndromes. Like type 1 has the broad base T-waves, in type 2 there is a biphasic T-waves, and in type 3 there's a late peaking T-waves. So whenever you are evaluating a patient of long QT syndrome, it's not only measuring the QT interval, but also look at the T-waves as well and get the sense how it's look like. And during training, I got the sense that at least my supervisors or my mentors always look at the T-waves very precisely and always stress on that. So provocative test, okay, I will try to be fast. So provocative test, ETT, we do whenever we have a high suspicion of long QT syndrome. Usually the long QT1 patients have early QT prolongation in early recovery, and for long QT2 patients, they have QTC prolongation in the late recovery. And then the adult guys could do a lot of epinephrine QT stress tests as well. In pediatrics, we didn't do that much. So that's a very busy slide, and I will go into the treatment options. So number 1 thing is the lifestyle modification, and we should stress on that. So we immediately jump on the medication part, but the lifestyle changes is very important. Avoidance of QT prolonging medications is very important. Identifications of other acquired causes of long QT like electrolyte abnormalities is very important. So this is the part from where you start. And then the beta blockers, they have a role in long QT syndrome. There's a bit of discussion who should be treated, either symptomatic or asymptomatic patient, but usually we put all of them on the beta blockers if they have the long QT syndrome. And then the left cardiac sympathetic denervation, ICD implantation, and then the sodium channel blockers, especially mexiletine has a role in long QT3, and we use it in other types, especially in type 2 as well. And it's usually shorten the QT interval for more than 40 millisecond, especially in those patients whose QT is more than 500 millisecond, then you can start a trial of mexiletine and see if it's work or not. So for beta blockers, there are different triggers for different types of long QT. QT1 is usually provoked by swimming or exercise, 2 is by loud sounds, and 3 is usually during sleep. And every type of long QT has some effect of beta blocker, usually more in those who are associated with tachycardia or more like type 1 long QT syndrome. And when we talk about the type of beta blockers, usually nadolol and propranolol are recommended. The other beta blockers does not show much efficacy, but unfortunately we does not have nadolol here. So our colleagues does use a bisoprolol and other beta blockers as well. So other treatment modalities has potassium supplementation in long QT type 2, mexiletine for type 3, also used in type 2. Permanent atrial pacing has some role, and then mutation-specific treatment start coming, especially ranolazine and flecainide has shows some promise. So I will move to the next syndrome, and if you look at this, a very typical ECG for what you see is J-point elevation in lead V1. And what is this? So it's the first time Brugada brothers define it as right bundle branch block, persistent ST segment elevation, and sudden cardiac death. And they present around two families, total of 8 members. Usually adult guys and most of the pediatricians also think that this is a disease of the adult, but we see quite much of Brogadas in younger population as well. The presentation is a bit different. And when we look into the first report of those Brogada brothers, out of 8 patients, 3 were younger patients less than 2 years of age. So for Brugada syndrome, usually type 1 morphology, and what is type 1 morphology is the cove-shaped ST elevation in right precordial leads, more than 2 millimeter in one or more than 1 precordial leads. So the other thing is here is mentioned is position in the second, third, or fourth intercostal space. So what is this? So this is a high lead ECG or Brugada ECG we do. So what we do, we put these leads into the higher place, V1, V2, V3, V4, and V5, V6 in the second, third, and fourth intercostal space. And if you do that ECG and you found the type 1 morphology is again a diagnostic for Brugada. So just a clinical score that's been published a few years back, and that predicts the lethal event in young Brugada syndrome less than 19 years of age. And then they identify the syncope, spontaneous type 1 ECG, sinus node dysfunction, and atrial tachycardias and conduction abnormalities as a risk factor. This is not an ideal score, just the reason to show here is many of those Brugada patients present in younger age with the atrial tachycardias or sinus node dysfunction or conduction abnormalities. So you should have to keep in mind that they can have a Brugada in later years or changes. So this is the risk stratification score. What does that mean? Why very high risk patients are more than usually above 6 score. So for provocative test for Brugada, usually the sodium channel blockers, every institution has different protocols. People use procainamide, ajmaline, and flecainide. We does not have procainamide here. Ajmaline is being available in Aga Khan University, and we do flecainide as well sometimes. The other important thing, especially in pediatric population, is to get the ECG during fever episode, because fever can provoke those Brugada changes. So again, when we talk about the management, the number one thing is the lifestyle changes, avoidance of those drugs that can make the Brugada changes, and then alcohol intake should be avoided. ICD implantation for cardiac arrest patients and who have the sustained VT. Then quinidine has the role especially in those patients who present with storm, VT storm or VF storm. And then in the acute situation, isoprel infusion can be used to suppress rhythmic storm in Brugada patients, because most of those Brugada patients have VT or VF episodes during bradycardia. So isoprel has the role. And then the catheter ablation is being famous more and more, especially in European countries. So the last syndrome I want to discuss here is CPVT or catecholamine polymorphic ventricular tachycardia. It's a rare channelopathy, but it's not very rare in younger population. We see quite much of that. So what does it mean is they usually have a structurally normal heart, normal resting ECG. If you see in this upper pane, the ECG is completely normal, no abnormality. But when you stress them, either with the exercise stress test or epinephrine, they start having polymorphic VT or polymorph PVCs. So how you diagnose? The patient should have a structurally normal heart, normal ECG, and unexplained exercise or catecholamine induced by directional VT or polymorphic PVCs. So this is diagnostic for CPVT. And again, provocation tests for those patients are either ETT or epinephrine challenge test. So again, the stress is you don't want to do provocation test for everyone. It's the index of suspicion that make you do those tests. And how you treat them, again, the lifestyle changes, especially competitive and strenuous exercises should be avoided. Beta blockers are the mainstay of treatment for those patients. Usually you have to push really hard. How you monitor that the beta blocker is effective was the effective dose. It's either 1 mg per kg or 2 mg per kg. What I do is I repeat the stress test on while patient is on beta blocker and look at the maximum heart rate. If there's suboptimal heart rate response, then we can push the treatment more. Beta blockers I talked about, and then there is a flecainide role in CPVT and a subtle class 2A indication, especially if patients are not responding to the beta blocker. Again, left cardiac sympathetic denervation can be considered, but it has own perks. It has some side effects as well. Interestingly, ICD implantation is still in the treatment algorithm, but we try our best to avoid those because when you put ICD in those patients with the CPVT, they usually go into the VF storm because every time they receive the shock, they have a very high catecholamine release and sympathetic stimulation, and they got back-to-back shocks from the device. So we try to avoid as much as we can. And why we use flecainide in those CPVT, because it's block the rhodine receptors, who has the role in calcium channels, and stop its release. So this is a very handy algorithm of treating acute treatment of those ventricular arrhythmias, which are suspected to be inherited arrhythmia related. So when you have someone with a VF or torsades or a VT, so how should you go? So assess QT interval and mode of onset and T-wave morphology. So if the QT interval is prolonged, then you have to get the sense that it's either congenital QT syndrome or acquired long QT. So if it's a congenital QT, you should start with the beta blocker. Sometimes patients become very bradycardic with the beta blocker, then there is a role of pacing to push the beta blocker hard. But if there is a causes acquired long QT syndrome, then the treatment is usually transvenous pacing and make the heart rate fast with the isopril. As we go on to the other arm of this algorithm, if the QTC interval is normal, then you have to look for the initiating PVC, either it's short coupled or late coupled PVC. So if it's a short coupled, you start with the isopril and then go to the quinidine, but it's a late coupled PVC that start the VF episode, then you go with the beta blocker, amiodarone, lidocaine, and procainamide. So the last part of my presentation is genetics. It's a very well-known genetics effect on these inherited arrhythmias. The problem is when we start with the inherited, with the genetics. So if you see the evaluation of sudden cardiac death, there is a recommendation that from the postmortem or autopsy, you should take some samples for the genetic testing, but that is not true for the alive patients. So starting with the genetic testing is reckless and dangerous, because when you order a genetic testing, you should know the phenotype first, and then you order for the genotype, because many of those mutations does have many phenotypes, like SCN5A, a very well-known mutation, does have the Brugada, does have long QT, does have other dilated cardiomyopathy phenotype as well. So it's very dangerous to start with the genotype. You should know the phenotype first and go to the genotype. And if you see a normal algorithm, how the workflow of the inherited arrhythmia clinics work, you realize that start with the patient screening, then you do the evaluation, clinical evaluation, and you make a phenotype sense, and then you order the genetic testing. It's the last part. And the reason of getting the genetic testing is because it can help in evaluating the family members for a cascade screening. Now there's a evolving role of gene-specific treatment, like flecainide in some types of long QT type 3, same for ranolazine. So that's where the genetics has importance as well. So it has importance, but should not be started first. So that's how I stop, and that's all from my side.
Thank you, Dr. Mohsin. That was such a nice speech. Due to shortage of time, we will avoid further questions. So, okay. Dr. Babar has one question. Okay.
I think shortage of time to have questions allowed. Let's think, okay, this is important. So one question that I have for you, Mohsin, is that frequently you will get a consult from the neonatal ICU. So you have a kid who has a relative bradycardia, baby who's born and has a QTC of 470. So आपने एक महीने बाद बुलाया, repeat किया 470. कोई family history sudden death की नहीं है. What's the role of genetic testing in that kid? That's one. The second, a family member comes to you, repeated IUDs, say intrauterine deaths, repeated जो है वो बच्चा पैदा हो के and sudden deaths हो रही हैं. उसमें role of genetic testing in a child who has come to you with a normal ECG now.
Okay, so next question. So for the first part, we know for the neonates, the QTC intervals are prolonged at the time of birth, and they usually take 2 weeks to come to the baseline. So what I do is wait for the 2 weeks, repeat the ECG, got the sense, either it's normalized or not. And then the other thing is evaluation of the family is important. So if there is any red alert sign, some history of family, sudden cardiac death or seizures or syncope, then I will go for the evaluation, further testing. But if everything is normal, I will keep following for a year with the ECG, not doing that much of investigation, because then we have to realize the cost factor as well. The other thing is important is usually the patient who have cardiac events with these long QT syndromes are usually who has QTC interval more than 500 milliseconds. So usually if it's fall in the 460, 470 limit, you are not talking about a risk of sudden cardiac death usually. So evaluating them repeatedly again and again, I think is enough. And once they reach the age of 5 or 6 years, then I will go for the exercise test to be make sure how it do in the recovery. For the intrauterine deaths, the yield of genetic testing is even lower, because there is a lot of reasons for the SIDS. And if you look at the sudden infant death syndrome as compared to the sudden unexplained death in a bit older patients, the probability of getting inherited in older patients is around 20%. But when you talk about the infants, it's coming to 7 to 8%. So again, I'm not very proactive for just sending just genetics and getting some variant of unknown significance, and then you become screwed. The last month we got a patient of CPVT. The mutation, she has 3 mutations, and all of those mutations for cardiac hypertrophic and dilated cardiomyopathy. But whole family has phenotype of CPVT. So what does that mean? We are still learning about those genetics. And it's a very evolving field. So hopefully in next 5-10 years, we have much more clear answers for those mutations.
What is the gender difference in terms of the prevalence in sudden cardiac death in long QT syndrome?
Okay, so usually it's autosomal dominant. So for inheritance, there is no gender difference. For the types of long QT syndrome, yes, there is a difference. Like long QT syndrome are more common in old age women, especially postpartum and after the birth of the baby, they have high risk of going into those cardiac events. Similarly, like for Brugada syndrome, the males are more prone for those cardiac events because there is a sense that testosterone has some level in provoking those events. So specifically only type 2 has a female predominance for sudden cardiac death or sudden cardiac events. Otherwise, there is not much difference of gender.
What is the role of the ischemia in long QT syndrome?
Ischemia?
Yes.
So ischemia is the reason of acquired long QT syndrome, and we are talking here about the congenital long QT syndrome. So whenever you'll see a QT syndrome, you first thing you should rule out the acquired causes of long QT syndrome, and ischemia is one of the cause. Okay. Thank you.
Thank you, Dr. Mehsa, and thank you all the panelists. Okay, so our next talk is going to be on arrhythmogenic cardiomyopathy by Dr. Yawar Saeed. And for that, I would like to welcome new panelists. So I would like to welcome Dr. Ashraf Dar, Professor of Cardiology and Electrophysiology. I would like to welcome Dr. Mansoor Ahmed, Professor of Cardiology at Dr. Ziauddin Hospital. And I would like to welcome Dr. Kashif, the Assistant Professor of Liaquat University Hospital, Hyderabad. Thank you.
Assalamu alaikum, everyone. We are having live entertainment as well in the background, so that will help. So, musical presentation, yes. So let's, without further ado, we'll start. So, arrhythmogenic cardiomyopathy, it's actually works very well with the previous talk that Mohsen was doing. So inherited cardiac conditions, the one part of it is, as you have all read, is the inherited cardiac channelopathies, long QT, Brugada. And the next one obviously is inherited cardiomyopathies. And one part of it, which obviously concerns the electrophysiologist more, is arrhythmogenic cardiomyopathy. And what's new? So previously we heard about arrhythmogenic right ventricular cardiomyopathy, but that entity is now being broadened in the 2019 Heart Rhythm Society's guideline. So let's start. So let's start with the case. So this is somebody who comes to us in the clinic, a 27-year-old patient with this ECG. So what anyone could see when you start with it. So a 27-year-old, no valvular abnormalities. I'll just tell you from the start and presented with this. So as you can see that this is the very interesting ECG in which you see a bigeminal pattern together with background atrial fibrillation. And this is very rare to see in a young individual. And couple this with non-sustained tachycardia, a non-sustained ventricular tachycardia, which we found in this patient in the Holter monitor, and a left ventricular ejection fraction of 35%. So the question is, how would you manage such a case? What medications will help? Whether you're going to start patients on beta blocker and ACE inhibitor, whether you are going to consider antiarrhythmics versus ablation if these patients continues to have ventricular tachycardia. What about ICD implantation, family history, genetic testing? So this is where obviously the understanding of an arrhythmogenic cardiomyopathy comes in. So arrhythmogenic cardiomyopathy now is being broadened into a disorder of the myocardium, not secondary to ischemic, hypertensive, or valvular heart disease. So it includes the genetic cardiomyopathies that obviously we thought about arrhythmogenic right ventricular and now arrhythmogenic left ventricular as well. Inflammatory disorders, and also the infectious etiology. So primarily, previously, when we look at inherited cardiac conditions, and the cardiomyopathy that's involved in inherited cardiac conditions are these: the hypertrophic cardiomyopathy, and then the dilated cardiomyopathy, and the various mechanisms that leads to dilated cardiomyopathy. And one of it is definitely genetic. And then arrhythmogenic right ventricular cardiomyopathy, you can see the left ventricular non-compaction as well. So primarily, I think the important question here, if there is ventricular dysfunction, is arrhythmia as the clinical presentation? If the patient does not have an arrhythmia in the clinical presentation and patients have a normal sinus rhythm with no atrial fibrillation, no VT, no escape capture by Gemini, then patients does not have ACM. And then you can think of other acquired conditions and cardiomyopathies, which obviously have been detailed here. But if an arrhythmia is the clinical presentation, then yes, then this patient, then you will go down this route of arrhythmogenic cardiomyopathy and think of, is there another systemic disorders present? And these are the systemic disorders that you can see. So primarily sarcoidosis, myocarditis, viral myocarditis, And the other causes of myocarditis, Chagas disease, obviously we don't see it in this part of the world. And then obviously the amyloidosis. So clinical evaluation is primarily similar as with everything, clinical history, physical examination, you do a detailed family history, and all these patients should have a 12 lead in ECG with echo and ambulatory ECG monitoring. An important addition with now cardiac MR is getting increasingly available in Pakistan is to, and these patients should undergo cardiac MRI scans. So if you see an arrhythmia on clinical presentation, the patient has got cardiomyopathy, don't straight away go for a coronary angiogram. So I think that's important distinction that I would like to say here. So if it's an arrhythmia on clinical presentation and it's a young individual who is presenting to you with arrhythmia and cardiomyopathy, don't always think that this is an ischemic cardiomyopathy and have to rule out the ischemic cardiomyopathy here. Because these patients may have underlying myocarditis, these patients may have, so these patients should have initial investigations which are primarily non-invasive for us to understand what are the causes of this cardiomyopathy, and CMR gives you a very valuable data here as well. Okay. Then obviously we have to consider the genetic and non-genetic causes, looking for echocardic and structural abnormalities. And an important aspect here is to assess the arrhythmic risk of sudden cardiac death. That what are the risks of this patient having a sudden cardiac death or a syncopal episode due to arrhythmia. And then obviously we go for third generation pedigree. Now, whenever we talk about the 3-generation pedigree in an arrhythmic cardiomyopathy, arrhythmogenic cardiomyopathy, this is a primary, the way, and it's not difficult, I mean, anyone can do it. Once you do it about 3 or 4 times, you can understand and easily make a 3-generation pedigree, primarily looking for the patient which is at risk. We call it proband, just like here, the affective individuals, and then you go 1 generation up, okay, ask for the similar generation, and then obviously the children's of the and the 3rd generation. So this is primarily the pedigree. So just affective individuals represented like this, which is a dark one. Obviously here it's a male, but obviously if it's a female, it becomes dark, and then you point it, and then so it's easy to do it. And then once you make a genetic pedigree, then you identify that if these individuals have normal cardiovascular investigations or arrhythmogenic cardiomyopathy findings. And then you go for whether there's a familial variant or no familial variant. But if you don't identify a familial variant, please continue and looking for ongoing evaluation. So I think the important thing in these individuals that have seen a genetic counselor or an appropriately experienced clinicians to do their evaluation. That's important, and that's I think we would like to promote. Then in big tertiary centers, we should have inherited cardiac conditions clinics, in which these patients should be referred to and evaluated thoroughly and provided the best treatment possible. So the 3 things, obviously, as you say, that this NHRS guidelines, this is the class 1 indications, that clinical evaluation in somebody with arrhythmogenic cardiomyopathy, then obviously their family to undergo clinical evaluation, and then the cardiovascular evaluation. Now we comes to obviously the specifics of patients, how to diagnose arrhythmogenic cardiomyopathy in these individuals. So in ARVC diagnosis, the patient's presentation is either primarily syncope or exercise-related palpitations, and on occasions, obviously, they are survivors of sudden cardiac arrest. If they have obviously ventricular premature beats that you find in a Holter or a presentation of a VT of left bundle morphology, and then obviously it should alert your mind about arrhythmogenic right ventricular cardiomyopathy. Now we are talking about the specific one of the diagnoses of arrhythmogenic cardiomyopathy. So this is a modified task force criteria for arrhythmogenic right ventricular cardiomyopathy. It's very detailed. I just summarize it. And primarily they look for two major or one major or two minor criteria. You must be understanding what is this two major or minor criteria. And this is why this is very detailed. And if you search this modified task force criteria for arrhythmogenic right ventricular cardiomyopathy, then you can obviously look into major and minor criteria. We look for specific features to start with. This is just to understand what's really happened in arrhythmogenic cardiomyopathy. So above the cartoon, which shows you the cellular structures which has been affected during arrhythmogenic cardiomyopathy. This is the immunohistochemical pictures that you can see here, that NCAD-headed molecules becomes as compared to no ARVC, in ARVCs becomes less, and then the PK plakoglobulin or PKP that we call it becomes much less here. So it's the structural disintegrity that we see in cardiomyopathies, which is obviously then it results in the cardiac MRI findings. So if you concentrate on the lower image here, this is the left ventricle, and this is the right ventricle where you see fibrosis, right RV aneurysm, and dilatation of the right ventricle and the right ventricular outflow tract. But primarily, this is a very good slide. It tells you from the cellular structure down to the cardiac MRI features of arrhythmogenic cardiomyopathy. I'll just quickly go past this. So what we see in arrhythmogenic right ventricular cardiomyopathy in an ECG. And I think the first thing to consider is deep anterior T wave inversions that we see from V1 to V3 and very sometimes up down to V4 as well. So you can see here there is deep T wave inversions from V1 to V3 in ARVC. And then this little epsilon wave that you can see here, more easily maybe seen here, a little squiggle just at the end of the QRS, but separated from the QRS, representative of abnormal. This is a minor criteria. So this is the ECG in ARVC. Remember T-wave inversions, which are the most commonly seen, and then this epsilon wave, this little squiggle at the just after the end of the QRS. The other important thing is prolonged terminal duration that has been not recent, about 5 years ago, has been identified. The prolonged terminal activation duration, we call it TAD. So it starts from the nadir of the S wave to just where the QRS end. And if it's more than 55 milliseconds in any of from V1 to V3, in the absence of complete right bundle branch block, then it's considered as a minor criteria. So ARVC we obviously looked at the T-wave inversions, we looked at the epsilon wave, and then there is another one which I think we should be aware of, to how to identify these individuals. Any patients with T-wave inversions also look for these from V1 to V3. Then finally we have these signal average DCG criteria and the presence of late potentials in the signal and average DCG. And there are 3 criteria which can look at. This actually gives you how to measure it, the prolonged terminal activation duration of more than 55 milliseconds here. So here, obviously, you can see the epsilon wave, and then here you can identify the prolonged terminal activation duration of more than 55 milliseconds in these patients, which gives you an idea that these patients may have ARVC. So this is just to show you the T-wave inversions that we see in patients with arrhythmogenic right ventricular cardiomyopathy. And these are the ventricular ectopics. Sometimes they are in bigeminal pattern, and you can see them that like we are here, but they are primarily from the RVs. Very rarely they are found in the right ventricular outflow tract, but primarily from the main right ventricular body. So, so that's how I see it. So genotype and phenotype is this. So if you look at the genotype, these are the abnormalities that we see in arrhythmogenic right ventricular cardiomyopathy. And these are the clinical features that we see in patients with arrhythmogenic cardiomyopathy. So in ARVC, you will see changes in ARVC, LVC here in skin abnormalities. And then conduction system disease, I think that's very important, that if you see conduction system abnormalities in a young individuals which are not explained by simple age-related fibrosis that we normally see. So conduction system disease in somebody, so this is suggestive of cellular dystrophy. Then obviously ventricular arrhythmias, especially in somebody who has a normal left ventricular function on an echo. So that's why sometimes they have this presenting features and then later on develop LV dysfunction. So the conduction system disease with Brugada syndrome, this is more common in SCN5A. So this picture is more commonly seen in patients with the SCN5A mutations and sudden death. So you can see that these patients can present in multiple settings, but I think the important distinction is if it's the arrhythmia is the clinical presentation, and then look at the ECG features. So this is again a busy slide, but it's just to tell you that ventricular dysfunction in arrhythmogenic cardiomyopathy, which is not due to systemic disorders, can affect both right and left ventricles, and it could be either, and it depends on which part of the cellular structure it's affecting. And if one of the cellular structure is affected, obviously, then the right ventricle is usually the one which is affected. But however, if another part, which is sarcomere, ion channel, mitochondria, cytoskeleton is affected in these genetic variants, then you most likely see a left ventricular cardiomyopathy rather than only right ventricular cardiomyopathy. Okay, so just to give you a brief description of genetic testing. So this is the classification which underscores what is the likelihood of pathogenicity. And this is being described by American Genetic Association. So as Mohsin was saying, that it should not be the first test. You first identify the phenotype. So as we are going along in this presentation, that we are first looking at the clinical history, which is extremely important. Then you diagnose these patients have a particular form of arrhythmogenic cardiomyopathy, and then you go on for these genetic testing, and these are these different 5 classes, which class 5 being the pathogenic, which class 1 is the benign with variant of uncertain significance. And there are different types of genetic testing which is available. Single gene testing, in which you just test for single gene, not routinely available at the moment. The next generation sequencing, or NGS, is primarily more which is available. And we'll do a cardiomyopathy and arrhythmia panel in these. And later on, it may be that the whole exome sequencing and whole genome sequencing becomes available as well. So we'll just go through with this. So genetic testing in ARVC and arrhythmogenic left ventricular cardiomyopathy, I think, is the class 1 indication. Once you diagnose the phenotype, then it's very important to do genetic testing in these individuals to identify what disease type it is. And then you can then do a family screening for these individuals to identify those individuals at risk. Then finally, how do you decide this patient for an ICD? What are the things that you could consider? And the decision for ICD is obviously simple if patient is a survivor of cardiac arrest. However, the problem comes when the patient is not a survivor of cardiac arrest, and then you have to identify those individuals which can have implantable cardioverter and defibrillator. So If they don't have hemodynamically tolerated or sustained VT, then these patients with these mutations, FLNC, Lemon, and ACM. So here, the genetic testing is actually making you decide which patient should have an ICD. So this is new, because obviously we don't do this before. The genetic testing did not inform our decisions about patient management, except that the family cascade screening. But especially in arrhythmogenic cardiomyopathy, if the patients have Fasciculum mutations, or the patient with Lemon AC mutations with LVF of less than 45%, you think of implanting an ICD in these individuals. If the left ventricular ejection fraction is less than 35%, and obviously you identify this patient's survival is more than 1 year, then the ICD is recommended as being green here. Medications primarily standard heart failure treatments, with the new disease being available at present. So just another minute or so. So primarily the management is heart failure management, and then finally the tachycardia and how to prevent progression. So you can prevent progression by recommending against high endurance exercises and competitive sport. Light exercise and walking is allowed, and then obviously review your ventricular tachycardia management. I just skip those, obviously, but this is an important, I think the important take-home message for arrhythmogenic cardiomyopathy is an entity in a differential diagnosis of ILV and RV dysfunction, and genetic studies helps in diagnosis and management. And is high risk of embolic disease, so always think of anticoagulation in these individuals. Arrhythmogenic cardiomyopathy, think that these patients may need anticoagulation, and they are at high risk for embolic disease. So this is a prime chart which actually goes in circle in patients with arrhythmogenic cardiomyopathy. So accurate diagnosis, you risk stratify that whether these patients need an ICD or not, because it's a progressive disease, and managing inappropriate and appropriate therapies, how to prevent progression by the use of drugs, exercise, advising against in high intensity exercises, genetic cascade, family screening for these individuals. So this is, I think, an important aspect in the management of these individuals with the arrhythmogenic cardiomyopathy. Thank you.
So yeah. Very good presentation. I wish के time का issue ना होता तो McKenna की slide जो बाय शायद VD है वो जरा आप ज़्यादा deliberate करते थे. I just had 2 questions. एक आपने start में ECG दिखाई of a patient, and you said VT also था.
Non-sustained, yes, in a Holter monitor, not on the ECG.
Achha, so it was a non-sustained VT, not कोई specific.
No, not a specific one. No.
Fine. इसी में catheter ablation का कोई role या इस पे कोई आप नजर से कोई चीज गुजरी हो इन patients में?
So prophylactic ablation obviously is not indicated unless obviously the patient is had an ICD. So if the patient is having recurrent ICD shocks, in only in these individuals in arrhythmogenic cardiomyopathy, it is recommended to have ventricular tachycardia ablation. And ventricular tachycardia ablations in ARVCs, you know, primarily they are epicardial VTs. So they are sometimes very difficult to ablate as well. So primarily a trial of drug in these individuals who have arrhythmogenic cardiomyopathy, ICD, and obviously the ICD was implanted because of VT. And if they are having shocks, if the antiarrhythmic doesn't work, then obviously then you go for ventricular tachycardia ablation. But it's a very difficult choice because these are very young individuals. And with long-term amiodarone in these individuals can have side effects, but that's primarily it's that the way you delay the progression of the disease is, and then use the VT as ablation as the last resort primarily.
Yeah, no, I think you have actually pointed out that this can vary from very benign to very malignant issue based on genetics. Now, people like me, I need some education, and I'm sure many like me would need some education, because we do find ECGs with T-wave inversions, epsilon waves there or not, because many of us may even ignore it. So can you educate us as to who are these patients who should be referred to you? Because we see it fairly commonly. It's not an uncommon situation.
Absolutely.
So
I
we
think
need to pick up before things happen.
I completely agree. It is something that is not very uncommonly seen, but under-recognized. So I think the one rule of thumb is that if there is anterior T-wave inversions progressing beyond V3, it cannot be normal. So I think that's the one rule of thumb, that you can have a T-wave inversion in V2, V1 and V2, but if you have T-wave inversions in V3 and beyond V3, then it's unlikely to be due to a normal variant. One more thing which we don't know, unfortunately, is what is the basics in our population. What is a normal variant? That's also something I think we should look at, and hopefully we will have more data on it coming soon. But beyond V3 and V4, if you have V3 and V4, that is something that obviously we need to be careful of. These patients have cardiomyopathies. And second, obviously, if you see an epsilon wave, so yes, epsilon wave sometimes can be overdiagnosed. But if epsilon wave is associated with T-wave inversions, that's where I think they should be referred to the or have further investigation. So if it's in isolation and you don't see T-wave inversions with it, and then obviously it may, because it's usually epsilon wave is usually an indication of a progress or disease which is already progressed. It's usually don't see in the initial phase of the disease. Initial phase of the disease, you see T-wave inversions primarily in arrhythmogenic cardiomyopathy.
Sir, my question is that you said that in a last slide, you mentioned that we're giving the anticoagulations because there is a fibrofatty infiltration or RV dysfunction. So without Qrs score or without any atrial fibrillation in this condition, we're giving the anticoagulation?
No. So I think that's an important distinction to make. So we think about anticoagulation only in those individuals who have arrhythmogenic cardiomyopathy. So ARVC is one entity of arrhythmogenic cardiomyopathy. Now that's what I try to make. So these patients can have atrial fibrillation. And obviously if the disease involved the left side of the heart, that's when you are thinking about embolic phenomena. Then you are thinking about strokes. Then you are thinking about cardioembolic disease. And that's when you consider anticoagulation. So not in ARVC per se, which only right-sided involvement, because then obviously it's all on the right side. You don't think of anticoagulation in that respect. But these individuals, because it's the disease that affects the whole heart, more likely they may have atrial fibrillation as well. So keep a lookout if they are having atrial fibrillation or not. Okay, thank you so much.
Thank you, Dr. Yavar, and thank you all the panelists. Now, our next talk is going to be on arrhythmia and acute coronary syndrome. For that, I will like to welcome Dr. Abdul Moeed. He's one of the youngest and energetic electrophysiologist and author of numerous articles which have been published in local as well as international journals. On the desk of panelists, I would like to request Professor Nawaz Lashari, Head of Department, Civil Hospital Cardiology. I will also request Professor Amir Hamid to come and join us, and Dr. Talha bin Nazir. Thank you.
Bismillah ar-Rahman ar-Rahim. Thank you, Sarim. That was quite a generous introduction of mine.
post-meal session are normally quite hard to handle because of the glucose level are high or all the energy level is down. This is not going to be an hardcore EP. It's going to be the something about the arrhythmia that we usually see in the ER settings. So this is the arrhythmia in ACS. I'm Dr. Mohit. I'm serving as an electrophysiologist in NICVD Satellite Center, Tano Mohammed Khan. Let's begin the session. ACS is one of the leading causes of death in all around the world. More than 500,000 deaths occur in US. Unfortunately, we don't have the exact data of our country, but the data is going to be the more or less similar as that of the US. And majority of the cause of death is the cardiac arrhythmias. Some of the arrhythmias are benign, some of the arrhythmias are malignant. So in the next 20 minutes or so, we'll be discussing that which is the hard thing to handle and which is the easiest thing to handle. So newer techniques should be learned, should be know how to monitor it, should be the new gadgets, that is the monitor, defibrillators and the pacemakers. One thing is that one should be knowing when to use it and how to use it. Post-MI arrhythmias, the common thing that we used to see in the arrhythmias in the ER is the tachycardias and the bradycardias, and the tachycardias is usually divided into two parts. The supraventricular tachycardias and the ventricular tachycardias. And about the bradycardia, there's the sinus bradycardia and the AV blocks. So we will be discussing these entities one by one. In the supraventricular tachycardias, the common tachycardias that we used to see is the sinus tachycardia, atrial ectopics, atrial flutters, atrial fibrillation, and atrial tachycardias. We'll be discussing it shortly. Ventricular tachycardias includes ventricular ectopics, AIVR, ventricular tachycardia, sustained, non-sustained, and monomorphic and polymorphic ventricular tachycardias, and ventricular fibrillation. Before going to the arrhythmias, it's better to know, revise or review our knowledge about the blood circulation of the conducting system. It's been supplied by the RCA and the LAD most commonly. Most of the conducting system above the AV node is supplied by the RCA, the right coronary branch. And the most of the system that is below the AV node is supplied by the left system of the heart. Interestingly, the anterior division of the right anterior fascicle is divided, is supplied by dual, has a dual blood supply, which is from the LAD and the RCA. So it don't get hurt that easily. If you think anatomically, LAD is supplied in most of the conducting system that we have already discussed. RCA, that is already so. If LAD is occluded, mostly the extensive anterior and extensive infarct has to be happened before, or it can conduct before it can damage the conducting system. Our left ventricular failure do occur, high degree AV block occur, apical aneurysm formation, thrombosis, thromboembolic complications. If the right coronary system is involved, right-sided heart failure, bradyarrhythmias is mostly that we see. About the hemodynamic consequences. Hemodynamic consequences that we used to see is about the demand and supply mismatch. Whenever there is an MI, where there is an acute coronary syndrome, there is an occlusion, there is a decreased coronary flow. There is a decreased coronary flow, and along with that, if we have the arrhythmias, there is an increased tachycardia. In the tachycardia, there is an increased demand of oxygen, and along with it, there is a decreased flow of the coronary flow. So there is going to be a lethal combination of this, and this further deteriorate the condition and further result into a vicious cycle. If the atrial contraction is lost in the supraventricular tachycardias or in the supraventricular arrhythmias, there is a loss in the atrial kick that result into a decrease in the cardiac output of 15 to 20%. Something about the ventricular arrhythmias, ventricular ectopics, AIVR, ventricular tachycardias. Let's have a discussion on this one by one. So, what's the obvious finding in this? PVCs.
कौन के साथ बोले कि नहीं आज तक हमने
now the PVCs. The PVCs is the most common arrhythmia that we can usually see in the ERs, and the ER physician and the ER staff should be knowing this. This is not the lethal one, but the most common one that we used to see. 5 could be having 5 to 100% time in the patient with the ACS. Incidence is high in the first 24 to 72 hours. It's not a predictive of high lethal outcome. Usually no treatment is required, but if the PVC burden is high, beta blocker is ideally indicated. It's not lethal, but if the RMT phenomena do occurs, it can result into a lethal outcome. Again, a common presentation that we used to see in ER. What is this? Here we are. Please. It's the accelerated idioventricular rhythm. It's usually called as a reperfusion arrhythmia. We mostly see it when the cybernetic therapies usually occur in the first 24 hours. Rate is up to 100 or less than 100 associated with the reperfusion, can cause loss of AV synchrony. Usually brief is spontaneous, hemodynamically stable, and usually no treatment is required. Result is a good sign. Again, it is a good sign of reperfusion. This one we usually see in the monitors whenever we get a patient of ACS. It's a non-sustained ventricular tachycardia. Recurrent ischemia, coronary reperfusion, not associated with increased risk of VT and VF. If it occurs within the first 24 to 48 hours, it's a predictive. It's not a predictive of long-term mortality. But if it has occurred more than 48 hours or after 2 to 3 fold, it increases the mortality because it is resulting into an increase or extensive damage of the myocardial cells. It usually improves after the beta blockers. This one, again a common one. It's an acute polymorphic VT. The rate is usually more than 200 associated with acute and ongoing ischemia. It's usually non-sustained, but it can degenerate into VF. If we are going to see this, you have to act vigilantly. Usually subside within 24 to 48 hours after MI. If it occurs late, then it means the ischemia is ongoing and the myocardium is still alive. Or the monomorphic VTs. Monomorphic VTs are rare in acute cases, in acute phases, because it usually occurs after the scar formation. It usually occurs after the 48 hours of the acute event. So if it's happening after 48 hours of the event, then it has to be consulted to the EP or do something you have to do for the myocardial perfusion scans to see the ADI is viable or not. If it is not viable, then you have to go for something like ablation or the Icd therapies, or if it is viable, then you have to revascularize it to prevent it further. Pathophysiology about the acute phase of the MI. It's broadly divided into two phases, phase 1 and phase 2. Phase 1 is reversible and phase 2 is more or less irreversible. Phase 1 extends about 2 to 30 minutes. There's a decrease in supply of the oxygen, there's a decrease in supply of the blood to the affected area that resulting into a decrease in ATPs, increase in lactic acid, cell gets swelled, calcium get overloaded, there's a catecholamine release and further deterioration of the myocardial conduction and the myocardial cells. Phase 2 is irreversible. Now, what happens? The arrhythmia can occur in any of the conditions in phase 1 and phase 2. But in phase 1, the arrhythmia is mostly the re-entry one because the cells are viable. And in phase 2, the cells are necrosed and the cells are dying that result into an automaticity in the particular cells that result into the arrhythmia. About the VT management, it's all depend upon the clinical condition of the patient. If the patient is stable or not. If the patient is stable, pharmacological therapy can be used. If the patient is unstable, then and you have to go for the defibrillation or different kind of therapy that we are going to discuss shortly. About the ventricular tachycardias. If the ventricular tachycardia is the patient is having a ventricular sustained ventricular tachycardia, what does sustained ventricular means? If it's more than 60 seconds. More than 30 seconds, and he's having a hemodynamic collapse. He's having a shortness of breath, acute pulmonary edema, peripheral sweating, cold and clammy skin. Then we don't have to go for the pharmacological options. We just have to go for an unsynchronized cardioversion, starting off with 200, then 300, then 600. Aggressive reversible cause has to be aggressively. The reversible cause has to be treated. That includes PCIs and if the patient is having a sustained monomorphic VT and there is no hemodynamic compromise, then only then we can go for the pharmacological therapies for the correction of the hemodynamic status. Starting off with the Myodon, that is the available option that we have mostly all around Pakistan. We start off with 150 milligrams over the period of 10 minutes. Can repeat it for 150 milligrams over the 15 to 20 minutes later. Then we have to go for infusion for next 24 hours, like 1 milligram per kg, 1 milligram per minute for 6 hours, and then 0.5 milligram per minute for next 18 hours. If you're going for cardioversion, then it's better to have for brief anesthesia episodes. Otherwise, it's going to be a painful event. About the ventricular fibrillation. If the patient is having a ventricular fibrillation, there is no need to think about the medical management of this patient. Just go for the unsynchronized cardioversion, starting again of the 200, 300, and 360. If the patient is having a refractory or unresponsive to the therapy, then only then we can give the Myodon. Procainamide is also an option for it need a long-term acting, but this is not easily or commonly available in our settings. To treat the underlying cause is the most prime thing. Arrhythmia is just the manifestation of the underlying. Arrhythmia is only the manifestation of the underlying pathology. Hypoxia, hypotension, acid-bed disturbance, and electrolyte disturbance. These are the common entities that usually happen when there is a myocardial damage. So we have to deal it accordingly before going for the revascularization. Ultimately, the underlying cause has to be treated and has to be treated promptly. The revascularization under ischemic, either going for a pharmacological revascularization or the PCIs, that are the options. And the defibrillator, if the patient is having arrhythmia, then defibrillator should be along the bedside of the patient. Now the other topic about the bradyarrhythmias. Common bradyarrhythmias is the sinus bradycardia that we commonly see in the patient of the MI or the ACS that we find it in the ERs. Mostly is the inferior and the posterior infarct because the upper half of the AV node is supplied by the right coronary arteries. Increased vagal tone do produce sinus bradycardia. Sometimes it is beneficial because the decreases the myocardial oxygen demand, as there's already a demand and supply mismatch in the MI. If no hypertension is observed, only the observation is required. If there is a bradycardia and the symptomatic, we can use atropine firstly. We can up to the 3 milligrams of dose. If the patient is still bradycardic after the atropine and the heart rate is 40 and patient is symptomatic, temporary pacemaker should be the option and should be used promptly. Atrioventricular blocks and the internodal blocks. Whenever the MI and the bradyarrhythmias is considered in the MI, block can occur at any level. That is the AV node, bundle of his, below the his, right bundle branch block, left bundle branch block, or the hemi blocks. Anything can happen. We have already discussed if it's a busy slide, it's not coming up to the visualization. Internodal block, if the internodal block or above the block, right coronary artery is involved. If the infranodal block or extensive anterior and MI is mostly the anterior periphery of the left system is involved. AV block in acute MI, almost always in AV node. If right inferior wall MI is involved, this almost always the AV node. High grade AV block, 20% of the inferior wall MI, and in that 60% went into the complete heart block. But the recovery is good, and it's usually recover after a brief period of 5 to 10 days if the patient develop a complete heart block even after the inferior wall MI. AV block in acute MI, acute anterior wall MI. If the AV block occurs in acute anterior wall MI, it's always having an extensive MI of septum, his bundle, and his bundle, and all of the septum. Setting is resulting into a severe LV dysfunction, slow and unreliable ventricular arrhythmias of 30 to 40 minutes. Now, when to go for temporary pacemaker? If the patient develop asystole, of course, we have to go for temporary pacemaker. Symptomatic bradycardia, any bradycardia that result into the symptoms of hypoperfusion, need to go for the temporary pacemaker, or it's not responding to the atropine. Bifascicular block going into with alternating bundle branch block with the first degree AV block need a temporary pacemaker. Morbid type 2 and complete heart block. Even before going for the PCIs, it's better to go for the temporary pacemaker to get a proper result. Recommendation for permanent pacemaker, persistent morbid type 2 or the complete heart block, transient high degree AV block with bundle branch block, or the symptomatic block at any levels. If the patient is having a block or having a TPM, mostly it is recommended to wait for 5 or maximum to 10 days to see the reversibility of the defect. If the patient get reversed, if the patient get a normal sinus rhythm without a transient or without a residual defect, it's better to go for temporary pacemaker. Sinus tachycardia, it's again a common entity that we used to see along with ischemia. 1 to 3% of the patient common with anterior augmentation with sympathetic activity. Patient is in anxiety, pain, ischemia. All this kind of element can result into sinus tachycardia, but at the longer run, this is going to worsen the myocardial entity because it's going to increase the metabolic demand of the patient. And again, there is a device and there's a blood demand and supply mismatch. Treatment is go for the bradycardia and save the muscle. This one, this is the atrial mature beats. Mostly it happens with when the right system of the conductor system is involved, coronary system is involved. No treatment is required and mostly get resolved once the ischemia settle down. What is this? This is the atrial fibrillation. Atrial fibrillation often occurs in the first 24 hours. Usually transient, may recur, incidence increase with age, large anterior wall MI, congestive heart failure, high degree AV block, atrial infarction, pericarditis. In inferior wall MI due to the proximity of the right coronary occlusion involving the sinus nodal artery, and the systemic embolism is a risk. What we can see in this, atrial flutter. Incidence of atrial flutter is less common in our society, is around 1 to 3%. Usually 1 or 2:1 block occur. It responds well with the DC cardioversion. Do we need to treat it? We don't need to treat it. We don't need to treat all the dancing waves in the ECG. It's just now this sustained atrial flutter with hemodynamic compromise. Initially with the ischemia, in the setting of the ischemia, it's better to go for the synchronized cardioversion. 200 milligram joule for atrial fibrillation and 50 joules would be better for the atrial flutters. If non-responding, then IV Madrone, digoxin, and the beta blockers could be used, because this is going to increase the myocardial demand and of the heart, and the heart coronary is already compromised, so it's going to be a demand and supply mismatch. It's going to be further deteriorating the myocardium of the heart. To conclude, any form of arrhythmia can be complicated, but the area physician should be knowing when to operate and what to consider to be a lethal and what to consider to be a benign. Always search for the appropriate underlying cause and treat it promptly. Thank you. Yes. I hope I concluded in time.
Any question answers? Okay, I will request the panelists to please be seated. Okay, there we have.
Sir, my question it is that I want to know one of the cause of bradycardia, because we know that the hypothyroidism or raised intracranial pressure, these are the common causes while we see in our wards, when we go to visit the patient. But the cause I have seen, the cholestasis, it is also one of the cause of bradycardia. So what is the cause for it and how we can treat that case?
Coronary bradycardia. Yeah, I couldn't get the question. Intracranial pressure do increase the result into a bradycardia, and hypothyroidism do cause. But the coronary stasis, I couldn't get it. Raised intracranial pressure do result into bradycardia and hypothyroidism do, but coronary stasis I couldn't get it.
Sir, I have studied in the Oxford book, which is of cardiology. It is written the cause cholestasis, it is also one of the cause of bradycardia. I have-
Cholelithiasis.
Yes. I have seen-
Cholelithiasis result into a pain, and pain result into a vagal tone, increased vagal tone. Vagal tone can result into a bradycardia.
So, but the cause was not written, but I have seen one patient. So that's why I want to know that what
Anything
is
that
the
result
cause
into
behind it and how we should treat that case.
anything that result into an increased vagal tone can result into a bradycardia. So in cholelithiasis, the pain do has an entity that result into an increased vagal tone. Okay. It can result like this.
No, I don't. I wanted to ask, what about the flutter? You have shown flutter with ischemia. What do you think is the mechanism for that? And how would you, what would be different in the treatment? But generally, what we were classically taught was the flutters generally come from the right side, right atrium, and ischemia is affecting the left atrium.
Mostly the right side system of the right coronary system of the heart can result into this, but flutter is less common. It's only 1 to 3%. It can happen like this. But if there is, you have to correct it like cardioversion.
Nice presentation related to the arrhythmia with acute coronary syndrome. So I would like to aid on this other than question. Okay, when there is an inferior valve, there is always be prepared for the bradyarrhythmias. When there is the anterior valve MI, so you be prepared for the tachyarrhythmias and the LV dysfunction shock. So generally in the tachyarrhythmias, be careful when you are treating the sinus tachycardia, because sometimes when you are giving the beta blocker to sinus tachycardia patient, suddenly, although they have baseline LV dysfunction, the patient develop the cardiogenic shock and then die. So these simple tips the students should keep in mind when they're dealing the type of arrhythmia, either brady or tachyarrhythmias. So be very gentle when you're playing with the piano and so like the arrhythmias.
Thank you so much.
Thank you, Dr. Mohit. Now I will request Dr. Sajid Sheikh to come and give his speech on management of VT storm. He's assistant professor at Icd Secondary Institute. Thank you.
Assalamu alaikum, everyone. Thank you for giving me chance here to present a talk. I am Dr. Sajid Ali, working as an assistant professor at Icd Secondary. The last presentation of session is a VT storm. I would try to complete in due time. So basically, VT storm is a nightmare for the cardiologists and also for the cardiac electrophysiologists, as a medical emergency characterized by 3 or more episodes of wide complex or tachycardia or VT in a 24 hours period. Without ICD and with ICD is 3 or more episodes of ICD therapies, including anti-tachycardia pacing or shocks within 24 hours. So incidence is about 20% in ICD recipients. The incidence of electrical storms is lower when ICDs were placed for the primary as against the secondary preventions. And the data on the prognostic significance of electrical storms strongly suggests that these patients have a poor outcome. In the MEDED2 service study, patients with electrical storms had a 7.4-fold higher risk of death than patients without electrical storm. This is very much important slide, and everyone should know what triggers the electrical storm. And by correcting these 5-6 diagnoses, very great prognosis. The topmost is the acute myocardial ischemia. Number second is new or worsened heart failure. Third is the electrolyte disturbances, especially hypokalemia and hypomagnesemia. Drug toxicity includes and QT prolongation. Very important. Drug toxicity, electrolyte imbalances are the underlying congenital as well described long QT. So mainly clinical presentation this program. Ventricular arrhythmia presenting in electrical storm. Most common is monomorphic VTs presenting in 86%. Then primary VF secondary to acute MI 1 to 21%. Mixed VT-VF 3 to 14%. And contributing 2%. The differential diagnosis, any type wide complex in sensing and lead fracture. So this list describes the causes of the wide complex QRS, differential diagnosis of wide QRS complex trachea. Number one is the VT, and any type of SVT with pre-existing bundle branch block or rate-related functional bundle branch blocks such as sinus take, atrial flutter, AVNRT or AVRT, or any SVT which occurs in a patient receiving an antiarrhythmic drug, primarily class 1A or 1C, in a patient with severe hyperkalemia. Any SVT with antegrade conduction by an accessory pathway, such as WW, such as sinus take, atrial flutter, or AVRT, and electronic pacemakers in certain specific settings. In patients with acute and ongoing episode of electrical storm, incidence with initial treatment is based on the hemodynamical stability. So this algorithm will describe how we should approach when the patient present with electrical storm. We should stratify either it's the tolerated VT, which is said to be a low risk, and we will add antiarrhythmic drugs. If it's unstable VT, we will label as a high risk, and immediately after initial management, we will admit to the ICU. We will look for the comorbidities such as poor LVF, chronic kidney disease, pulmonary disease, or Icd reprogramming. After the first initial management, the main drugs were started, beta blockers, amiodarone, and other. And on the base of the pain SD score, which which differentiate patients into two groups, low risk and high risk. And this score describes the patients who are low risk for favorable results on the catheter ablation of the VT. Now, this is the 5 points of the pain SD risk score. Pulmonary disease, chronic obstructive, and we have a 5 score with age more than 60 years, ischemic cardiomyopathy, NYHA class 3, 4, EF of less than 25% in strong VT, and diabetes mellitus. If a patient is a low risk, they shown a better results with catheter ablation of the VT. If the high risk, with a score of more than 50, they shown a poor results with catheter ablation. So majority of the VT storm patient presents with monomorphic VT, and monomorphic VT occurs when the ventricular activation sequence is the same without any variation in the QRS complexes. It is due to electrical wavefront re-entry around a scar, and monomorphic VT is due to does not require active ischemia as a trigger. It's uncommon in acute ischemia. This ECG shows a monomorphic VT with RBB morphology. And one such patient present in ER, we should apply an ACLS algorithm if patient usually hemodynamically unstable. After ACLS algorithm, we will start beta blockers, non-selective preferred such as propranolol, IV amiodarone, and we consider sedation, anesthesia, and involve the EP people and treat acute failure if present. A patient present with hemodynamically stable, we have two options. Either I try to electrical cardioverter or IV procainamide, or second line is IV amiodarone or lignocaine. This ECG is demonstrate the polymorphic VT. The main causes of polymorphic VT is divided into based on the QT interval. So long QT is torsade, which is maybe is due to congenital, or it may be due to acquired, which is pause dependent, and most common is due to secondary to drugs or hypokalemia. And the most common acquired long QT in ischemic presentation is very rare. While patients with ischemia who present with a polymorphic VT usually have a normal QT, and the focus should be on the treatment of the ischemia. This is algorithm shows the treatment of the polymorphic VT. Start with the same ACLS protocol if patients are hemodynamically unstable. Then we have option of beta blockers, propranolol, IV, amiodarone, sedation. And with a normal QT, acute ischemia is the major, most common cause, and we should initiate ACS therapy as early as possible and involve intervention people. IV amiodarone, and there is a role of IV lidocaine. If there's no acute ischemia, then we will treat with IV amiodarone and treat acute heart failure if present. If patient with a prolonged QT torsade, we have to remove or correct the precipitant for that prolonged QT. IV magnesium is an option. Overdrive pacing, especially atrial, is preferred, and beta blocker. This is the most lethal rhythm, which is presenting in electrical storm, ventricular fibrillation. With mortality rates between 85 and 97%, ischemia is the primary mechanism of VF. Patients who have a normal heart may develop a VF, but it's triggered by closely coupled monomorphic PVCs. PVC is the trigger and often originates in the distal percutaneous system. RFA ablation in these sites can eliminate future VF episodes. A few points regarding pharmacolotherapy. Two main drugs used in the VT storm is one is amiodarone and other is propranolol. Amiodarone is a very superior efficacy for terminating most ventricular arrhythmias, while in the terms of beta blocker, many studies shows, many small randomized study, not a large randomized trial, but small studies show oral propranolol is recommended and very beneficial in comparison to metoprolol. So propranolol consistently decreases the incidence of fatal VF, although several beta blockers decrease susceptibility. Most studies focus on the propranolol. In canine study, beta blockers increase the fibrillation threshold 6 times. And because of lipophilic nature of propranolol, it enables active penetration in the CNS and blockage of the central and perijunctional receptors in addition to peripheral beta receptors. This article published in Circulation, they target the sympathetic blockage versus advanced ACLS life support. So total of 49 patients, and they divide into two arms. 27 in those patients where they focus the sympathetic blockage, and 22 patients in those patients they just continued ACLS. At 1 week, after 1 week, the strategy in which sympathetic blockage was applied, 21 survived, and after 1 year, 18 survived. On the other end, on those where there's only ACLS continued, only 4 survived at 1 week and only 1 survived at 1 year. So amiodarone is widely used as a treatment of electrical storm. It rapidly, after rapid IV administration, it blocks fast sodium channels and very few negative inotropic effects. Moreover, incidence of torsade is low in such patients, despite the potential for significant prolongation of the QT. Amiodarone has resolved electrical storm with convergence rates of approximately 60%. Regarding side effects of the amiodarone, the common are the nausea, vomiting, weight loss, bluish gray discoloration, hypo or hyperthyroidism, liver disease, hypersensitivity. These are common and these are reversible upon discontinuation of the amiodarone most of the time. With long-term use, most dangerous complication is pulmonary fibrosis, which leads to the riot of shortness of breath and effects on the heart is sinus brady or arrhythmias. Very rare optic neuropathy, peripheral neuropathy were observed. Beside amiodarone, there is a role of lignocaine, especially in acute ischemic VT storm. For patients who have insistent VT and of myocardial ischemia has failed to be a contributing factor, urgent coronary arrest should be pursued. This chart shows a dosage of different drugs used in VT storm. I will discuss 2, propranolol and amiodarone. Unfortunately, we have no IV available propranolol in Pakistan. What we use is oral 10 to 40 milligram of mouth 3 to 4 times a day. And on amiodarone, we will give bolus of 150 milligram IV or 10 minutes, and will continue as a long term as 800 milligram per oral twice a day for next few days. Other option, which is in a study or in multiple studies, shows promising results is a catheter ablation. The catheter ablation of ventricular tachyarrhythmia is an important and effective therapy for electrical storm, especially those patients who are unresponsive to amiodarone and beta blocker, or despite of these medication has continue in incessant VT. The ablation of these conditions is a complex procedure with significant risk, and catheter ablation may also be considered in patients whose ventricular tachyarrhythmias are not controlled with medical therapy. In a meta-analysis of 471 patients with electrical storm compiled from 39 publications, there was a high initial success rate for ablation for all ventricular arrhythmias, 72%, along with a low procedure mortality of 0.6%. Catheter ablation should not be considered as a bailout therapy, but a valuable option in all patients presenting with electrical storm related to structural heart disease. Radiofrequency catheter ablation is effective not only in the acute management, but also, but it leads to the control of ventricular arrhythmia. 90% of patients who have long-term follow-up, improving either VT or ES-free survival. In a recently published Vanish trial, 34% relative risk reductions of electrical storms were observed in patients treating with catheter ablation as compared to the escalation of antiarrhythmic therapy, especially of amiodarone. Other general therapies include thoracic epidural anesthesia or general anesthesia, insertion of intra-aortic balloon pump or temporary ventricular assist device. In appropriate patient, these devices may help stabilize patients with refractory recurrent VT. Regarding neuroaxial modulation, sympathetic hyperactivity plays a critical role in the onset and maintenance of ventricular arrhythmias, and modulation of the cardiac sympathetic denervation may be a valuable option. Surgical catheter cardiac sympathetic denervation usually performed on the left side through a video-assisted thoracoscopic approach. It is shown to suppress significant decrease arrhythmia burden in 56% of patients refractory to antiarrhythmic therapy and catheter ablation. Electrical storm in ICD patients, usually patients requires intravenous analgesic and sedative, and interrogation of device should be done as early as possible to distinguish appropriate from inappropriate therapy. And shocks without evidence of arrhythmia indicates device malfunction, such as sensing of electrical noise or fractured lead. In these cases, device should be immediately switched off. And there's also maybe a rapid SVT IFib causes of the inappropriate shock, which should be managed with the ICD programming and placing a magnet over ICD. So shocks from ICD have adverse effects among patients with heart failure who received ICD for primary prevention. Those who receive shocks from arrhythmia have higher mortality than do patients who receive no shocks. Not only are the shocks painful, but also distressing to patients. Antiarrhythmic medication can reduce the frequency of ICD shocks. In 2 studies, sotalol reduced the incidence of recurrent sustained VT and lowered the risk of death in ICD shock. In a multi-center optimal pharmacologic therapy in cardioverter defibrillator patients trial, 69 patients with ICD was assigned to receive beta blocker alone, amiodarone plus beta blocker and sotalol. At 1 year follow-up evaluation, amiodarone plus beta blocker had a most effectively reduced the number of shocks. In programming ICD to develop anti-tachycardia pacing for fast VT can reduce the need for shocks. Rapid pacing often terminates VT, and in pain-free treatment 2 trial, anti-tachycardia pacing was very effectively treated fast VTs. This resulted in 70% fewer shock than did normal ICD programming and improved the patient's quality of life. This algorithm shows how we manage the patients with VT storm with ICD. First, we will assure that if there's a pseudo shock which had to be fended, we should only reassure the patient. If the shocks were inappropriate, secondly to the AF or SVT, we will add beta blocker, calcium channel blocker, and apply a magnet, or activate SVT discriminated in ICD programming, and we will think for ablation of SVTs. And inappropriate shocks, secondly to lead oversensing, ICD reprogramming should be done. And if the shocks were appropriate, evaluate and treat the reversible cause, electrolytes and ischemia, antiarrhythmic drugs, sedation, optimize anti-tachycardia pacing, and for refractory VT and VF, general anesthesia and IAPB and ablation should be considered. But prognosis in electrical storm is generally associated with poor outcomes, with most studies reporting an association between electrical storm and cardiovascular mortality. In the AVID trial, electrical storm was significant independent risk factor for cardiac non-sudden death, which occurs most frequently within 3 months. And MEDIT-2 trials found that patients with electrical storm is 7-fold higher risk of death when compared with those without electric storm, with a 17-fold increased risk of death within first 3 months after storm onset. This ends, and thank you. Any question?
So I have a question or two. One is, do you have any experience in using 2 or 3 antiarrhythmic drugs? And what are your thoughts on sedation of the patient? What level of sedation do you go to as an initial therapy when the patient comes in?
Usually a patient not responding to higher doses of antiarrhythmic, we should ideally switch patients to a complete sedation and paralyzing and keep on ventilator to.
No, sure, because these patients are serious patients. If they go on when they may not come off. So short of that, that's what I was asking. Conscious sedation, short of that, how much would you, and what is your protocol in your experience? Because it helps. You have to knock them out, only then will you be able to take off the stress of the arrhythmia. And the other question would be the antiarrhythmic drugs. What are the, if you've used 2 drugs or 3 drugs, what are the drugs that you prefer? I'm not talking about propranolol, amiodarone.
We usually use amiodarone. Then we can add sotalol. We have few patients who are responding amiodarone plus sotalol. And
what about lidocaine?
Lidocaine has a better results in terms of ischemic etiology. Other than ischemia, is a very poor results. Some patients responding to mexiletine, which is orally available here, but not the promising in my experience.
Okay. Now we've used a lot of lidocaine and amiodarone together. They seem to work, and then we shift them to mexiletine, which is not available. It's smuggled, but still we have it. And naturally they're structurally damaged, so we don't use flecainide. But there's a paper from my center where I had worked, the fellow had worked with me, he was my senior fellow, he'd written a case report on using 3. So they'd used propafenone on top of this. Okay. And that's shown that it was a very difficult case and they had brought them out. So what about using intra-aortic balloon
Other
pump?
problem is facing in our Pakistan is non-availability of the other drugs. We have only sotalol.
I understand that. So, and what about intra-aortic balloon pump?
Sorry?
What about using intra-aortic balloon pump counter pulsation at any point in time?
This IABP is also favoring patients on those who are treated acute ischemia, and they respond on those patients. And beside the ischemia,
but it's also reducing afterload, clearing. It has other mechanisms also. But in your experience, you don't use.
No.
Sure.
We will avoid placing in ICD in a VT strong patient. We will first study to stabilize the VT, because it can lead to the dangerous outcome with multiple shocks. We will first stabilize the VT. Then after say 3-4 months VT free episode, we can improve it. Yeah. Usually 2 drugs are made. Yes.
I just have a comment, and I would support Amir's notion of adding. So most of the ventricular storm that we see is with cardiology patients, acute MI. They've done everything that they could do to revasc, and then now it falls into our lap, right? So the data that we have out there is not as robust for ventricular storm. And the type of drugs that are available in Pakistan is limited. So in my experience that I've used in last 5 years at Tabahart, we have to be very aggressive when we're treating ventricular storm, post-MI, ACS. They have done, the interventionists have done everything. So lidocaine, amiodarone combination together, it works miracle. The cardiologists fear that adding beta blocker is going to make the cardiogenic shock patient may go hypotensive, which is actually not the cause. The reason to add beta blockers is to treat cardiogenic shock. It is to reduce the sympathetic activation. So propranolol works really, really well. Even if we give it oral, that works well. Sedation, relaxation has to be done. We have to apply all what we have. I'm also very pro of IABP, especially with the ACS and VTBF. The interventionists are not very fond of putting IABP with the data. Cardiogenic shock में इसका कोई role नहीं है. All of that, short of LVAD, what we have is IABP, and it will reduce it is not to improve the shock, it is to reduce the recurrence of arrhythmia. So yes, combination of amiodarone, lidocaine, propranolol, IABP is what we do just right off the bat and give the best 48 hours to the patient.
So thank you for bringing this topic up here. जो हमारा experience generally है ना, वो is similar to what Amir and Faria are saying. The role of lidocaine usually is thought to be only in acute coronary syndromes, polymorphic VT, उस तरह के situation में. But we've also found that even in stable repetitive monomorphic, I shouldn't use the word repetitive, but recurrent monomorphic VTs, there is a role of lidocaine because it may suppress in addition to the sodium channel issues, it also so it's supposed to have some automaticity. Okay. Which may prevent the PVCs that are triggering the arrhythmia from occurring. So lidocaine may have a very useful role. Of course, the problem with lidocaine use in our hospitals is that you can get lidocaine toxicity, especially if the patient is intubated or heavily sedated. आपको पता नहीं लगता कि toxic हो गया.
Usually within 24 hours, they develop symptoms. Afterload.
And therefore may alter the structure of the arrhythmia circuit. Thirdly, personally, I think one of the first things I do, and I tell everybody else to do, is if you have a patient who's come in with a ventricular storm, make sure they're well sedated. क्योंकि ये बड़ी एक चीज तो वैसे ही lethal चीज है, उसके साथ उस बेचारे को बहुत तकलीफ हो रही होती है, बेचारी को they're in great pain and other things. Moreover, once they are nicely sedated, they usually, that also reduces their sympathetic drive. That leaves one of the things that I often will do. I don't know, I don't have any data to suggest that it helps, but we find it useful, is to use atrial pacing to speed things up and prevent PVCs from occurring. So sometimes if you speed up the heart rate used from the atrium, ventricles se thoda dar lagta hai because it may
develop into the VT.
weather it out. Usually it is, these events are not all related to ischemia. Most of these patients that I've seen are patients who are chronic heart failure. Their heart failure becomes worse. Ventricle gets dilated more, sympathetic drive kicks in. And if you can sort of break the cycle, they can survive. But often, in fact, usually not for very long. They go home, they come back. But you do what you have to do.
the same protocols for extubating them. वो अगले दिन जाते हैं CTR team आगे उनको
बिल्कुल
so you when you once they are intubated have them intubated for a longer period of time
हाँ पूरी sympathetic blockage हो जाए और वो
change their beta blocker to propranolol because beta 1 beta 2 upgrade down regulate हो जाते हैं
बस ablation
उसका खाने का उसका वाइटल का अगर वो पुश में है वो प्रोटोकॉल चेंज कर दे he's on the monitor do not check vital rate गाना फिर उठ के बैठ जाएगा and so these are very important minor things but they make a huge difference.
Just one more thing, VT ablation was brought up by the audience and it was presented. It is very unfortunate here that no matter how much we want to do VT ablation, I will never want to do VT ablation in this setting. Despite complex ablators, we don't have support and I don't know what the other operators feel. We should not embark on doing primary VT ablation in electrical storm in our situations where we don't have LVADs and support teams to. So VT ablation looks very fancy from the outside. Unfortunately, in Pakistan, it's not. It should be a no-go area.
It's not. So I trained with John Savage, investigator of Flemish trial, and he used to get frustrated at times and he used to say, "I wish my catheter had a needle at the tip of the catheter." And actually, they're working on a needle catheter which will send in a needle and ablate deeply. A lot of times you are on top of the substrate, but actually you're away from the exit point, and therefore it's very frustrating. So definitely need a lot of experience if you are ever going to embark on that.
I think excellent talk, but I have one query about the Brady-induced VTs. What do you do like that with these patients? What are your experience about this?
Brady-induced straight away is past TPM. And because they pass dependent, they what happen QT will prolong and can induce polymorphic VT. So as early as you pass TPM and pacemaker.
So does any criteria on which you say this related to Brady induced VT?
The ECG is very obvious, which shows short long coupling with Brady induced PVCs, but that lead to the polymorphic VT. Thank you.
May I, before we conclude, we were just having a chat about stellate ganglion blockade. I think I've discussed this with Dr. Talha as well. I wonder if Dr. Sajid or Dr. Amir or any of the panel have any experience with it or whether they want to talk about it.
I think data out there to suggest that because this is a situation where whatever you do, and even if it makes a little impact, it's going to have huge repercussions. So this is some place where you can think of that. But you need to have someone who can do it. Your center should be.
I'm glad actually this came up. Interestingly, there have been a lot of papers suggesting that stellate ganglion blockade has been attempted from an endovascular approach from the left side. But if we study, interestingly, the confluence of these stellate ganglions, it drains into the retroaortic plexus, which is on the right side. There are definitely trials going on in Europe right now, which I am aware of. They've got quite promising results, although obviously we need the data to come out and have a look at it. But if doing a point ablation in the retroaortic plexus, because the confluence is there, if you stop the output, that can definitely play a role in terminating or help terminating these particular VT storms. But again, I think I would agree with Dr. Faria and Sir Amir that in today's situation, as I think the logistics, because it's not only a one-man show, it's always a team effort. It needs a holistic approach. It doesn't only require a procedure to be done. It takes even things where things need to be managed after the procedure, before the procedure, during the procedure. All of these things, once the environment is conducive, which I think it will take time. It will take time. I just wish earlier, the better, but the fact is it will take time. And this stellate ganglion approach, I think it will be probably very promising as soon as it comes out. but obviously data needs to be seen in this.
And Vanish, if you go into Vanish, Vanish did not give you mortality benefit, although this is a substrate where you don't look for that. I feel that the medical therapy that they gave parallel could have been improved.
Okay, thank you for nice input.
Thank you, Dr. Sajid. Thank you all the panelists, speakers and guests. And now in the last, I will request Professor Azam Shafqat. He is the head of Department of Electrophysiology and ICVD to come and have a few words with us.
Thank you very much for asking me to present this vote of thanks. This has been another very stellar performance by the organizers. So I would especially like to thank Dr. Ghazala, Dr. Faria, and Dr. Yawar, all of whom were active participants in the organization of this. Along with this, I would like to thank GETS Pharmaceuticals, who helped bring this whole scene together. We've had multiple people who have contributed to this program, not the least of all the panelists, most of whom are very senior cardiologists and left their busy practices to come and participate and encourage both our audience and our speakers. So on behalf of the Pakistan Heart Rhythm Society and ICVD, I would like to thank both the organizers and the sponsors who catered to this event. So once again, thank you very much. I would like to make two further announcements. One is that we have a very active program tomorrow, especially for fellows and electrophysiologists, and I hope we will have a good solid attendance for that. The second is that there is a meeting of the Pakistan Heart Rhythm Society annual general meeting, and I would like all the members and associate members, which include the fellows, to please participate in it. It's at the Morgra boardroom right now. So once again, all of you, thank you very much for being here and giving us a wonderful day of arrhythmias and electrophysiology in the setting of cardiology. Thank you very much.